Good morning and welcome back. I'm Ralph DeVito, President and CEO of the American Brain Tumor Association. Today is a somber day, so before we go into day 2 of our program, just want to reflect and remember that it was 20 years ago this morning that America was attacked on September 11th, 2001. Planes were flown into the Twin Towers, to the Pentagon, would have been another target, probably the White House, if not for the heroic bravery of passengers and flight crew that brought that plane down in a field in Pennsylvania, outside of Shanksville, I believe. So we pause today. We think about the 2,944 people that lost their lives, their families, their friends, their colleagues, their communities, the huge impact. I can remember vividly where I was on that day, and I'm sure many of you also can remember. I've never seen the country rally together in such a way after that. It was a remarkable day. It was a somber day. There was bravery and heroic actions by so many. So let's take a moment. Let's pause in a moment of silence. Thank you very much. I greatly appreciate that. Day 1 of the ABTA's National Conference was absolutely wonderful. Special thanks to Doctors Hervey-Jumper and Gingras for their working with our staff to assemble a panel of experts who gave their time to deliver in a very effective way to those of you that were there. And we had about 1,000 people pre-register, so most of the people will be getting this pre-recorded. So we are just really thrilled with the caliber of yesterday's program. And today will be, I promise you, absolutely spectacular also. And I do want to say this: we are committed to making this the largest program of its type in the brain tumor community, even better. So you'll be receiving a survey. Please take a moment, think about how this conference could be even more effective for you, for others that you know, and I promise you we will listen and consider it as we develop next year's program. And as I said yesterday, we are planning to have this program in person in Chicago, and we'll also make it available virtually. Before we introduce 2 very special people, I want to take a moment to remind you of 2 great services that the American Brain Tumor Association offers to patients and caregivers, to family and friends. First, we have trained staff that provide service via phone or email on our care line. And Emily just provided that phone number. Go to our website, abta.org, and you can get that number. And the other is something that's more personalized from peer to peer. We train hundreds of people who are available to serve as mentors, confidants, guides, shared experiences. So please take advantage of that by contacting us. So now it's my pleasure to introduce 2 folks that have become friends. They were the first 2 executive directors of the American Brain Tumor Association, and they continue to be active supporters. They are serving as honorary board members. Don and Gail Siegel. Gail?
Well, thank you, Ralph, and good morning, all. As you know, ABTA was founded by Susan Kramer in 1973, and you met her yesterday afternoon. Susan was the association's birth mother, and Donald and I were ABTA's adoptive parents. We know too well the loneliness caused by a brain tumor diagnosis. Our son was diagnosed with an inoperable tumor in 1975 when he was 7.5 years old. Our goal is to ease that loneliness and accompanying fear by instituting a wide range of patient service programs. We also hope to realize a future where brain tumors are just another treatable disease by funding all manner of research projects and encouraging the best and the brightest to become involved in that research. In the intervening years since 1973, our programs have been expanded and enlarged, including the conference you are attending today. The first conference was held in 1993 and commemorated the 20th anniversary of our founding. Since then, we have held dozens of conferences, local, regional, national. We have funded hundreds of researchers and research projects. And most importantly, we have had a seat at the table where brain tumors were the topic in government, professional, and patient advocacy organizations. ABTA has been here to assist you and to amplify your voice in many ways. We hope that you continue to let us know your concerns and needs, and how we might increase our efforts on your behalf. You are the reason for our existence. Fingers crossed that we will be able to meet you in person next year when this horrible pandemic is finally under control. Until then, be cautious, be well, and use this virtual conference to your advantage. And by the way, our son is now a 46-year survivor.
You got to get up.
Okay.
I just knocked my wife out of the seat so I can get in front of you. Thank you for the kind remarks, Ralph, and good morning, everyone. We hope that you found the program yesterday to be meaningful, productive, and helpful. We expect today to be the same. As a veteran of over 25 years of these meetings, I can appreciate the work that has to go into making it successful, and this year even more. So I thank Ralph and Nicole, Emily, and the staff of ABTA for putting us all together during these challenging times. And by the way, thank you for all the work that you've been doing and you do all year round. We started raising funds. Let me just reflect back on these 25 years. I always have left these meetings a little more optimistic and certainly energized. And we hope that those of you attending will feel the same way. We started raising funds during the mid-1970s, and we realized the need to wisely utilize those funds. We asked one of our medical advisors at the time what he would suggest. His advice, quote, "Give the money to the best and the brightest of young researchers," end of quote. We did that, and we still do that. We give the money to encourage researchers at a time when they need to be encouraged to get into this field, a very challenging field for young researchers, of course. And it has worked remarkably well. So many of those young researchers have stayed in the field and devote their professional lives to finding the cause and the best treatments for brain tumors. Another important and successful utilization of our funding is the Central Brain Tumor Registry of the United States. Over 25 years ago, ABTA set up a committee to study the feasibility of a national registry of brain tumors. Up until that time, there was just a scattering of states that were gathering this information. So it was important to be able to do this on a national basis. And that led to the formation of CB Trust, a separate organization that gathers and disseminates brain tumor incidence and mortality data to the professional and lay community, mainly through the efforts of a former ABTA board member, Carol Kruchko, CB Trust is now internationally known and respected. You can get more information about CB Trust at cbtrust.org, and I encourage you to do that. So as you can see, ABTA has been at the forefront of utilizing the financial support of our generous donors to advance research and build a better future for patients and their families.
Thank you so much, Don and Gail, for your contributions to the ABTA and for sharing with us how our resources and funds have evolved over time. I would like to take a few minutes to acknowledge those who have helped put together this wonderful conference. Thank you to all of our speakers whom you heard from yesterday and will hear from again today. Thank you to our sponsors and funders for their support of this conference. I especially want to thank our titanium sponsor, Northwest Biotherapeutics, and our platinum sponsors, SDB Oncology and Novocure, for their support. And last but certainly not least, I would like to thank our conference planning co-chairs, Dr. Sean Hervey-Jumper and Dr. Avanthia Galanis, who have put together an incredible program, bringing together national experts from medical institutions to share with you today. For those of you who are joining us for the first time today, Dr. Sean Hervey-Jumper is an associate professor of the Department of Neurological Surgery, director of the Glial Tumor Neuroplasticity Research Laboratory, and co-director of the Sherry Sobrato Brisson Brain Cancer Survivorship Program at the University of California, San Francisco. Dr. Avanthia Galanis is a professor of oncology and the Sandra J. Schultz Professor of Novel Therapeutics at Mayo Clinic. She is also the chair of the Neuro-Oncology Committee at the Alliance for Clinical Trials in Oncology. Thank you both to Eva and Sean for all your time and commitment and energy for putting together this incredible program. I would now like to welcome Carla Varner, ABTA Board Chair, to introduce our award presentation.
Thank you, Emily, and hello, everyone. The Joel A. Gingras Jr. Foundation has been a longtime partner to the American Brain Tumor Association. When Joel Gingras Jr. passed away from a brain tumor in 1988, the Gingras family dedicated their lives towards helping others fight this disease and formed the Joel A. Gingras Jr. Memorial Foundation. By doing so, they joined the brain tumor movement. Since parting with the ABTA over 30 years ago, the JAG Fund has donated over $2 million to ABTA research. These funds have drastically impacted the way the ABTA serves the brain tumor research community. We thank them for their tireless commitment and partnership. I would like to now introduce you to Jonathan Gingras, president of the Joel A. Gingras Jr. Memorial Foundation, to say a few words. Jonathan?
Thank you, Carla, and appreciate the warm welcome. I'd also like to thank the American Brain Tumor Association for inviting me today. As Carla said, I'm the founder of the Joel A. Gingras Jr. Memorial Foundation. I'll make the name a little bit easier for you. We use Joel's initials, and we keep it simple, and we go by the JAG Fund. As I prepare my thoughts today, I asked myself, put myself in your shoes, and I wondered, what would you want to hear? What could I say that could bring value to your day? And I wanted to make sure that I kicked off this meeting with some encouraging words. My story is around finding a cure for brain tumors. It starts out sad, but it ends up happy. Sad because I lost my brother Joel to a brain tumor in 1988. He was 27 years old. Happy because his death inspired me to fight. I want to go back to where it started, 1988. I'll do the math for you. That was 33 years ago, which seems like a lifetime. I hope after I tell you about the JAG Fund that you were inspired to fight, inspired to not give up. JAG Fund raises money to support brain tumor research. We've funded 32 medical fellowships through the ABTA, and these fellowships provide critical funding to support brain tumor research done by brilliant doctors, nurses, and researchers. Their focus is to find a cure, and these amazing people are on your team. They are relentless in their search for an answer. They're focused on helping you with your fight. The JAG Fund and the ABTA is determined to continue this funding of this research. We are 100% committed to helping you. Please know that you're not alone. My brother Joel was my best friend. In the spring of 1988, I started seeing him struggle. He had headaches, imbalanced, nausea, and I could see fear in him. He was my hero, and for the first time in my life, I saw him as a human. Never in a million years would I thought that his life would be cut short by a brain tumor, but that's what happened. I want you to know that part of the story because there's a silver lining in this. The silver lining is that the JAG Fund was born. Joel was the life of the party. He seemed to have a knack of connecting with every sort of person out there. When he and I were in college, he had no prejudice with anyone. He never judged somebody for their IQ, their race, their religion, their gender. He was only critical of you if you didn't want to join the party he was trying to throw. So don't get me wrong, though. Joel was smart, he was athletic, and he was very serious. He worked hard, but he also played hard. There was one particular party that Joel loved. Every summer, we would bring friends to my hometown for a tube float on the Delaware River. It was the event of the summer. People would come from all over the place to sit in an inner tube, soak up the sun, and have a few beers. Little did I know that that event would become a permanent part of my life. As I mentioned, Joel got sick in spring of 1988. After around Father's Day that year, he found out that he had a brain tumor. Needless to say, our world was changed forever. Due to complications from his surgery, he was unable to come home from the hospital. And with hospital bills mounting, my friends and I decided to use the tube float as a way to raise money to help him with those expenses. It was a big weekend. People came from everywhere. After the float, his friends and I headed down to the University of Pennsylvania to say hello to him. Sadly, Joel passed away in October of 1988. My family and I decided to use the money we had raised to donate to the American Brain Tumor Association. We wanted the funds to be used to make a difference. The following year, as I tried to continue my life, I thought the tube float is coming, so why don't we continue to try to raise money for the Brain Tumor Association? All of my friends agreed, and from there, the JAG Fund was born. In our early years, our goal was simple. We just wanted to raise money for brain tumor research while holding our tube float. As we grew over time, so did our purpose. We found that our events were starting to create awareness of this disease. People were paying attention to our work, and they started calling us. We were getting phone calls from brain tumor patients and their loved ones. The good news was we were able to connect them to the American Brain Tumor Association, where they had access to educational material and counseling. This was a meaningful change for our organization. So we now carry the responsibility of helping people find answers. There's one thing you need to know about my family. We're fighters, and we're doers. Thankfully, we've surrounded ourselves with amazing friends who are the same. Together, we were determined to help, and we will never let brain tumors beat us. We are keeping Joel's spirit alive, and our goal is to keep the other families from being robbed of a brain tumor. So roll forward 33 years to today. We're the longest continuous fundraising organization for the ABTA. We've donated over $2.3 million, and we've touched many lives. Our efforts are recognized by the ABTA in 2010 when they created the Joel A. Gingras Award. It was a way for them to recognize individuals and organizations for making significant contributions in the fight against brain tumors. Our past recipients include researchers, doctors, entrepreneurs, friends, families, and brain tumor survivors. It's an amazing list of incredible people who are dedicated to finding a cure. I'm very proud to have Joel's name memorialized and associated with these heroes. Nothing will bring Joel back to us, but that doesn't mean we quit. Please know that the JAG Fund and the Gingras family is committed today as we were in 1989. We are determined to find an answer. We're determined to find a cure. We are all part of a fraternity, one that none of us chose to join, but here we are, people who were impacted by a brain tumor. As I said before, you're not alone. You are why the JAG Fund and the ABTA continue to fight. So let me circle back to my initial thoughts of what could I tell you that would matter. I hope you hear this loud and clear. You're not alone. The American Brain Tumor Association is your partner in this fight. They have an amazing team, and they have created a network of organizations that are fighting the same fight. There are power in numbers, and the numbers are working in your favor. So thank you so much for letting me tell my story.
Thank you, Jonathan. In In recognition of the Gingras' dedication to the cause, the American Brain Tumor Association announced the Joel A. Gingras Jr. Award in 2010. The purpose of the Joel A. Gingras Jr. Award is to recognize an individual or organization who has significantly contributed to the mission of the American Brain Tumor Association. We are pleased to recognize Rick Sontag, president of the Sontag Foundation, the Brain Tumor Network, and Spring Bay Companies as a recipient of the 2021 Joel A. Gingras Jr. Award. The Sontag Foundation is one of the largest and most well-known funders of brain cancer research in the United States. The Sontag Foundation has greatly contributed to the ABTA research program, which established a long-term partnership to expand our understanding of brain tumors through innovative research. In 2020, the Sontag Foundation was the ABTA's first ever presenting sponsor of the national conference. The Brain Tumor Network, who you will hear from later today, is a nonprofit organization with the mission to aid adult patients with primary brain tumors who seek personalized information about treatment options beyond the standard of care. Most recently, the ABTA partnered with the Brain Tumor Network to help meet the expanding needs of brain tumor patients and families by jointly referring them to each other's services. The Sontag Foundation has passionately supported people and organizations that make a significant and continuing impact in the lives of individuals with a major strategic focus on brain tumor research and support for patients with brain tumors. Please help me to welcome Rick Sontag as he receives his award and shares more about the Sontag Foundation and the Brain Tumor Network. Rick?
Well, thank you, Carla, and thank you, Ralph, and the rest of the people at ABTA. I'd like to start out by saying I'd be remiss if I didn't tell you that 20 years ago to this day, almost at this very hour, shortly after 9 o'clock in the morning, I was in our company airplane descending to land in New York City at Farmingdale Airport. And as we approached the airport getting ready to land, I noticed a big trail of heavy black smoke coming out of what kind of appeared to be the World Trade Center. As we got closer, I saw a huge puff of light gray smoke coming from those same buildings, and I had no idea what I'd seen. It wasn't until I got on the ground that I realized what I saw first was the black smoke created by the first airplane hitting the North Tower of the World Trade Center. And the later burst of light gray smoke was from the impact of the second plane hitting the South Tower. I'd seen the tragedy of 9/11 up close and personal. I was there probably in an airplane that was as close as any airplane to that second plane that hit the South Tower. In that short time, everybody in the United States had their lives changed. Well, this is the same way that I was introduced to the world of brain tumors. All of a sudden, back in 1994, I was president of Unison Industries. We were a manufacturer of aviation components. We had purchased the company in 1980, and in a little over 10 years, grown that company from one small operation with less than 100 employees to an international company with over 500 employees. The company was successful, was growing. My wife and I also had 3 healthy college-age children. We were finishing the construction of a new house, and life was just plain good. Then one night in June that year, our world collapsed. So Susan had a stroke. She was later diagnosed with an anaplastic astrocytoma. That's a 1 grade below a GBM, glioblastoma. And the doctors told me she had about 3 years to live. Well, I was in a total panic as to what to do. I had no idea where to start, and I found myself struggling to try to find information to do the right thing. And somehow I got her into a clinical trial, and miraculously she survived. In fact, she's still alive today, and even though she's living with a number of impairments. So dealing with brain cancer was really a horrible experience for me. And I just decided it was such a difficult thing to deal with for me, making those life and death treatment decisions in the short time I had available, that I was going to do something about that disease. And so after things stabilized with Susan, and my bad experience was replayed a number of times over and over in my mind, I decided to do something about it. The first thing that I did, and Susan and I did, was to start donating money as to brain tumor charities. The very first donation that we made, in fact, was to ABTA. And we did that over a number of years. But after a while, I got to the point where I said, you know, I would rather do more than just write a check and expect somebody else to do the work. I'd rather do something myself more important. In fact, I had several conversations with Naomi Berkowitz, who at that time was the executive director of ABTA, to decide what we could do. I finally decided that I just needed the right opportunity to do something more significant. Well, guess what? In 2002, that opportunity came along. We sold our company to General Electric. So finally, I had the personal time and resources to do something about the disease. And that's exactly what I did. I started by taking part of the sale proceeds and establishing the Sontag Foundation. And we began the foundation by deciding that our main focus would be sponsoring research related to brain tumors. In fact, as Carla mentioned, that's still the main focus of what we do today. And over the last 20 years, our foundation has donated about $50 million to approximately 60 research personnel around the United States. In fact, as Carl also mentioned, we've become one of the largest private sponsors of brain tumor research in North America. When we did that, we also remembered that we probably wanted to do something to help people affected by the disease. So 1 or 2 years after we started the foundation, we established a brain tumor support group right here in our home turf of Northeast Florida. And every month since that time of early 2000s, we lead a group of people, brain tumor patients and their caregivers, as well as family members, to discuss how to handle the problems of how you live with the disease of brain tumor. No subject is off the table: handling seizures, falling, memory problems, driving, you name it, we talk about it. Caregivers and patients get a chance to help each other with suggestions for how to cope with the disease. Since the time we started that group, we've helped about 200 families cope with the disease. And if you add in the family members, it's probably affected 500 plus people in all. And over the years, we also found that as a foundation giving money for brain cancer research, a lot of people were calling us asking for help in finding things like treatment options of clinical trials, second opinions and the like. And I thought back to my own panic when I was searching through information, trying to find the best options for Susan. And we decided there had to be a better organized way of helping people that are affected by this disease. So in 2016, we decided to form the Brain Tumor Network. And as Carla mentioned, Brain Tumor Network helps provide personalized information to help brain tumor patients and their caregivers deal with the disease and find more effective treatment. It started out with one oncology nurse that we hired out of Mayo Clinic here in Jacksonville, and now has a complete large staff of nurse navigators, social workers, medical records people, and other support personnel, aided by our proprietary information system. And as I mentioned, among other things we do is locate second opinions, clinical trials, as well as help people work with various social issues like insurance. It's exactly the kind of thing that I really hoped existed when I was dealing with Susan's situation. And over the last 5 years, we've helped well over 1,500 patients and going on 2,000 patients throughout the United States. As Carla also mentioned, you're going to be able to hear from 2 of our people associated with Brain Tumor Network a short time later. And it's been a proud for me to be able to establish both the foundation and Brain Tumor Network. And as Carla also mentioned, we have a relationship that goes even deeper with ABTA. We have a joint partnership program where BTN and ABTA help each other. Likewise, we were the sponsors, as Carla mentioned, of the last national symposium. And recently, the foundation, our foundation, gave a $50,000 challenge grant to ABTA to help them with their fundraising program. And that combination of us plus ABTA makes us feel like we are part of the solution that all the founders of ABTA had envisioned. And that's why it's even more of an honor to receive this award from the ABTA and to realize that we are helping work in the tradition of Joel Gingras himself. And we are honored to receive the award. And I, just for the sake of showing you what it is, this is the award we're talking about. And I gotta say, this is one heavy load, not just from a weight standpoint, but to be able to live up to the expectations of what that award means. So on behalf of Brain Tumor Network, Sontag Foundation, all the people that are associated with us, I'd like to thank ABTA for this award, and best wishes for a good rest of the meeting. Thanks.
Thank you so much, Rick. We are truly just so thankful for our partnership with you, the Sontag Foundation, Brain Tumor Network, and you are so deserving to receive this award. We are honored for your contribution to ABTA and the whole brain tumor community, and we know and trust that you will continue to do good work. So thank you so much for being our partner. We now have a short break and a research update. The program will resume at 10:45 a.m. Central Time with How to Navigate Clinical Trials. See you soon.
Good morning. My name is Morgan Schrock. I'm a postdoctoral scientist at Ohio State University, and I was awarded a basic research fellowship from the ABTA from 2019 to 2021 by an anonymous corporate sponsor. And I wanted to share with you our exciting findings regarding a novel antimitotic for glioblastoma patients. There are a lot of strategies to treat cancer. Mitosis is the process by which one cell becomes two. And chemotherapies that stop mitosis are called antimitotic drugs. And this is a brief schema of the mitotic process. And what you can see here is that at the beginning of mitosis, a cell pulls up into the spherical shape and the DNA condenses into chromosomes, shown here. Microtubules, these red lines, attach to the chromosomes and push and pull them so that they center in the middle of the cell. And once every chromosome is aligned, they're pulled apart and one cell becomes two. An example of an antimitotic drug is paclitaxel, which is used in breast cancer, but cannot be used in brain cancer patients, particularly glioblastoma patients, because it can cause a peripheral neuropathy. The symptoms of a peripheral neuropathy include numbness, tingling, pain in the arms and legs, loss of coordination and balance. It can be quite debilitating. And the reason that paclitaxel works in breast cancer tissue is because in breast tissue, the microtubules only function in helping with mitosis, but in the brain, they have a unique additional function in helping send signals. The strategy that our lab takes is that we are trying to develop an antimitotic treatment that instead of impairing microtubules, targets the motor proteins that travel along microtubules. And you can think of the microtubules as the highway and the motor proteins as the trucks that travel along the highway. And our favorite motor protein is MKLP2. And this is a computer-generated graphic of what MKLP2 looks like. It has two arms at the top that carry a big cargo. This blue thing is a big cargo, and it travels along microtubules you see here. And when I play this video, you'll see that it just generates energy from its motor and it walks along a microtubule. And we have several drugs in hand that inhibit MKLP2. And these small molecule inhibitors actually stop MKLP2 just like this. It keeps it frozen on the microtubule so that it can't walk. And if we look at cancer cells under the microscope, this is what they look like. Each individual shape is a cancer cell. This is a cancer cell. This is a cancer cell. And if we treat them with our MKLP2 inhibitor, what we see is a mitotic arrest. So these cells are pulling up into that spherical shape and they're in mitosis, but they're not splitting into two. So they're just kind of halted in mitosis. And if we go out even further, we look at these cells 2 days after treating with the MKLP2 inhibitor, what you see are a bunch of dead cells. These cells have lost that spherical shape because they're dying. And this is very exciting for us. If we look at cancer cells, these are cancer cells zoomed in, each one is a cell. If we look at them with the MKLP2 inhibitor zoomed in, what we see, I'm going to pause the movie here, each of these individual lines is a chromosome. And a lot of them are aligned at the center of the cell, but some of them are out at the poles still. And if I play this movie, what you'll see is they dance around for a really long time trying to get aligned at the center of the cell. Some of them do eventually split, like this one and this one, but most of these cells actually stay arrested in mitosis. So to sum up the significance of our findings, we have discovered a previously unreported function for MKLP2 in early mitosis. And this is important because MKLP2 function in helping chromosomes get to the center of the cell provides the rationale for using MKLP2 inhibitors as an antimitotic chemotherapy for brain cancer patients, particularly for glioblastoma patients, because glioblastoma is characterized by being a cancer that has cancer cells that divide very, very frequently at a high rate. And so if we can stop their mitosis, we can stop the cancer growth. And finally, we have been able to show this in the lab. This right here is a growth curve of glioblastoma cancer cells, and you can see that they grow very rapidly. But if we treat them with mild or moderate doses of the MKLP2 inhibitor, there's no cell growth at all. These cells die. And I wanted to thank the American Brain Tumor Association, my lab mates, and my family for supporting this work. Thank you.
Welcome back. Our co-chair, Dr. Eva Galanis, will introduce our next two speakers.
Welcome to the second day of the ABTA conference, and good morning. During the first day, we heard about discoveries and advances that generate hope for better treatments. A lot of these discoveries have been translated into clinical trials. Participation in clinical trials can offer patients and family access to these treatments. In addition, participation in clinical trials is shaping the neuro-oncology of the future and gives hope to other future patients, and that clinical trials of today will translate into standard of care treatments for tomorrow. Having said that, a lot of you in the audience know that sometimes it's very challenging to decide what is the right trial, and also to navigate the process of being enrolled in a clinical trial. So this session shares strategies in considering clinical trial enrollment, and we are very honored to have two prominent neuro-oncologists to discuss that. Dr. John DeGroot, who is a professor and director of clinical research in MD Anderson, and soon to become the division chief in neuro-oncology in UCSF, and Dr. David Reardon, professor of medicine at Harvard Medical School and the clinical director of the Center of Neuro-Oncology in Dana-Farber. They are exceptional clinicians and researchers, and in addition, they are passionate patient advocates. So I have asked them not only to cover the topic, but also just give us maybe a brief glimpse about themselves, who they are, why they're passionate for the work they do. Please welcome Dr. DeGroot and Dr. Reardon. Dr. DeGroot will present first. So John, welcome.
Thank you very much. I really appreciate the invitation from Dr. Galanis and Dr. Hervey-Jumper for the opportunity to present to you today. I'm going to present some of the basic backgrounds about clinical trials and sort of go through some of the nomenclature and various other basic aspects of the studies themselves. These are my disclosures. And these are the objectives that I'm going to be walking through today. Talk a little bit about background of the clinical trials, benefits of participation, just the real nuts and bolts of what a clinical trial is, who can participate, what are the stages of development, and run through some of the key terms at the very end. So just as a bit of background, I'm sure everyone knows about clinical trials, but unfortunately, very few patients are actually enrolled onto clinical trials. I think Dr. Reardon later will go through some of the reasons why that has been such a challenge, but we all are huge advocates for clinical research because it's really through participation in these trials that we're going to be able to gain the knowledge that we need to understand the safety and the efficacy of the therapy so that we can actually advance patients and improve outcomes. There are, of course, many potential benefits, and I don't want to read through all of these, but in clinical trials, you're potentially able to get access to therapies that maybe you couldn't get through public sources. And when you're on a clinical trial, you get a lot of attention from the clinical research team, which is really important in terms of making sure that the therapies are safe, but also to help you navigate some of the challenges that come with participation. And of course, what's very interesting is patients who participate in clinical trials actually do better, even if they're randomized to the control arm. And this is something that I think really speaks to getting this expert medical care and oversight by the clinical research team. There are, of course, potential risks. That could be that the side effects from the treatment or that the treatment may not work. And sometimes clinical trials require a bit more commitment than they would if you were just participating in standard of care treatments. So what exactly is a clinical trial? This is a study that's done in human volunteers designed to answer specific health questions. And it may not be focusing on a drug, for example, to improve outcomes necessarily, but it may be a trial to better understand how to detect the disease or how to prevent the disease. But the goal ultimately is to determine if this new test or treatment is actually safe and whether or not it's effective. There are multiple different types of trials. Some are observational, meaning literally just being observed. Others are registry type of trials. This is RWE, stands for real world evidence. So these are patients who are being treated actually within the community, within what would be considered approved or standard of care. And then those are interventional trials, so actually where something is being done specifically to the patient. There's multiple different components of the trial, and I'm going to walk through each of these because I think they're helpful in terms of understanding the structure of how clinical research is performed within the medical centers. So a clinical protocol is really sort of an action plan that describes what can be done. I kind of think about it as the rules. Who would be eligible to participate? What types of treatments are being done? What are the doses of drugs that are going to be given? How long is the study, and what types of information will be collected? And all this is overseen by a principal investigator, so somebody who's responsible for all aspects of the protocol and all patients. For multi-center trials, there might be a PI at each of the different institutions, and everybody works together to make sure that everybody's being treated similarly. So what is informed consent? So I think everybody who has had surgery or some kind of procedure in the past has had to sign an informed consent. And this is essentially done to provide participants with the information that they need to understand whether or not they should or can participate. Obviously, participation in any clinical trial is voluntary, but this informed consent process and the document that you sign really lays out all of the details about potential risks, but also potential benefits, as well as your rights and responsibilities. A member of the research team would meet with you and review all of these potential risks and benefits and rights, and then help answer questions and determine whether or not proceeding is something that the patient wants to do. Clinical trial endpoint. So an endpoint really is just kind of an event or outcome that can be objectively measured to determine if an intervention is actually beneficial or not. And there are multiple primary endpoints that can be implemented. For example, earlier stage studies might look at safety, but then there also can be endpoints such as improvements in outcome, delaying the time before the tumor comes back. We use MRI scans, which can show decreases in tumor size, and also importantly, whether or not a treatment impacts whether or not your quality of life is good or not. We also integrate as scientists what we call correlative endpoints. These are things like biomarkers that we use to understand how an agent works, and also different tissue studies to see whether or not what we're doing works in specific subpopulations of patients. Who can participate? So all studies have guidelines about who can participate. These are really designed to keep the patient population as uniform as possible. And there are inclusion criteria and exclusion criteria. Inclusion criteria would be those factors that you would have to have that would allow you to participate. And then an exclusion criteria would be factors that, if were present, would keep you from participating. This is a kind of a laundry list of some of the things that we commonly think about with inclusion and exclusion. It could be the age, the type of tumor, some kind of molecular factor within the tumor, like IDH mutation. There's one very important factor that we use, which is the Karnofsky Performance Score. And that is something I'll show in the next slide. And having good function and be able to take care of yourself. Some of the exclusion criteria that we think about are having something that's been directly implanted into the tumor, for example, whether there's been some kind of bleeding in the brain, which is a potential risk. There are some other very specific therapies related to different types of treatment. For example, patients who have autoimmune diseases would not be good candidates for immunotherapy trials. And for example, some studies might restrict the amount of steroids that you're having to try to prevent having an anti-inflammatory type of response, which could keep a therapy from working better. This is the Karnofsky Performance Status Score. Most clinical trials restrict studies to patients who are able to essentially care for themselves. And as you can see, the score runs from 0 to 100, and we usually include patients who are 60 or 70 and above. Again, this is an effort to make sure that any type of intervention that we give doesn't hurt anyone. And sometimes for patients with a lower KPS score, there is a greater risk to those patients. So the different types of trials are going to run through early phase, and then phase 1, 2, 3, and then 4. So early phase trials are sometimes referred to as window of opportunity trials. Some people have called them, I think incorrectly, phase 0 studies. But these are studies that are designed to give a treatment to a patient prior to going to surgery. And this is meant to sort of bridge the gap between what's done in the laboratory and what we do in the clinic. We might be looking at the tumor to look at drug levels or other types of biologic endpoints. And sometimes these are done prior to phase 1 or at the same time as phase 1, but are really given to patients where drug has not really been given to many brain tumor patients. The goals of these early phase trials is to make sure that the drug or whatever is being given is actually engaging the target within the tumor itself. So obviously, we have to know that the target is present. So knowing that there's this minimal target expression level within the tumor. But then also, as you've heard, the blood-brain barrier can restrict delivery of drugs or cells or other agents into the tumor. And so this is a really important mechanism to determine whether or not the drug is actually getting across the blood-brain barrier and actually impacting the tumor. This is meant to really bridge the preclinical and clinical development and even expedite, speed up the therapeutic approaches. So phase 1 trials are looking to basically determine safety of the therapy. We sometimes collect data on the dosing and the timing. And sometimes patients on these types of trials are actually getting first access to drugs. We think this is really important, and we're able to determine whether or not this drug is safety and what is the dose that's minimally effective for patients on these types of trials. These are usually small trials, maybe only 10 to 20 patients, but it's important to remember that all drugs that are now used in patients have actually had to go through phase 2 trials. Are studies that are designed to gather additional information, not only about safety, but also to get an early look as to whether or not a treatment is actually working. These are looking at response in multiple different ways. It may be the imaging, it may be patient survival, some of those other endpoints that we talked about. And a study like this might look at maybe 20 to 40 patients on average. And sometimes there's even trials where there's randomization of the the treatment to multiple different types of arms to look at multiple drugs at the same time. Phase 3 trials, these are really the gold standard for determining whether or not a therapy is effective or not. So this is taking drugs who've gone through these phase 1 and 2 studies and actually testing whether or not this drug actually can improve upon this current standard treatment. And these are typically randomized and typically enroll hundreds of patients. So this is sort of the summary. Phase 1, safety, looking at side effects. Phase 2, really looking to see if a drug is working or not, but also make sure it's continuing to be safe in larger numbers of patients. And then phase 3 is the gold standard to confirm the efficacy of a treatment. There is something called a phase 4. I won't spend much time on this. Once a drug is approved, sometimes there are phase 4 studies that allow for scientists to actually track additional safety data and determine whether or not the drug is efficacious across broader populations of patients, and to make sure that long-term the drug is safe. So just a couple of key terms. So placebo, this is an inactive product that might resemble the study drug, but does not have any treatment value in and of itself. Most of our studies don't include something that just has placebo. There's usually it's some type of therapy or standard of care together with a placebo. Randomization, so this is a process in which 2 alternative treatments are assigned to volunteers by chance rather than by choice. So basically you don't get to choose which agent you're on or which arm of the trial you're on. And then a lot of these randomized studies are blinded. So single blind would be that the participants still don't know, but others do. And then double blind, which is the more common one, would be where participants and the research team do not know which therapy is given, being delivered to the patients. So I think, there are some practical considerations. Obviously, trials might require more frequent trips to the hospital for blood work, MRI scans, IV infusions for drugs, and for studies that involve radiation, maybe having to receive radiation at that center. There can be a lot of other documentation that has to be filled out. And fortunately, some trials do offer reimbursement for some of those patient travel and food expenses, because we know participation can be quite expensive. So some questions ask your doctor. You can read through these, but what is the purpose? Do researchers think that this will work, or why do they think it will work? What is the responsibilities if participating? Potential side effects? What other options? What kinds of procedures and tests would have to be involved? And then will I be able to take regular medications and other things during the study? And then once this is all done, this is all companies or investigators come together, assimilate all of the information, and then present this data at various forums and meetings and in publications. And of course, work with the regulatory agents like FDA to try to get these drugs approved if they have been shown to be effective. So with that, I would just like to thank you for your participation. And I think we're going to leave questions to the end.
Hi, good morning. My name is Dave Reardon, and I'm the clinical director at the Dana-Farber in Boston. I wanted to thank the ABTA, Ralph Vito, Nicole Marth, and all of the team for putting together this wonderful conference. And it wouldn't have happened without the hard work of Drs. Galanis and Hervey-Jumper. So special thanks to them for organizing this. And I'm very honored and privileged to have the opportunity to follow Dr. DeGroot and talk a little bit more about navigating clinical trials. As an aside, Dr. Galanis asked us to say a couple of words, a little bit of background, a little bit of information for familiarity. I got into, I'm the only physician in my family. Going into medicine, knew I was very keen to be in a field where I could help work with patients who are sick, going through difficult times, and was immediately drawn to oncology because of the severity of illness that patients are afflicted with, but also because of the science. that goes hand in hand with this field. In every field in medicine, there's always research, there's always work ongoing to move the field forward and gain more information to help better understand and treat diseases. But I think it's amplified in oncology quite a bit. And in neuro-oncology in particular, I think is very much a field where the severity of illness and the importance of science are going hand in hand, where both areas work very hard to come together to improve outcome for patients with these illnesses. And I think that's very relevant to what we're talking about here today in terms of clinical trials. And it's something I've been very involved in and I've prioritized quite a bit in my career because of the science that's involved, that our research colleagues in the laboratory are driving better insight, better understanding of what makes these tumors tick, what gives them an advantage over normal cells in our body, and then how can we exploit that information to develop better therapies. And we have to utilize formal strategies in order to be confident that we're utilizing that information with these therapies, these promising investigational therapies that are coming forward. And that's through the opportunity posed by clinical trials that Dr. DeGroot just very nicely described in some detail. And I'll elaborate here. Here we go. So for my disclosures, unfortunately, no stocks or patent rights. I have had a fair amount of collaborative effort from many companies to help support our work and been involved with. So the overview for my part of the talk, I want to switch and talk about, instead of some of the nuts and bolts that Dr. DeGroot covered, talk a little bit about actually putting these trials into reality and making them work, particularly in the current era, and talk a little bit about barriers for clinical trial enrollment, the impact of COVID-19 and the emergence of telehealth. I want to spend a little time on some of the common myths that are out there about clinical trials, and then finish by a little introduction to the next session, kind of setting the stage for how patients and families can try to work to find the right trial for you. In terms of barriers for participation in clinical trial, I don't have time to go over all of these details today, but I do want to highlight first and foremost that our community in neuro-oncology is very focused and aware of these issues and have made it a priority to better understand what are some problems, what are some of the hurdles that get in the way from patients participating in clinical trials. Clinical trials for our community are a critical priority. We really have to do as many of these important trials as possible to improve outcome for our patients. So we've got to figure out these barriers and overcome them. And our community, and I refer specifically to the Society of Oncology, or SNO, some of you may have heard of, is the largest multidisciplinary organization of professionals focused on the care of patients and families dealing with brain cancers. And the society put together a recent review with input from many different sources, including patient advocates, barriers that are impeding participation in clinical trials for patients and families. And there are four main categories of barriers. Those that to try to care the brain tumor. Did I lose you?
Your internet seems to be going a little
Hello?
out on your video.
Okay, maybe I'll stop my video so at least you can see the slides without compromising that quality and the audio. Is that okay?
Yeah, that's absolutely okay.
That'll help.
Mhm.
So the site or organization where you're seeking care, there may be some issues within the institute that limit clinical participation. The physician who's overseeing care of patients, there may be some gaps or problems there to better understand and overcome. There certainly are some issues related to clinical trials that we as a community are aware of and trying to do better to make the trials more broadly applicable and able for patients and families to participate in. Then there are a number of factors at the level of patients and the community that can impact and have it make a hurdle or challenge for patient in clinical trials. And all of these, we move to the next slide. Barriers and issues are relevant. The barriers that I highlighted in the 4 levels on the prior slide, on the next slide, please, these are even further amplified in populations within our communities. Please advance to the next slide. That are underrepresented, particular populations. Again, our community and the Society for Neuro-Oncology, please go back one, are aware of these additional issues that make things more challenging for minority populations, and pitfalls highlighted across the bottom here. There's many to go into and to discuss. Don't have time for that today, but there's related to various stages of care for patients and families going through dealing with the diagnosis, initiation, care for treatment. And we as a community, again, focusing on better understanding these hurdles, these challenges, and overcoming them for all patients and families, in particular those coming from underrepresented minority populations. If we go to the please. I wanted to take a moment and just a little bit of the impact of COVID-19, and that has had a significant impact on all levels of research, whether they be in the laboratory or in the clinic through clinical trials. But one of the silver lining from this pandemic and its impact on research has been the emergence. We had to pivot and shift to telehealth. And this provided a significant opportunity to take advantage of the capability of telehealth to be able to care for our patients and continue to perform clinical research, clinical trials. So in some ways, this telehealth surge represents a silver lining of the coronavirus pandemic. Patients and families, I think it's been having the opportunity to have visits, to interact with their clinical team, whether it be physicians, nurses, mid-level research staff, from the comfort of living in your room and home, saving time and travel and costs associated with that. Our patients in particular, it can be difficult for traveling, for limitations on physical function and capability, and not having to deal with that as much by having to travel back and forth is big benefit and help for patients and their caregivers. There's flexibility of setting up visits, when we can do them, how we can do them. And it's also allowed us to decentralize much of the aspect of clinical trials, to expand them and allow them to be more available at broad level. There are disadvantages. It's challenging trying to evaluate patients and how they're truly doing over a video rather than on a face-to-face evaluation. There can be problems with the availability and access of telemedicine and internet technology. Again, could be amplified as disparities amongst my populations and further foster we certainly want to avoid. There may be less sophisticated technology we can apply in these evaluations, from laboratory studies as well as imaging, that may be a problem or an issue. We have to rely on logistics like shipping, scans and samples, blood samples, etc. And I can only speak to the fact that using the telehealth platform poses a lot more work and effort for the research team to be able to do scheduling, getting access to the material that normally coming in for your visits would be readily available through the context of the visit. Here, everything is taken work because it's being done locally and shipped. And then we have up and talk about those results with you all once we've got them in and gone over them. The status of where we are today with telehealth, things are continuing to shift. The pendulum definitely swung nicely in favor of telehealth. It's even much of the clinical research work that's ongoing. And now the pendulum is swinging back a bit more, where access for telehealth is becoming less available. And many states, now that the national emergency status has been lifted, are requiring more visits and no longer allow, particularly for out-of-state virtual visits. So things continue to shift here, and we're doing our best to adjust accordingly. If we could go to the next slide, please. Just some wanted to highlight in wrapping up some common myths associated with participation in clinical trials, and I've listed probably many more, and I hope we'll have some chance to answer questions, some of these that you all may have in the next session here. First, myth number one, I'll be treated like a guinea pig. I think, although it's understandable about clinical trials and investigational therapies, our research teams, and I speak for our community and the neuro-oncology or brain cancer world here, where our teams work very hard for maintaining a high level of personalized care, whether you're being treated on a trial or with a standard of care therapy. And as Dr. mentioned, in some situations, actually participating in a clinical trial, because of the diligence that's involved in monitoring those patients very carefully, actually an even heightened level of scrutiny and personalized care, which I think underlies the benefit that patients get from participating to be negative. Second myth is clinical trials is because they use untested drugs, and yes, clinical trials are evaluating drugs in various stages of development, but they happen through a very careful review and scrutiny before they get to the point of being administered to patients. And then in the context of the clinical trial, there is very heightened monitoring and evaluations to watch out for and to intervene if there do to be side effects or issues developing. So although there is an element of unknown, because of the heightened diligence and monitoring that's involved, the level of danger in participating is quite low in general. Myth number three is once I participate in a trial, I cannot change my mind. That's absolutely not true. Patients who participate in a clinical trial can change their mind at any time. No question asked, they can simply indicate to their team that they never want to participate in the clinical trial, and the clinical trial and their participation will end at that point. Myth number four is I'm in a trial because I'm afraid of getting a placebo. As Dr. DeGroot mentioned, there are randomized clinical patient would get either a placebo or standard of care treatment relative to the investigational therapy that's being performed. We as clinical trial investigators are obligated to make you aware of that possibility if it is part of the trial or not. So you will be, that will be discussed ahead of time, and you'll know going into the trial if there is that possibility of being put on a standard of care arm of the clinical trial. Myth number five is joining a trial helps future clinical trials that we're involved with often argue the next generation of patients who are dealing out of participating in a clinical trial, including monitoring and vigilance that goes into the best level of care while they're participating in the clinical trial. So I think the trials do help patients regardless of the drug is successful or not. Yes.
Your internet seems to
Emily?
still be glitching, and we're just going to jump right into questions and answers right now, as we have a ton of questions coming in and we want to make sure that we have enough time for it. My pardon to interrupt you, but if you can, just try to keep your camera off during the questions and answers, and then you can still verbalize them. If you're still having issues, you can use the number I sent you to call back in to help respond to the questions too.
Sorry about that.
That's okay. Thank you so much, both of you. And now we will take some questions.
Thank you both so much, and I apologize for the internet issue there. As a reminder for anyone who has questions that they'd like to ask, please type and submit it using the Q&A button, and we'll answer as many questions as time allows. So one of the first questions that we have here is asking, are you aware of any studies or trials on proactive therapy or steps that patients can take to help reduce the chances of recurrence? So this would be during wait and watch after treatment has already been done. Is there anything that can be done proactively to prevent reoccurrence or regrowth of the tumor?
I'm happy to start. And Dr. Reardon can add if he has other comments. This is something that I get asked daily, and I think it's a really important question. I think today we don't have any therapy that we know can be administered, post-treatment to delay recurrence. This is a very challenging scenario, in part because to run a clinical trial might be very difficult to actually determine whether or not this approach is effective or not, because there are so many things that go into that risk of recurrence. And so I think it's a wonderful area. It's an important area for us to spend additional time on and trying to figure out what can be done. But as of today, unfortunately, we don't have anything that we know works in that setting.
All right, so one of the other questions that we have here is asking, what can a patient do, let's say they're newly diagnosed, they just received their diagnosis. What are steps that they can take now to help ensure that they're getting access to the best treatment options available? Are you aware of resources, or can you provide any guidance on where they can go to find out information about trials that they might be eligible for?
Yes, this is also a really important question. I think one of the places to start is with your current doctor who's helping to take care of you. That might be a place to start. But there are also a lot of resources that are available. And I think actually in the next section, there's going to be some discussion about resources, American Brain Tumor Association included, that can help perform, sort of a navigation role and really try to help identify, other resources or other places where patients can go to receive treatment on clinical trials.
Thank you so much for sharing that. Another question we have here is on the costs of clinical trial. Can you provide some insight on what parts of the clinical trial might be covered by a patient's insurance, if any parts of the clinical trial are covered by insurance?
Right, so the way most clinical trials are designed and the way most insurance companies view the ability to pay for a patient's participation on a clinical trial is that those treatments and investigations that are considered standard of care are still covered by the insurance company. Anything that's not standard of care would then need to be paid for by the sponsor, such as a company, or if it's an investigator-initiated trial, by some other type of funding mechanism, maybe a grant or a foundation that can help supply the funding for those things. There are occasions when insurance companies will claim that something is not standard of care, and that really requires the research team sort of advocating for the patient, and usually those things can be resolved. There's not many chances now when insurance companies are refusing to pay.
On your slides, you had mentioned, you had listed conflicting roles as caregiver versus scientist for the physician. Can you elaborate on that and share with our audience what you meant about that conflicting role?
Well, I think there is a responsibility. There are two levels of responsibility for clinicians caring for patients when they're participating, when there is the opportunity to participate in clinical trial. First and foremost is the care of the patient and make sure everything is done as optimally and handled as well as possible. The secondary responsibility many of us have in conducting clinical research is to make sure that the clinical trial conduct is followed carefully and compliantly, and that everything is done as effectively as possible as outlined in the clinical trial. And sometimes it can be a little challenging to do both of those, serve both of those roles and complete both of those objectives well. But I think first and foremost is our commitment to providing the very best care for the patients and families and not letting that in any way be compromised.
Thank you so much
Did you
for
hear that okay?
Yes, we did. Thank you. Thank you for providing that clarification and understanding. Another question we have here is asking about the patient's rights during the clinical trial process and the preclinical steps as well. You know, we know that patients have the right to informed consent, but can you tell us a little bit more about what other rights they might have throughout the clinical trial process?
Well, one in particular that I mentioned, and I hope it came through, was one of the myths about not being able to change their mind or withdraw participation in the clinical trial. And that is something that's completely not true. Once signing a consent form is not a contract. It's your permission to participate in the clinical trial and allow our team to work with you and your family in the conduct of the clinical trial. But patients and families have the right at any time to change their mind and withdraw from the trial if things aren't going well, or if it becomes too challenging or difficult to participate, or no questions asked. You can just change your mind and decide not to participate. That, I think, is first and foremost of an important right that sometimes patients and families don't realize that is important to understand.
Thank you. Dr. Groot, did you want to add anything to that?
No, I think that's exactly what I would have mentioned as well. You know, all of those rights are listed in the trial, and I think the one that Dr. Reard mentioned is probably the one that comes to mind for most people. So, thank you.
Thank you. Another question we have here is asking, if a patient has already been on a clinical trial, do they qualify for other clinical trials in the future, or does having been on a trial in the past negate their chances of being on another one in the future?
In general, participating in one clinical trial does not negate participating in subsequent clinical trials, but I think, as Dr. de Groot explained, each trial has very carefully itemized criteria for patients to participate. And some trials do exclude patients if they've had certain types of prior therapies, or if they've had a certain number, in excess of a number of different types of therapies. So those would be the situations where there may be, having participated in a trial may make it difficult to participate in a subsequent clinical trial, just depending on what's specified in the eligibility criteria for each trial.
Thank you so much. Dr. de Groot, did you want to add anything?
I think that was well said. I think the other one is just the number of times that you have a recurrence can sometimes be a challenge. There are some sponsors in particular that want to limit trial eligibility to first recurrence, for example. And so if you're on your second recurrence, that trial would not be an opportunity for you. And so in participating, one is not eligible, but not because of being on a trial, but because of the other way the eligibility criteria are written.
Thank you. I think we'll take just one last question. This is again back to covering costs. So, some trials might only be available in a specific location. Is there resources or assistance available for patients who have to travel for a trial or who need housing or lodging during their stay for their treatment?
Yeah, so there are some trials that do include costs or payments for participation that can cover things like housing and travel and food, for example. I think it's always remains a huge challenge, maybe over and above many other of the challenges to participation in clinical trials that Dr. Reardon outlined earlier. This tends to be one that I think is getting a lot of scrutiny. And I know as an investigator, working very hard to try to get sponsors in particular to actually help.
Well, thank you both so much for your time. That is all the time that we have for questions for this session. I will turn it back to Emily and we'll move forward to the rest of the program.
Thank you so much. And thank you, Dr. DeGroot and Dr. Reardon, for that wonderful session. We really hope that the attendees enjoyed it. As a reminder, each of you will receive a copy of the transcript, slides, resources post-event. I know we had a few questions asking about that, so each of you will get these as a resources post-event. For those of you who need a break, please take this opportunity to stand up and stretch your legs. We invite the rest of you to stay on to hear our research update, and we will return in just a few moments to hear from our partners, the Brain Tumor Network, on patient navigation. Thank you so much and see you soon.
Hello, everyone. I'm Loitash Karumbaya, an associate professor in the Regenerative Bioscience Center at the University of Georgia. I'm grateful for a discovery grant from ABTA and the Uncle Corey Foundation that supported our work on immunosensing glioblastoma-induced glycomodulation. I'm sure we are all intimately familiar with the poor prognosis associated with glioblastoma, or GBM, which remains a hard-to-treat cancer. Despite several therapeutic innovations in clinical standard of care, we still do not fully understand mechanisms by which these tumors spread and avoid being targeted by drugs and novel immunotherapies. Research in my lab is focused on studying the role of a meshwork of sugars that are produced by GBM and that surround the tumor microenvironment. We and others have demonstrated that this meshwork of sugars is unique to the brain tumor environment and can promote the aggressive growth and invasion of GBM, and also presents a sticky matrix that can potentially block the entry of drugs and suppress the activity of novel tumor targeting immunotherapeutics. Our findings, supported by the ABTA grant, suggest that these sugars suppress the activity of tumor targeting T-cell therapeutics. Ultimately, we envision that blocking the activity of these sugars in the GBM microenvironment will restrict tumor invasion and enhance the efficacy of novel drugs and immunotherapies against GBM. Work in my lab is focused on devising novel glioma on chip platform technologies that can replicate the 3D brain tumor environment and that can be used to rapidly screen the efficacy of novel GBM targeting therapeutic agents. Promising therapies identified through these screens can then be validated in preclinical animal studies prior to clinical testing. I would like to again thank ABTA and the Uncle Corey Foundation for supporting our work and for also supporting the training of a talented graduate student, Megan Logan, who led a lot of this research in my laboratory. I would also like to acknowledge the support and mentorship that I received from my clinician collaborator, Dr. Dan Bratt at the Northwestern University Feinberg School of Medicine. Thank you.
Welcome back. Our next session is on patient navigation. Patient navigation is still considered a relatively new term in the healthcare industry, measured by metrics and tools. This session explores the positive impacts of brain tumor navigation through the metric that matters most, the patient experience. Please welcome our presenters, Tracy Edwards, Social Work Navigator, and Jenna Tazi, Neuro-Oncology Nurse Navigator from our partner, the Brain Tumor Network. Tracy will present first, followed by Jenna. Thank you so much.
Thank you, Emily. Hello, everyone, and thank you for taking the time to be with us today for our presentation on patient navigation, guiding and empowering patients and caregivers. We hope today finds you well amidst the pandemic and remembering 9/11. We have nothing to disclose, but I would like to congratulate and commend our president and founder, Rick Sontag, who graciously accepted the Joel A. Gingras Award earlier today. We hope you find this information valuable. By the end of this session, you will learn the definition of patient navigation and why it is a need, how the Brain Tumor Network is serving that need, how to find and enroll in clinical trials. What is patient navigation? Patient navigation provides individualized assistance to support patients, caregivers, and loved ones. This assistance reduces barriers they may be facing and increases timely and quality access to medical and psychosocial care. Patient navigation in oncology has been refined over the last 20 years with the addition of core competencies, Commission on Cancer Standards, metrics to measure outcomes, and certification is offered in the field. What does that mean? Oncology patient navigation is now nationally recognized and standardized. You can find patient navigation in a variety of settings. Nonprofits like the Brain Tumor Network are objective and can talk with you about care at many different treatment centers or with a variety of providers and focus on your specific needs without bias. Cancer treatment center navigators can help explain an internal network and scheduling, as well as to you face-to-face and provide education and information. Insurance providers have navigators who attempt to increase the efficiency of your healthcare and attend to your needs by phone. Pharmaceutical and commercial companies like Optune have built-in supports that offer patient navigation for their specific treatment. Clinical trial navigators help with specific trials at specific centers, and patient care and survivorship navigators often focus on symptoms and quality of daily life. They can be a significant source of psychosocial support and care planning throughout the continuum. So to recap, a patient navigator guides you through the healthcare system, helps you communicate with your healthcare providers, helps you get financial, legal, and social support. An article from the National Institutes of Health identifies the top 3 barriers to care for individuals newly diagnosed with cancer to be healthcare communication issues, insurance and financial concerns, lack of social support. We can increase healthcare communication by advocating for sooner results and appointments, discussing medical terms and treatment in a way that you and your loved one can understand. We can let you know what to expect and questions to ask. We can help you understand insurance and finances by educating you about in-network providers, appeals, applying for Social Security, disability, other benefits, communicating with your employer, and options for continuing healthcare coverage. We can also inform you of resources available for financial assistance. We can help address the lack of social support by connecting you with people who understand what you're experiencing. We can connect you with organizations that address things like meals, in-home safety concerns, respite care, transportation. There are also many resources for helping loved ones and caregivers to cope. Caregivers often feel helpless and hopeless and isolated and neglect their own needs. We can encourage patients and families to find adaptive ways to enjoy life and have fun. What are some real-life examples to barriers of care? George, who is a concerned adult son and advocate for his dad, came to a brain tumor network and they weren't sure where to turn. George felt his dad was receiving adequate care at his home cancer center, but wanted more options beyond standard of care. Our nurse navigator helped them to identify centers of excellence and provide them with a personalized clinical trial search, identifying potential trials at each center. They had one virtual second opinion and were about to go in person for a consultation at another center. George let us know that they had the most recent MRI results, but they had not gone over it with the neuro-oncologist. We would help here by providing questions to ask at the second opinion consultation and by following up to be sure they were able to address the MRI results with his neuro-oncologist and that they were able to understand them. Karen's husband was working full-time when he was diagnosed with a GBM. He wanted to maintain employment and return to his job not long after surgery. He needed time off now and then for various treatments and when he would experience symptoms or side effects. I've been helping them for a while to navigate through his paid leave, Family Medical Leave Act, short-term disability, and to link as much paid time off as possible. Eventually, he decided to stop working. Karen reached out stating, "I may call you when we get further into disability situation." His short-term disability bucket renews on August 8th, which is why we've been trying to make it until then. Once he starts that, we will do the application for employees' long-term disability benefit. Evidently, that process can take several weeks. I can help Karen by walking her through the disability process or by just letting her know that it may not be as daunting as it seems. I can acknowledge how hard it is for this patient to give up his employment and for their family to face this uncertainty. Karen and her husband also participate in a brain tumor support group where they share concerns and receive support from others who have similar experiences. And now we come to Sharon. Sharon is a wife and caregiver, and her husband has recently been diagnosed with a brain tumor. He has not yet started standard of care. She is worried about the lack of social support if they travel to a clinical trial. She shared, "Although I am the one asking about trials, I'm reluctant to leave home and pursue treatment. We have a business, a lot of support, and the comfort of home. I know these are real things, and leaving home right now might overwhelm me." She also asked about the insurance coverage and paying for clinical trial. We heard about that in our last session. It is one thing to find a viable trial. It's another to face the logistics of making it work for you and your family. She commented, "If something is compelling enough, we should consider it." And I can assist her in acknowledging just the weight of that decision. I can help by connecting her with brain tumor support resources and travel and lodging resources if needed. And yes, there are resources to help assist with the cost of those things. I can also assist her to find out about paying for a clinical trial, having met their annual out-of-pocket maximum. As you can see, most people facing a brain tumor have a multiple intersection of needs. I'm now going to hand it over to my co-presenter, Jenna.
Thank you, Tracy. There are many benefits to having a navigator on your team. We have a dual approach to care at the Brain Tumor Network, where each patient and caregiver has access to an experienced neuro-oncology nurse navigator and oncology social worker. We provide a holistic approach to navigating, assessing for any barriers to care by actively listening to patients and caregivers. Patients come to us at all time points of their diagnosis, and we strive to meet them where they are. Next slide, please. Through our clinical and social work assessments, we can provide individualized navigation. Each patient or caregiver's unique needs are matched to personalized resources. For example, a patient may call in wanting to get connected to a local support group or needs more education on what to expect during standard of care. A caregiver may call in anxious about a patient's upcoming scan and needs someone to talk to. Or a patient was just told they have a recurrence and they want to pursue clinical trials. We will help with any of these scenarios and more. Just last year, we helped navigate 500 families. We helped facilitate 300 consults. We presented 150 personalized clinical trial searches, and 310 people received psychosocial support. So when can I consider a clinical trial? It is important for us to educate patients and caregivers on the critical time points when patients are eligible for a trial. We often utilize these scenarios, as you see here, to inform a patient on when they can consider a trial. A few examples include at the time of a new diagnosis prior to surgical intervention, after the initial biopsy or surgical removal, but before starting standard of care, after completing standard of care, but before starting maintenance therapy, or at the time of tumor progression or recurrence. Please note, this is for general informational purposes only. Due to the extensive diversity of primary brain tumors, not all patients will be eligible for surgery or have standard of care. So how can you find clinical trials? Any of these critical time points that I mentioned earlier are an opportunity for you to ask your care team what trials are offered at their institution. If they do not have any trials to offer, this is when you can search on your own. You can try using trial matching databases on the internet. You can search through clinicaltrials.gov. You can look on specific institution websites, or you can explore organizations that can assist with a trial search. By utilizing Brain Tumor Network services, we can review your medical records and provide a personalized approach to navigating the clinical trials database. Through our clinical needs assessment that we perform, we can understand a patient's tumor pathology, molecular profile, treatment history, comorbidities, and KPS score. We also make sure to gather information on geographic location and demographics to assess for any barriers to care. We ask questions like, how far are you willing to travel? Do you have a support system in another area? Are you able to cover frequent travel costs? This allows us to understand if we should look locally or nationally for clinical trials. So how can you enroll in clinical trials? With the detailed information described previously, we can utilize our internal clinical trial matching system and perform a search. A list of trials is populated and narrowed down based on inclusion and exclusion criteria. The list includes detailed explanations of the trial requirements, phase and design, as well as information on what treatments will be used. We also provide information on prior studies utilizing the novel treatment if available. An example of this list is pictured here. This list can be printed or emailed to your care team. We encourage you to discuss the list of trials with your care provider, not only to understand the trial better, but also to help facilitate reaching out to the trial coordinator on your behalf. This is one way you can enroll in a trial. The following are a few other ways you can enroll. Once you have the trial location that you are interested in, you can seek a consult or a second opinion with the facility where the trial is being offered. For example, I recently helped a family who was interested in 2 different trials at the Cleveland Clinic, but they lived in New York. I suggested they make a virtual appointment with the clinic and helped facilitate communication with the doctor. The family was eventually able to discuss eligibility criteria and more information about the 2 trials they were interested in at that consult. If you want questions answered quickly, You could try calling the contact number for the clinical trial location you are interested in, found on clinicaltrials.gov. You can also utilize the services through the Brain Tumor Network and have a navigator start a conversation with the trial coordinator or research nurse. We can share details about your diagnosis and treatment goals with the trial coordinator to better understand if you would qualify. While clinicaltrials.gov has a list of inclusion and exclusion criteria, it is often necessary to talk or email with the trial site to find out more information on the screening process and the trial itself. We collect this information and make notes in our internal system for future patients that we assist. Having a list of questions ready when contacting the trial coordinator can be helpful in deciding on whether you want to participate in the trial or not. Each question will fly in with each click. Thank you, Emily. You heard some questions earlier, but here are a few more to consider when asking to gain a better understanding of participating in the trial. How many people have enrolled in this trial so far? Why is this treatment thought to be effective? What are some known possible side effects? Can the treatment be given close to my home? How many treatments will there be? How long will each take? Will the trial doctors communicate with my local care team? And what costs are covered by the trial sponsor? What will be my responsibility, and will my insurance cover those costs? There are wonderful resources available that we've listed here that can provide you with the valuable information on overcoming any obstacles to care. And if you'd like to get in touch with the Brain Tumor Network, here is our website and contact information. We offer ongoing navigation to adult primary brain tumor patients within the United States. We also serve as a source of information and referral to anyone with questions or interest in the brain tumor community. Tracy and I wanted to thank you for listening to our presentation today on patient navigation, and a thank you to the ABTA for our wonderful partnership. We are happy to engage in any questions at this time.
Thank you so much for your wonderful presentation. We will now take questions. As a reminder, if you have a question that you'd like to ask, please type and submit it using the Q&A button on the bottom of your control panel, and we'll answer as many questions as time allows. So one of the first questions we have here is asking, who is the right person to turn to for navigation support? Is there a difference between a nurse navigator and an oncology nurse navigator? Should patients be reaching out to one over the other?
It depends on the setting. And so, first of all, no, there's not necessarily a difference, because if you are in oncology and if you're in the neuro-oncology clinic and there is a nurse navigator there, they're going to be the oncology navigator. So we just use that tag to be descriptive. But if you are, often there are navigators divided up by disease. So there may be a breast cancer navigator, there may be a lung cancer navigator. Obviously, if you were receiving navigation at the center, you would receive that from the navigator that was appropriate for you. And at the Brain Tumor Network, we only navigate brain tumors. So if you were to utilize our organization, that's our focus. But the oncology and the neuro-oncology are just descriptive of what disease process you have.
Thank you for providing that clarification. Along the same lines, there's a lot of different titles that we hear. We hear patient navigator, nurse navigator, like we just talked about, social worker. Is there a difference in the type of support that a social worker would provide versus a nurse navigator?
So I'll start and then let Jenna add on if she wants to. So there is patient navigators guide patients through care, and we can guide them through different aspects of care. So for example, we have social work and nurse navigators. The nurse navigator would be the person to do more of the deep dive into the clinical trial search. They would provide you with medical information, and Jenna can speak more to what they do. And the social work navigator would focus more on your psychosocial needs, your emotional needs, connecting with the social worker at the center, connecting you with resources for support, transportation, finances. So it's kind of divided up that way. It's a little difficult to answer because in some settings, there can be a navigator who is doing multiple roles, and we kind of overlap a little bit. So I can see where it would be confusing, but that's how we differentiate at the Brain Tumor Network.
Yes, that was a great explanation, Tracy. We as nurses at the Brain Tumor Network, our primary focus is trying to get patients to the best care that they deserve. So if we do experience or understand that there's a need to bring in the social work navigator, we will do that. And it's nice that we can have this dual approach to care where we can treat the patient holistically, essentially.
That's great. Thank you both so much. Do all hospitals have a patient navigator?
No, not necessarily. And that's one of the things that we try to do as navigators with a nonprofit is to help people find out what resources are available in their brain cancer center where they're being treated or where they may be going for a clinical trial, and to tap into those resources as well. It's becoming more common, and many cancer centers do, but not every one. And then there are some that have, different workers, such as a chaplain or a social worker or a patient advocate who can fill in some of those gaps if there's not a navigator.
Thank you so much for sharing that. And I know that you mentioned that the Brain Tumor Network provides support for those in the US. Are you aware of any resources that are available to any of our attendees who might be tuning in from Canada or other countries? Would you be able to share any places that they might be able to turn to for this kind of support?
They can go to the IBTA. So that's where we go for a lot of those types of information. They have an extensive list for multiple countries on their website for resources in those areas. And so I know that I often refer to our brain bank. They have their founder, unfortunately, passed away earlier this year of a GBM, but she was from the UK and lived here in the United States in New York. And so they have a cross section of resources as well that they help patients with. So I think that obviously that's not our expertise, but I think that the IBTA is probably the best catch-all website to sort of start exploring. And certainly, we answer questions for international patients quite frequently to direct them send them in the right direction.
And the Brain Tumor Foundation of Canada has been a resource that I've reached out to when I have received patients from or caregivers from Canada looking for information.
Fantastic. Thank you both so much for those wonderful resources. Another question we have is, what resources or guidance can you provide for patients and families when they're trying to evaluate which provider is the right provider for them, or what institution is the best institution to get treatment from? What guidance can you provide for that? What are considerations they should keep in mind?
This is a great question. We usually provide them with questions about, is it a center of excellence? Do they have a multidisciplinary approach to care at these centers? Besides, doctor experience, how many years has the doctor been in practice? Do they focus on primary brain tumors? Questions like that. And then we obviously also take into consideration if somebody can travel. With COVID right now, we make sure that, that's something that we bring up to make sure if you're going to have care at a center that's, you need to fly to every 2 months for checkups. So yeah, I don't know if Tracy wants to add in anything.
I don't have much to add. I just think, as we kind of mentioned in the presentation, you really have to, it's one thing to find a trial on a piece of paper, and it's another to really consider it, and if it's right, and all of the things that go into it. And that's not said to say that to discourage you from looking into clinical trials, but also there's just a lot that goes into that decision that isn't just medical. It's also what's right for you and your family. What's the quality of life going to look like? What is this going to cost us? And we understand that, and just want to, you know, recognize that it's quite a process, and it's such a challenging time for you and your family. And there have been, I will say, there have been, since the pandemic, there's been some opening up of some additional resources as far as telehealth appointments and second opinions. So I'm not sure how long those are going to continue, but we have seen that.
Thank you both so much for answering these wonderful questions from our audience. Unfortunately, that is all the time that we have for questions for this session. I encourage you both to stay on and type responses to any of the questions that we weren't able to reach just yet. And I'll go ahead and turn it back to Emily, and we'll move on with the rest of the program. Thank you again.
Thank you so much, Tracy and Jenna, for sharing with us about patient navigation. The ABTA appreciates our partnership with the Brain Tumor Network because it allows us to expand and work together to achieve both our missions and visions. We will now proceed with our lunch session. We encourage you to listen in while enjoying your lunch for the unique opportunity to meet the ABTA Board of Directors and hear why they are involved with ABTA and passionate about the mission. Following this meet and greet session, you will have the chance to hear from our sponsors who have helped support this conference, sharing the resources they offer to patients. You will also hear from our researchers with important scientific updates. For those of you who need to take a break, please take this opportunity to do so. Stand up, stretch your legs, use the restroom, and we will see you after the lunch session at 1:05 p.m. Central Time for treatment resistance. Thank you, and we will now proceed with our Meet the Board session. Please welcome back Carla Varner, Chair of the ABTA Board of Directors.
Thank you, Emily. As Emily said, welcome to the Meet the ABTA Board of Directors session. I'm Carla Varner, the chair of the ABTA board. Thank you for joining this session, which is really designed to help you get to know us a little bit, understand a little bit more about what it is to be on the board of the ABTA. We're a group of volunteers who are responsible for the governance of the ABTA. We work very closely with our president and CEO, Ralph DeVito, who oversees the day-to-day leadership and management of the organization. And thank you all again for participating in this year's national conference. We really appreciate the support and hope you found it to be useful so far. In my day job, I am an in-house attorney for a financial services company in Chicago. I have two young children, Natalie, who is just starting third grade, she's 8, and Jack, who just turned 3. We also have a dog, Max, who, if you're really unfortunate, you will hear him during the session. Well, let's hope that he doesn't speak up. As for the ABTA board, there are currently 9 of us, hailing from various disciplines, be it law, medicine, human resources, marketing, branding, running companies. We really have a diverse group. And this allows us to bring multiple perspectives to the boardroom and the discussions that we have there, which I found to be very, very helpful, actually, and always interesting. Never a dull moment in board meetings, notwithstanding what you might hear about board meetings. I joined the ABTA board in 2014 after 2 close friends lost parents to brain tumors. So I've seen pretty close up the devastation caused by brain tumor diagnoses. As you're going to hear from the board members that are participating in today's session, the board has multiple committees focused on different aspects of the ABTA mission. As board chair, I participate in each of those committees and am able to learn a lot about all the different functions of the ABTA and different initiatives that we are pursuing in connection with those committee participations. So at this time, I want to ask each board member to introduce themselves and tell us why they're involved with the ABTA. And we're going to start with Ram Subramanian, the vice chair of the board. Ram?
Thank you, Carla, and hi, everyone. Again, as Carla said, my name is Ram Subramanian. I live here in the suburbs of Chicago with me, my wife, and 2 girls. I've, both me and my wife have been, in the last few years, been looking to give back more to the society. And my mother-in-law, my wife's mother, is actually a 29-year survivor who's still with us. She's turning 70 this year. And back in India, she was diagnosed with the tumor, and we have been very lucky to have her with us. So it's certainly certainly something very close to heart. And I got a chance to interact with the board in 2015, met with the leadership team back then, and was very impressed by just the level of commitment and passion that the staff and leadership had. And so really, it's an honor for me to get a chance to serve on the board. In terms of a little bit about me from my professional life, in my day job, actually, I'm a banking executive. I've been in the banking industry for several years. I currently am the chief marketing officer for the deposits business for Discover Financial Services. So again, that's a little bit about me, but now I'll pass it back over to you, Carla.
Thank you. Brandon, do you want to go next?
Sure. Thanks, Carla. It's nice to meet all of you. I'm Brandon Starkoff, currently secretary of the board. I've been a board member for 4 years now. And I'm actually a survivor. I was diagnosed 10 years ago this month with a grade 3 astrocytoma, which was kind of a surprise. At that point in time in my career, I was doing a lot of global traveling, and I had just had twins a year and a half just before being diagnosed. And as part of that, coming out of treatment, I spent a lot of time focusing on contributing back to organizations that were helping to address a lot of the growing list of questions that I had. And so I started my own fundraiser, and over the course of 7 years, we've raised over $300,000. And a lot of that money goes towards grants, obviously research grants that are really amazing people that come together and are able to sort of uncover solutions around treatment, post-treatment care, and ways to help, hopefully in the future, eradicate this disease. So I'm very excited to be part of this board. It's a great group of folks. I just actually went through a second round of treatment just because a little bit came back. We wanted to take care of that. So I just completed that, and I feel great. And on the side, I'm actually, I am a CEO of a marketing technology company. So lots of fun opportunities there. And I do what I can to certainly help the ABTA from a data technology standpoint and how we're getting better at understanding who you are as members and who our researchers are, so we can better address you and create more value for you. So that's my backstory. I do talk to brain cancer patients all the time, people that are just diagnosed, at least one a month. I'm more than happy to be here as a resource to help connect you with the ABTA, but also to help talk through the experience. So with that said, I'm going to hand it off to Bob Crutchin, who's our treasurer, and he does amazing work for the ABTA. So Bob, it's all in your hands now, buddy.
Thank you, Brandon. Hello, everyone. I'm Bob Crutchin. I have been around the ABTA as a volunteer since 1998. That was when we lost our best friend, Paul Fabry, and we started up a grassroots golf outing that we've been doing the last 24 years with all of the proceeds dedicated to the ABTA. We've raised about $800,000 in that period of time, and it's just such an honor and a thrill in being involved in that on a yearly basis. We just did our 24th annual about 3 weeks ago, and we're set for our 25th annual August 6th of 2022. As a result of the success and generosity that we've had from just family and friends and neighbors and people who never even knew Paul, my friend, Jeff Fougeroux, who actually had the idea to start our golf outing back in '98, he got involved directly with the ABTA and eventually became the board chair. He's now a alumni or a legacy board member. Jeff asked me to join when his term was ended, and I've been on the board as in the same class with Brandon for the last 4 years. And the reason I'm involved is multifaceted. This is the leading brain tumor organization really across the globe. We have fantastic partnerships. I was just listening in and have been in and out the last couple of days to the Brain Tumor Network, and we have the partnership with them and also many other organizations, including CB Trust, as you heard about yesterday. But I'm involved really to drive the quality of care, support caregivers and families that are going through the brain tumor battle right now. This is an incredibly daunting challenge, and we've been at it since 1973. And what we've been able to accomplish so far has been unprecedented. And we need, as Brandon said, we're all resources to everybody that's on this webinar right now. Anything that you need as far as connectivity to the ABTA, the resources that we have a couple of fantastic board members that are new to our board, Dr. Berger and Mr. Danny Monson, who you're going to hear from in a second. And all of us are dedicated in our personal lives, professionally, and certainly as philanthropists and getting involved with the ABTA directly to drive the research grants. I've had the pleasure of meeting many of our ABTA Alumni Research Network researchers and hear exactly where the money that is being raised is going towards. And all of these efforts, again, couldn't be accomplished without all of the generosity of all of you. And think about your circle of influence, people that you know, business leaders, friends, family, that you can get involved in supporting and driving the mission of the ABTA forward. As the treasurer, I work with our excellent Senior Director of Finance and Audit, Phil Samuels at the ABTA. And our mission is obviously to make sure from a financial perspective that the ABTA is solid today, but more importantly, builds and grows for the future. So with that, I want to say thank you for the opportunity to serve the ABTA board, and I'm passionate about what we do. We have a great group, and I want to turn this over now to Dr. Mitch Berger, who recently joined our board, and one of the leading specialists in the brain tumor field, and just delighted that he's joined our board. Dr. Berger?
Yeah, well, thanks, Bob, very much. And good morning, everyone. Actually, it's morning where I am on the West Coast. For those of you who don't know me, I'm a neurosurgeon. I was the chair of neurosurgery at UCSF for 23 years. I'm still full-time neurosurgeon. I'm director of the Brain Tumor Center, and actually spending more time now in the brain tumor arena, both in research and clinical trials, than I ever have been in the past. So it's wonderful. So I volunteered to be on this board, and I'll tell you why I did that, because I am living proof that the system that the ABTA set up works. So early in my career, when it's so difficult to get a research grant, I was very fortunate to get a grant from ABTA. I was working in the area of drug resistance in what we call alkyl transferase. You now know this as a patient as MGMT, and this was the beginning of that story. The ABTA grant allowed me to do high-risk research. I turned it into NIH funding, and I think the rest is really history. And I've encouraged many, many colleagues throughout the country to be involved with the ABTA in terms of applying for their grants. So I'm the only physician surgeon on the board, and that's a real honor for me. And I think, again, the reason I wanted to do this is I wanted to give back to the ABTA, because without them, I would not have had the great career that I have had in terms of carving out new technologies, methods, research agendas for the brain tumor community. So I wanted to give back, and I think I can help them understand the perspective, having been on President Biden's Blue Ribbon Moonshot panel. I'm still on that. I really understand where things are going and where the opportunities are in the cancer research field. So I find the board members to be extremely patient with my thoughts. They embrace some of them and they know when to say no about others, but it's just been really delightful for me to get to know them. I've had many other capacities in the ABTA. I've served on the scientific advisory board. I've reviewed grants throughout the years. I've participated in many patient conferences. In fact, it's probably one of the few times I've missed many of my flights going from Chicago back to San Francisco, staying in line until the last person came forward, because I really enjoy the rewarding experience of talking to patients, understanding the trials and tribulations they're going through along with their family members. It makes me a better caring physician. So I enjoy being part of those conferences. I'm glad to be here saying a few words now. And again, I want to thank the ABTA for allowing me to participate on their board, and I look forward to many years of serving in whatever capacity you wish me to serve in. So thank you very much. And I think I'll turn it over to Danny. Are you the next person up, or is it Jim?
Either one. Danny?
Good morning or good afternoon. Thanks, Mitch. My name's Danny Munson. I am from Southern California. My day job, if you will, I'm the CEO of my family's logistics company, States Logistics Services. I have a wife, Jennifer, 3 daughters, Julia, Katie, and Emily. I became aware of the ABTA back in 2017. Our daughter, Katie, was diagnosed with a glioblastoma. And so we became aware of the brain tumor community a little bit at that point. Katie passed away in September of 2018. Before she had done that, though, she had set up a foundation, the KM Legacy Foundation. And the purpose of that foundation is to promote brain cancer awareness and research. And so I reached out to the ABTA and got to know Kelly Sitkin and Ralph DeVito. They actually came out and visited me here in California, and we were able to put together something a little bit unique. I wanted to take one of my company's trucks and kind of wrap it with some decals and information about how we can promote brain cancer awareness. And obviously that truck is out on the highways here in Southern California 7 days a week, and thought that'd be a great opportunity. And they jumped right on board, and we were able to put that together. And so through that, just the relationship that we've developed, was pleasantly surprised. Ralph asked me to become part of the board as well. So this is my first year on the board, along with Mitch. I participate on the mission committee and the development committee. I've also been helping on the BT 5K West committee as far as the planning for the walk here in the LA area for the past few years as well. It's a pleasure. I'm very excited to be part of the ABTA board. As several people have already mentioned, we have a great group on the board, very diverse backgrounds and experiences, and just excited to be part of that group. Obviously, my passion is to also promote awareness for brain tumors and fund research, and God willing, find some cure for these insidious brain tumor diseases in the future. And I definitely am super excited about that, and very, very proud to be part of the organization in this capacity. So again, thank you to the ABTA for allowing me to be part of that. Thank you for including us today in this virtual presentation. Hopefully in the future we can do this in person. But at this point, I think I'll turn it over to our last board member, which has been Mindy. Is that correct?
It's actually Jim Riley.
Jim, I'll pass it over to you.
Thanks, Danny.
Thank you very much, Danny. Jim Riley. I've been on the board since 2014. I'm currently the Chief Human Resource Officer for Winco Foods. The reason I joined the board was because both my mother and mother-in-law both had brain tumors. My mother-in-law unfortunately passed away from a glioblastoma, and my mother had a meningioma who did survive and went on to live a healthy life afterwards. What I love about the board, quite frankly, is events like this. It's the integration of both patients, caregivers, and professionals within the healthcare community with expertise in brain tumors. So I'm really excited that everyone who's attending this conference hopefully will take away a great and phenomenal learning experience. I'm part of the Governance and Nominating Committee, and we are responsible for basically the recruiting and selection of new board members, such as Danny and Mitch. So I'm very grateful and humbled to be part of this board, and I'll turn it back over to Carla. Thank you.
Thank you, Jim. Our two other board members, Mindy Plugy and Jacqueline Lemke, were not able to make it today, but hopefully you have enjoyed hearing from those of us who have been able to participate. Thank you to each of you who were able to participate, board members. We really appreciate your participation today and your inputs every day. It's really so important to the organization, and we very much value your leadership and service to the mission of the ABTA. For those of you attending the conference, I want to thank each of you again for joining us. The ABTA welcomes those of you who want to become more involved with the organization and its mission to visit our website, www.abta.org. On our website, you can find ways to get involved, be it volunteering, fundraising events, joining our peer mentorship program, which actually pairs brain tumor patients and caregivers with peer mentors who have been through a similar situation. Or, you could just simply share your story and let others know that they are not alone on this brain tumor journey. Many of the ways you can get involved can be done virtually, as evidenced by today's and yesterday's, annual conference, which is awesome. I personally think it's great. Allows more people to participate. When it is safe to do so, we will resume in-person programs. If you are in need of further information, you can always call the ABTI care line. That's 1-800-886-ABTA, 1-800-886-2282. Our caring staff will provide information, assistance, and resources. Thank you again. Enjoy the rest of the conference and your lunch.
Thank you so much, ABTA Board of Directors. We really appreciate your leadership. Up next is a video highlighting the low-grade glioma registry developed by Dr. Elizabeth Claus from Brigham and Women's Hospital, Harvard Medical School. The ABTA provides research funding to this registry to assist in determining inherited and non-inherited genetic variants that may be associated with increased risk of low-grade gliomas. Enjoy the video. After, you will hear from the rest of our researchers and sponsors. Thank you.
Greetings, this is Dr. Elizabeth Claus. I'm a professor in the Yale School of Public Health, as well as an attending neurosurgeon at Brigham and Women's Hospital in Boston. I'm here to talk to you a little bit today about the International Low-Grade Glioma Registry. We're very thankful to the American Brain Tumor Association for all their support towards the registry, as well as allowing us to present some results and an exciting new development for the registry. As you know, there are many gaps in the understanding of glioma, particularly for low-grade glioma, which affects over 30,000 adults in the United States, and that's our overall goal in developing this registry. Who's eligible? There have been a number of changes recently with the World Health Organization revising its central nervous system pathology guidelines for central nervous system tumors, but we'll be including individuals who are initially diagnosed with grade 2 or 3 low-grade glioma, regardless of whether they go on to have a higher grade. This would typically include patients with oligodendroglioma, astrocytoma, or one of the older used terms, mixed glioma. Patients should be 21 to 79 years at entry, but we don't have any restrictions with respect to sex, gender, race, date of diagnosis, or place of residence. The things we ask for are a pathology report, as well as permission to obtain a blood or saliva sample and a tumor sample from each of your surgeries. We also ask for an online questionnaire to be completed, which will ask for information about your medical and family history, treatments, and your residential and occupational history. And to give thanks where thanks is due, we would like to thank again the American Brain Tumor Association. This is where it all started, at the same meeting that you're currently participating in 5 years ago, where we began registration with our first group of patients. So we would like to thank these patients, as well as all the patients that have joined us over time, It was this preliminary data that allowed us to write a larger grant to NIH to receive funding to do these additional exciting analyses. We have over 400 patients to date from 21 states and 16 countries. We were shut down for about a year secondary to COVID, but we're back up and running. Our exciting new development is that we're now a participant engagement and cancer genome sequencing center. Our focus is low-grade glioma. These are our partners in this effort: Yale, Mass General Brigham, Jackson Laboratory in Farmington, Connecticut, as well as University of Colorado and Beth Israel Deaconess Medical Center. The new project is called Optimum, which stands for Optimizing Engagement in Discovery of Molecular Evolution of Low-Grade Glioma. And so essentially what we're trying to do is to build a cohort of 500 patients initially diagnosed with low-grade glioma and who have recurred, so that have had 2 or more surgeries. And the overall goal is to look at the genetics of the first and later surgeries to see what has changed, what has not changed, how treatment affects these changes, and how outcome is affected, in the hope that we can develop more effective therapies for low-grade glioma. We also hope to better engage patients. We've been able to have Liz Salmi, who many of you probably know, a patient researcher. She's going to join us as a co-investigator on the study to help us partner with patients. And we actually are hoping to develop a patient stakeholder advisory group. So for those of you that are interested, please contact us. We have some new software called Hugo, which allows us to better access patients' medical records, including pharmacy and imaging data, and will make things easier for patients to join us. It also lets us, with patient permission, get data from any devices or sensors such as a Fitbit or Apple phone. We hope to develop a new clinical trial app to make access to this information easier for patients and their providers. So how do you join the study? You can contact us at glioma@yale.edu or register through the Mass General Brigham website, Rally for Partners. We've got the direct website here. The links are also available at the ABTA and other patient organizations. You can search for us on the web or use this code. And again, we thank you for those who have already participated and hope that many of you will be interested in joining us, or at least contacting us to hear more. Thanks so much.
Hello, my name is Roger Stoop. I'm an oncologist specialized in brain and spine tumors, leading the Northwestern Medicine brain tumor team. With locations in Chicago, the western and the northern suburbs, Northwestern Medicine's elite patient-centered brain tumor program offers the highest quality, compassionate and innovative treatment for patients in Chicagoland, the Midwest and beyond. The caliber of our program is reflected by the top 5 ranking of Northwestern Memorial Hospital for neurosciences and neurosurgery by US News and World Report, and the highest possible ranking, exceptional, received by the Robert H. Lurie Comprehensive Cancer Center from the National Cancer Institute. Today, members of Northwestern Brain Tumor Team will talk with you about Courtney, a 38-year-old mother.
Courtney's husband brought her to the emergency room after she had a seizure. An MRI revealed a lemon-sized mass in her right brain, and I saw her in the clinic the day after she was discharged from the emergency department. Prior to her appointment, I had reviewed the imaging with our expert neuroradiologists.
Neuroradiology is a subspecialty that focuses on the diagnosis and characterization of abnormalities of the brain and spine using neuroimaging techniques. Dr. Lucas shared Courtney's case with me, and we reviewed her MRI together. Based on her MRI, I suspected a low-grade glioma.
When I met Courtney, I explained the suspected diagnosis and the next steps to be considered. I suggested that she meet with one of our neurosurgeons that day to discuss surgical options. Because our multidisciplinary team is co-located, we just had to go across the hall for Courtney to meet with Dr. Lesniak.
We felt that awake surgery would allow for maximum safe tumor resection, while ensuring the surgery would not impact Courtney's functional ability like speech and memory. Courtney did very well in the surgery and left the hospital after only 2 days. The resected tumor tissue was then analyzed in detail by our expert neuropathologist at the Lurie Cancer Center for state-of-the-art tissue and molecular diagnosis, which is important for guiding post-surgical treatment.
The Neuropathology Division at Northwestern Medicine is a world leader in brain tumor diagnosis, including the use of next-generation sequencing. These new technologies allow us to classify tumors more precisely and to understand their genetic makeup, since tumors with certain genetic markers will respond better or worse to different treatments. Pathology is a critical tool in our arsenal against brain cancer.
Days later, with Courtney's full pathology and molecular results, the whole team reviewed her case in one of our 2 weekly brain tumor boards. These meetings are attended by Northwestern brain tumor experts in the fields of neurosurgery, neuro-oncology, radiation oncology, neuroradiology, and neuropathology. This team also includes nurses, nurse practitioners, social workers, and cancer genetics counselors. Various treatment options are considered and discussed before coming up with a personalized recommendation.
We discussed her case at the Multidisciplinary Tumor Board, and it was decided that she would benefit from radiation therapy. There are several radiation therapy techniques used for the treatment of brain tumors, including regular fractionated external radiation therapy with X-rays or protons, gamma knife radiosurgery, and fractionated stereotactic radiation therapy. The indications for these different treatments are mainly based on the type of brain tumor on pathology and genetic testing.
The consensus recommendation from Tumor Board was to treat Courtney with proton therapy. Proton therapy is an advanced form of radiotherapy that treats tumors with a precise dose of radiotherapy that conforms to the shape of the tumor with the goal of reducing the risk of side effects and damage to surrounding healthy tissues. This treatment is being studied for patients with Courtney's tumor type, so we proposed she enroll in this clinical trial. After a detailed discussion of the trial rationale, she elected to participate and is now receiving proton therapy at the Northwestern Medicine Proton Center, which is the only proton center in Illinois and one of only 29 facilities in the U.S.
Through Courtney's care, I served as the dedicated social worker to her and her family. So much of brain tumor care is dependent on the patient and their caregivers having resources, guidance, and support. In Courtney's case, she elected to join one of Northwestern Medicine's monthly support groups. At Northwestern, we understand how difficult and frightening a brain tumor diagnosis can be for the patient and their family. We are dedicated to being there medically, physically, and emotionally every step of the way.
Ultimately, Courtney has had an incredible response to treatment. She was rapidly diagnosed and treated and is now doing very well and living a high quality of life with her family. All of us at the Northwestern brain tumor community are committed to advancing the understanding, diagnosis, treatment, and prevention of brain and spine tumors. We achieve this through innovation and scientific discovery, while providing expert, state-of-the-art and cutting-edge treatment, compassionate care, and support to both patients and caregivers.
We're a group of clinicians, scientists, and community advocates working together to find a cure for brain tumors.
We've got the dream team, and it is a multidisciplinary team working together to make the next breakthrough in terms of the diagnosis and treatment of brain tumors.
Hello, my name is Maria Belén Garcia Fabiani. In 2019, I received the ABTA Basic Research Fellowship in memory of Bruce and Brian Jackson, and the title of my presentation is Impact of H3G34R Mutation in Reprogramming the Glioma in Immune Microenvironment. This project was done at the University of Michigan Medical School, specifically at Dr. Maria Castro's lab, and I was a postdoc there for 4 years, living in Ann Arbor, which is a very nice city. So let me make a brief introduction about pediatric high-grade gliomas. This type of tumor are the second most common malignancy of childhood after acute leukemia. Today, the standard of care is surgery plus radiation and chemotherapy, but with dismal outcomes with median survival of 9 to 15 months. Recently, some studies show that pediatric high-grade gliomas have key characteristics that distinguish them from the adult disease, and these are associated to genetic mutations and epigenetic changes. So what is epigenetics? Most of us are familiarized with genetic mutations, which produce changes on the DNA, and those changes translates into abnormal proteins usually, and those proteins usually bring problems to those cells. On the other hand, epigenetic modifications do not change the genetic code, and when we talk about epigenetics plus the DNA molecule, we are talking about the epigenome. The DNA is wrapped around histone proteins, which are these yellow circles, and how that structure is compacted or not will determine if gene expression is activated or repressed. An easy-to-read DNA sequence will be open, and the gene expression will be activated. A compacted DNA sequence will have a repressed gene expression, and the epigenetic cares about these dynamics in the DNA structure. The pediatric high-grade glioma that I study in this project is a tumor that has a mutation on one of these histone protein, a mutation that is called G34R. This type of tumor is found in adolescents, and the standard of care is the same that we mentioned at the beginning. The survival for these patients is 18 months, and there's been some new therapies under study in the last years that aim to harness the immune response, the immune system against these tumor cells, and these therapies are called immunotherapies. Brain tumors are not isolated entities in the central nervous system, and they are surrounded by brain cells and by immune cells. Usually when we think about the immune system, we imagine the immune system fighting infection, but the immune system also monitors for the appearance of cancerous cells. But these cancerous cells have mechanisms to evade immune response, and that usually leads to cancer progression. The hypothesis of our project was that the tumor microenvironment of a specific type of pediatric high-grade glioma is permissive for the application of immune-related therapies aimed at stimulating the anti-tumor immune response. We were able to successfully consolidate an in vivo mouse model for this type of tumor, and we were also able to study the immune response mounted against this tumor. We observed that these tumors were prone to be treated with immunotherapies. Also, we went deeper into study the mechanisms behind this immune response, and we observed that the G34R mutation was involved in this immune response, and we went further to test the efficacy of immune stimulatory gene therapy to treat these tumors. We applied this gene therapy in those animals with the G34R tumors, and we observed that this gene therapy successfully improved survival, and mice developed immunological memory against these tumors. So to conclude, we were able to test a gene therapy at the lab that successfully improved the survival of animals harboring brain tumors with G34R mutations by the activation of the immune system. This therapy has the potential to be translated into a clinical setting to treat children or adolescents with this type of tumor. And we also developed a mouse model for this tumor that could be used as a tool for future studies. Thank you so much for your attention.
Hello, everyone. My name is Albert Kim. Today, I'm excited to present some of my research about brain metastases. So a little bit about me. I recently completed my neuro-oncology fellowship at the Dana-Farber and Mass General Hospital, and just joined the staff here at the MGH Cancer Center, where I treat patients with brain tumors. When I was a first-year fellow, I was lucky enough to receive the Basic Research Fellowship, which gave me protected time to explore some of the work that I'll talk about today. I'd also like to express my appreciation to the ABTA and the family of Paul Fabry for investing in my career, which has led to my current faculty position as a physician scientist for brain tumors. Brain metastases are the most common brain tumor. The yearly incidence is about 100 to 150,000 in the United States. This number is rising as patients with systemic cancers are living longer with more effective treatments. Once they spread to the brain, the prognosis is poor, in large part due to relatively few systemic treatments with durable efficacy. Over the last year, I had the opportunity to work with the ABTA to analyze results from a survey from brain met patients, caregivers, and physicians about physician practice patterns, quality of life metrics, and how best to move the field forward. Some of the interesting findings was first, a variability in physician practice patterns. This wasn't terribly surprising given a rapidly evolving standard of care. Here we know that patients seen by private practice physicians are more likely to have whole brain radiation recommended to them compared to academic physicians, which has implications in neurotoxicity. Second, we noted that clinical trials, which is an important step to developing new treatments, are frequently not an option for brain met patients, as only 20% of patients had that recommended to them. This paper was recently published earlier this month in Neuro-Oncology Practice, and if interested, I'd encourage you to check it out. One of the challenges facing brain mets treatment is the fact that brain metastases are functionally divergent from that of the primary tumor or extracranial metastases. In a seminal study published by my mentor, Priscilla Brastianos, more than half of brain metastases had unique targetable mutations not detected in the paired primary tumor or extracranial metastasis. And so what this emphasizes is a need for brain met tissue sampling to accurately guide CNS-directed treatment. The next question we asked is, if oncogenic drivers were detected in the brain met, would targeting these be effective? And so to test this hypothesis, we planned a trial in which patients with brain metastases and a CDK pathway alteration were treated with palbociclib, which is a CNS penetrant CDK inhibitor. 15 patients were enrolled of multiple different histologies, and 8 of them had intracranial benefit at 8 weeks after initiation of palbociclib. The median overall survival for the entire cohort was 6.4 months, which compares favorably to the historical standard, and 3 patients were still alive at the time of publications after almost more than 2 years after they started treatment. And the median time to progression for these 8 patients with benefit was 6.5 months, suggesting that this treatment was reasonably durable. But while precision medicine approaches for brain metastases have demonstrated impressive responses, in clinical practice, a lot of patients aren't able to benefit from this, as this ultimately requires a brain biopsy. And so what this underscores is a need for non-invasive biomarkers. So we then asked, could liquid biopsies help? So in addition to sequencing the primary tumor in the brain met, we also sequenced cell-free DNA from the serum and CSF. And what the CSF is fluid that bathes the brain and spinal cord that's generally obtained by a spinal tap. On our genomic analysis, we essentially found here that the CSF cell-free DNA more closely mirrors the brain met genome than does the plasma cell-free DNA or the primary tumor. Here's another a molecular analysis of CSF cell-free DNA taken at the time of brain met resection that revealed a targetable mutation. This patient later went on to our palbociclib trial and did quite well. And so with that, I'd like to close. The work I do is multidisciplinary, and so I have a lot of people to thank. I especially want to thank my mentors, Priscilla Brastianos, Elizabeth Gerstner, and Jayshree Kalpathy Kramer, as well as all of my colleagues and friends pictured here that's helped in brainstorming and data analysis.
Hello, my name is Intrinsic, and I'm a research associate in the Adrian Bohr Lab at Memorial Sloan Kettering. I'm a recipient of 2019 ABTA Basic Research Fellowship, which is supported by an anonymous corporate partner. The primary focus of our research is leptomeningeal metastasis, which can be characterized as a spread of cancer cells into the cerebral spinal fluid or between the sheets that are covering the brain. On the magnetic resonance image, we can see this disease as these white plaques on the surface of the brain. cerebellum, or pons. And the three major types that are contributing to this small disease is breast cancer, lung cancer, and melanoma that easily spreads into leptomeninges. What's particularly bleak about this disease is the overall survival, which is for most patients measured in a couple of months. Thanks to the support from ABTA, we were able to show that even in the presence of cancer in the leptomeninges, the cerebrospinal fluid is being filled by lots of immune cells, or cells that are under normal circumstances able to fight cancer or pathogens. And you can see here that they are really overrepresented in this space compared to the cancer. We used our preclinical models to show that cancer cells in this environment are able to steal iron from the immune cells. And when we use a targeted approach to then steal the iron from the environment overall, we're able to control the growth of the disease, as you can see, in comparison to mice that are treated with just vehicle without any drug. And we're able to prolong their survival if we use this preclinical strategy. And this strategy is currently being pursued into phase 1A/B clinical trial, and we are pending FDA approval since there's no targeted therapy for this disease at all. This study was done in a model in which we introduced human cells into mice that don't have functional immune system, so human cancer cells can grow in them. But to be able to fully model the disease with the interactions of immune system as they are, we developed mouse models in which we use mouse cancer cells in the mouse organism to have all the cells that are necessary for these interactions. Using this strategy, we showed that interferon gamma, a cytokine that is putting immune cells into the action, is able to control the growth of cancer cells. As you can see, the decrease here in blue, and also is able to improve the survival of these mice, again, shown in blue lines. And this manuscript is currently under preparation for submission. In the last year and a half, we were experiencing COVID-19 pandemic, which meant for us that we were admitting patients with severe COVID-19 symptoms also in their brain. Now, these patients had fallen into delirium or coma, and we were interested in what's happening in them. So we profiled their cerebrospinal fluid, compared them to the controls, and we found out that they have extremely increased levels of some anti-inflammatory, of some inflammatory mediators that are able to damage the brain. Half of this cohort of patients were harboring parenchymal metastasis or leptomeningeal metastasis into the brain. And we proposed that we can use dexamethasone, a commonly used anti-inflammatory drug, to suppress these symptoms. Thank you so much for your attention, and thank you so much for your support.
Hello, my name is Dr. Jaden Shaw. I'm the Executive Vice President and Chief Medical Officer at Karyopharm Therapeutics. Karyopharm is proud to be a sponsor of the American Brain Tumor Association National Conference and proud to sponsor ongoing research in GBM. Karyopharm is a small pharmaceutical company based outside of Boston, Massachusetts, started in 2008 by our founder and Chief Scientific Officer, Sharon Chackham. We've been focused exclusively on developing selective inhibitors of nuclear export, and specifically a drug named selinexor. This is an oral therapy that's given once or twice a week. We were recently granted approval for this drug for patients with 2 different types of blood cancers, including myeloma and diffuse large B-cell lymphoma in 2019 and 2020. As you can see in this slide here, there's lots of ongoing research that we have right now with selinexor, both in various blood cancers, including myeloma and lymphoma, as well as various solid tumors, including in patients with sarcoma, endometrial cancer, other solid tumors, as well as GBM, which we'll be focused on today. How does selinexor work? So selinexor specifically and selectively inhibits XPO1. And XPO1 is a protein that shuttles tumor suppressor proteins from the nucleus to the cytoplasm. These tumor suppressor proteins should be inside of the nucleus where they'll normally be activated and where they function to suppress tumors. Now, cancer cells will overexpress XPO1, and they do this to bypass the mechanisms of tumor suppressor proteins. So when they overexpress XPO1, then these cancer cells will shuttle these tumor suppressor proteins into the cytoplasm where they're no longer active. So by inhibiting XPO1, which selinexor does, it leads to the nuclear localization of these tumor suppressor proteins. So these proteins then live inside the nucleus where they can function and kill cancer cells. Importantly, selinexor also combines very nicely with radiation therapy and temozolomide, which are two commonly used treatment modalities in patients with GBM. In our initial experience with selinexor in GBM, in recurrent GBM, we learned two very important things from this KING study. Number one, we know that selinexor crosses the blood-brain barrier and then gets into the space around the brain where it's important where it can actually work for patients with GBM. And we showed in patients with GBM, that selinexor does have single-agent activity. We saw patients with both a partial remission as well as a complete remission for those patients with relapsed GBM. Based on that, we've launched this new study called Export GBM.29. In this study, we're adding selinexor into the current standard of care. So whatever you'd otherwise get as a standard of care, we're adding selinexor on to see if it improves it. For example, in patients with newly diagnosed GBM, we'll add it either to radiation or a combination of radiation and temozolomide based on if your disease has MGMT methylation status. And importantly, for patients, unfortunately, with recurrent GBM, we're combining with lomustine, which is another important standard of care, to see if we can improve outcomes with a combination therapy. This trial is currently open now and enrolling at these various centers that you see here, and more centers to come soon. Our contact information is here for any questions or information. Thank you so much for your attention.
Living with serious illness is hard enough. When financial pressures hit, it can feel impossible to live a full and enriching life. But what if you had funds to use right now? Fifth Season Financial can help. Our Funds for Living program provides funds for living to use today and funds to help your loved ones in the future, all by accessing something you already own, your life insurance. Fifth Season can advance you money based on the value of your life insurance policy. Face value of $100,000. If you qualify, you can receive up to a $60,000 Funds for Living advance. But unlike a traditional loan, you don't pay back the advance or fees during your lifetime. Instead, everything is repaid later from the proceeds of your life insurance. The funds remaining in your policy go to your beneficiaries after you're gone. There are no restrictions on how you can use Funds for Living funds. There are no fees to apply. Contact us today to learn more.
Going through cancer treatment can be an overwhelming experience. There's new information to take in, important decisions to be made, and logistics to manage. You're often on your own to find the support you need to tackle all of these new challenges. Navio helps you manage your care with confidence. Our personalized care management app is based on your doctor's treatment plan, combining your specific schedule with helpful tools to keep you informed and on track with your care. You'll find a range of resources at your fingertips, including information about what to expect, answers to common questions, and links to trusted organizations. Your treatment calendar is automatically set up with your medication schedule, lab work, and appointments, along with timely reminders. And you can keep track of medications as you take them with your medication checklist. With Navio, you can feel more informed, confident, and in control of your care. Hi, this is Erin from Navio. If you or someone you know is going through cancer treatment and could benefit from Navio, you can learn more and sign up at get.navio.com. Also, our team is always trying to learn from people who've been through the cancer journey, so if you're interested in being a patient or caregiver advisor, you can reach out to me. You can email me at erin@navio.com. Thanks and take care.
Hi, I'm Dr. Ricky Wong, neurosurgeon and director of skull base and pituitary surgery at North Shore Neurological Institute near Chicago. As a longtime sponsor of the Patient and Family Conference, North Shore appreciates all ABTA does to help brain tumor survivors take control of their health, and we are passionate about playing a role in it. Our multidisciplinary team believes in a personalized treatment plan that includes both the patient and their family in the decision-making process. Options may include immunotherapy, clinical trials, or minimally invasive surgery. North Shore utilizes some of the most advanced technologies for brain tumors. My expertise includes performing brain mapping, the endoscopic endonasal procedure, and the minimally invasive keyhole surgical approach. They all reach difficult to access areas of the brain, focusing on survivorship and maximizing quality of life. To learn more, visit northshore.org/neuro. Thank you.
Our brain and nervous system are central to what makes us human. Tumor biology is exceedingly complex, and when brain cancer strikes, the impact is devastating, often life-threatening. For 25 years, our members have been unraveling the mysteries of nervous system tumors. We're a diverse community of scientists and clinicians at the leading edge of cancer medicine, working to fight tumors affecting the nervous system. Our members collaborate across disciplines from every corner of the world, pioneering bold advances in science, including new treatment options, personalized medicine, and precision oncology. Our highly regarded journals and scientific conferences provide an important platform for communication and exchange. We foster collaborative research and support the professional development of young scientists. We've improved the quality of life for our patients. Modern treatment options are less toxic with fewer side effects. Patients are living longer, healthier lives. But what lies ahead? Our discoveries have led to great advances, but there's so much we don't know. With passion and curiosity, we're compelled to move forward, to gain deeper scientific insights, to make extraordinary medical breakthroughs, to improve treatments for our patients, to realize a world where tumors of the nervous system have been eradicated.
The best care for most patients with cancer is multidisciplinary care.
We have all of the people in place here to really care from patients start to finish.
We have radiation oncology specialists, neuro-oncology, general oncology people who are very subspecialized in cancer treatment.
We have the advantage of clinical trials of every modality available to treat brain tumors that are not readily available nationwide.
The radiotherapy delivery devices that exist here are not replicated anywhere else in the world.
We have the best-in-class neurosurgeons, the most innovative surgical options, and the best radiation modality options. That's how we advance care. That's how we make scientific progress. We try to make sure at Miami Cancer Institute that we have a trial for everyone who walks through our doors.
Over 23,000 people will be diagnosed with a brain tumor this year, with glioblastoma being the most serious.
Gliolan is an oral solution the patient drinks prior to surgery that helps the neurosurgeon locate the brain tumor under the blue light filter on the surgical microscope, where the malignant tissue fluoresces a red-violet color while normal brain tissue appears blue.
So surgical removal of the worst part of a glioblastoma, which is also referred to as a contrast-enhancing tumor, can lead to longer patient survival. So that's what we try to do with surgery, but we also want to preserve function. And so when the tumor is close to important areas, that may limit what we can do. But to remove all of the worst part of the tumor, we need to be able to see where the edges of that tumor are active. Gliolan is the name of a substance called 5-aminoalevulinic acid, or 5-ALA, which is converted by tumor cells into another substance that glows red when we shine a blue light on it. While all cells in the body can convert 5-ALA to the fluorescent molecule, tumor cells seem to do it much, much faster and much more avidly. And so when we give 5-ALA to a patient who has a glioblastoma, during the surgery, we shine a blue light on the tumor. We can see it glow red, and that helps us to distinguish what is tumor from what is normal brain.
There are currently over 700 surgeons trained on the use of Gliolan in almost 250 centers in the US, with over 80,000 patients benefiting from the advanced solution worldwide.
Find out more by visiting glioland.com.
Welcome back to our afternoon session. We hope you took advantage of our lunch session to meet our ABTA Board of Directors and hear from our sponsors and researchers. Our co-chair, Sean Hervey-Jumper, will introduce our next speakers.
Good afternoon. This has been a great morning so far. So if we think through what we've done so far over the last day and a half, we've gone through knowing your tumor and establishing a diagnosis. We've gone through surgical considerations. We've gone through chemotherapy considerations, even clinical trial considerations and how to navigate clinical trials and get through clinical trials and those advanced therapeutic options. But we're left with this all too common event that happens called treatment resistance. What happens when these treatments don't work or stop working, and what are some considerations? So this next session is called tumor resistance to drug treatment, and what are some strategies to overcome them. And we brought two experts in this area. They're really amazing folks. Our lectures will come on treatment resistance by Dr. Ranjit Bindra, who's a radiation oncologist and co-director of the Yale Brain Tumor Center. He is also a rock star, literally and figuratively, in the field, both within our field as a physician scientist, as well as a gifted drummer. He, in fact, has been a drummer since the age of 5, and he continues in a band to this day. Second, after him, we'll have Dr. Nancy Ann Bush, who is the clinical director of neuro-oncology at University of California, San Francisco. And she's a close friend of many folks here, including myself. And as you know, she is an amazing communicator through the tumor board that we had yesterday. And she may, in fact, be the most interesting person that I've ever met, with a range of loves and interests, from hiking, outdoors activities, sailing, living off grid, Division I tennis player. She's just an amazing person. And more than anything, she is a devoted patient advocate and amazing neuro-oncologist. So this session is going to include two speakers. We'll begin with Dr. Bindra, who will focus on kind of more the mechanistic aspects of treatment resistance. And then Dr. Nancy Ann Bush will then segue and build on that with delving a little deeper into concepts of what this means for therapies moving forward. So with that, I'll hand this over to our amazing speakers.
Wonderful. Can you hear me, Sean? Okay. Thumbs up.
You're perfect.
Excellent. Wonderful. Thank you so much for the kind introduction, and really excited. I will say that science and medicine is a lot like rock and roll. It's about making albums and going on tour, and so it's really exciting to be here today. So I'm going to go ahead and get my talk started off. Let me just make sure I have my controls okay. Just give me 1 moment. Okay. First, just my disclosures, which are shown here. We are interested in developing brain tumor therapeutics, not only in the academic setting, but also in the biotech pharma setting, just to get drugs faster to our patients. And what I'll do is start off today with a couple of topics. First, how does chemotherapy work against brain tumors? Why is temozolomide so effective against gliomas with MGMT silencing, a biomarker that I'm sure many of you are aware of? How do gliomas become resistant to drugs like temozolomide? And finally, we'll just end with, are there treatments for patients that ultimately develop TMZ resistance? So first, just some key background concepts for this section. So one of the most important things to realize is that DNA damage occurs very frequently in everyday life, just going out in the sun, things like inflammation, if you're exposed to smoke or air pollution, all of these things lead to damage to the DNA, okay? And because of that, our cells, because of that, our cells have overall evolved very sophisticated mechanisms to overcome or to address that type of DNA damage. And you can see here at the top, the DNA damaging agents, just as an example, are shown here, everything from radiation therapy to UV light. All those induce very specific types of DNA damage, and those are repaired by very specific pathways that are shown on the very bottom. And we'll cover some of those pathways because they're relevant to the chemotherapies that we often give our patients. So how does chemotherapy work? So cancer cells typically are more rapidly dividing than normal cells, and the chemotherapy's job is to kill those rapidly dividing cells, and that creates damage in the DNA that prevents those cells from growing. Two key factors to consider here are the type of DNA damage that's induced by the agent, and also the status of those DNA repair pathways that I mentioned earlier, which are very important in understanding the response to therapy. So why is temozolomide so effective against gliomas? As many of you know, we've used this drug for many, many years, probably over 30 or 35 years or so. And just some key points to take home today. One is that temozolomide induces damage directly on the DNA bases, a very specific type of damage called O6-methylguanine. It's just a way that the temozolomide deposits a very specific lesion in the base of the DNA. And MGMT, which is a gene, again, we'll spend some time on today, is called methylguanine methyltransferase. And that's really just a DNA repair gene that is really good at taking off that O6-methylguanine lesion. That damage, if unrepaired, causes a number of things in the cells. One thing that happens is something called DNA mismatches, which ultimately prevents the cell from adequately replicating and eventually kills that tumor cell, okay? And clinically, we know that this is very important. As many of you likely are aware of the STOOP trial back in the early 2000s, that trial showed that if you give patients surgery and radiation, and if you test adding concurrent or simultaneous temozolomide followed by adjuvant or after the radiation therapy temozolomide, that increases survival for those patients. So this is a very important drug in our cancer clinic, specifically in the brain tumor clinic. Just to move to the next slide, sorry, there's a little bit of a lag on my side. So the question is, why is temozolomide so effective against gliomas with MGMT silencing? Often you'll hear on that, you'll look on that report and you'll hear about this biomarker MGMT promoter methylated or unmethylated. And this can actually be quite confusing to patients, and we spend a lot of time explaining to it, and our lab actually spends a lot of time researching it. So the MGMT gene is silenced, or also referred to as methylated, frequently in glioma. In tumors where MGMT is unmethylated, it simply means that that MGMT protein, the gene or the protein, is expressed in that tumor. And if you give the patient temozolomide, the temozolomide hits the tumor, but is able to repair the damage from the temozolomide. Often we hope that patients have MGMT methylation on their report, because that means that the MGMT is actually silenced or not expressed in the cell. And now we know that that tumor cell doesn't have that tool in the toolbox to repair the damage. And often we see that temozolomide works quite well in this group of patients. This is also clinically important. When we talked about the STOOP trial earlier, they looked at patients within those cohorts and showed specifically that the patients that had methylated MGMT versus unmethylated, so lacked the expression of MGMT, did far better than the patients that expressed MGMT. And that was shown in the clinical trial that is shown here. So this is a very important biomarker for us in the clinic, and we often spend a lot of time making sure that we can confirm whether this is true. So why is this important at the mechanistic level, and what happens when patients become resistant to temozolomide? It turns out that when you have silencing of MGMT, and we'll hear about this more in the second part of our talk, another set of DNA repair genes, specifically mismatch repair genes, get mutated, and that causes resistance. And we could spend a whole other hour on why that is, but really all we need to know is that simply TMZ becomes invisible to the cancer cell when you have a mismatch repair mutation. And I sort of like to think of this So if a tree falls in the woods, it doesn't make a sound, meaning mismatch repair is not there to recognize that lesion. It essentially becomes invisible for the cancer cell. And so mismatch repair is a very important, mutations are a very important marker for resistance. But this is not only the full part of the story. When patients get these mismatch repair mutations, you'll often hear this referred to as a hypermutator phenotype or hypermutant. And this is important because mismatch repair's normal job is to prevent errors in replication. So at the top here, you see a normal cell or a tumor that doesn't have a mismatch repair mutation has very, very low rate of mutations. But when you have a mismatch repair mutation, they acquire mutations over time, and we call them hypermutated. And certainly many of you have heard that term, and it can be confusing to many, but in most cases, that is synonymous with a mismatch repair mutation that has been acquired during the course of resistance to temozolomide. So what are the treatments for patients that have TMZ resistance? So there are other chemotherapies which retain activity independent of MGMT and MMR status, meaning methylated or unmethylated MGMT, and wild type or not mutated versus mutated mismatch repair. An example drug that many of you may have heard of is CCNU or lomustine. Another interesting area that we'll hear about in the second part of our talk is immunotherapy may be active against these tumors because of the increased mutation rates and what we call neoantigens or new proteins that are produced by those cells. But this is an active area of investigation by many groups across the country, and certainly folks that are on this call, including Nancy. Combinations of DNA repair inhibitors are also being tested, which could actually overcome resistance. For example, temozolomide plus PARP inhibitors, and some of you may know PARP inhibitors from breast cancer, Lynparza or olaparib. Combinations of temozolomide in glioma may be of great interest, and possibly specifically in tumors that are resistant to TMZ via mismatch repair mutations. And our group spends quite some time working on this research area. So just to conclude, chemotherapy is an important backbone of therapy for gliomas. Temozolomide is highly effective against tumors with MGMT methylation or promoter methylation. Mismatch repair mutations are a common mechanism for temozolomide resistance. And while this can be a problem clinically for the temozolomide response, we can possibly use or exploit this new defect for other therapies. These mutations cause this hypermutator phenotype that I talked about earlier, and many believe that that hypermutator phenotype may be the basis to develop novel therapies that specifically target tumor cells that have these mismatch repair mutations. And just to sort of conclude here, there's a lot of hope and a lot of interest on many labs trying to understand how we can target these tumors. It is my hope that in the coming years, we'll have a number of different treatment options like the ones that I mentioned for patients. With that, I'm going to turn it over to the second half of our talk, and thank you for listening.
Thank you.
We're giving you remote control.
Thank you so much. Oh, I went too fast already. Thank you so much, Dr. Bindra, and thank you so much to the organizers for having me and Sean for that lovely introduction. You know, Sean is one of my best friends, so it's nice to have him be able to introduce me. So I'm going to be talking about temozolomide resistance, what it means to you as a patient. Dr. Bindra just did such a lovely job kind of going over the basic science of how this happens, but what does it mean to you? For my disclosures, I work with some companies for clinical trials. Okay. My mouse is going so fast. Let me use this back here instead. Okay, so I'm going to review how often does temozolomide-induced mutation actually happen? And what are the implications if your tumor becomes hypermutated? What does it mean? Are there risk factors for the development of hypermutation? We're going to touch again on, are there treatments for patients with hypermutation? And then finally, how do I know if my tumor is hypermutated? So first, how often does this actually happen? Now, the Boston group led by Tuat did a beautiful study that was published about 1.5 years ago now, looking at over 10,000 specimens of patient tumors, looking to see how often does hypermutation happen in different tumor types. So this graph is showing you 3 kinds of tumors: oligodendrogliomas in red, astrocytomas in yellow, and glioblastomas in blue. Primary means at the time of diagnosis, and post-TMZ means after treatment with temozolomide. And what you can see here is that about 60% of patients who have oligodendrogliomas that are treated with temozolomide had evidence of hypermutation. They saw 30% of patients with astrocytomas, IDH mutant astrocytomas, had hypermutation after treatment with temozolomide, and about 23% of patients with glioblastoma had evidence of hypermutation after the treatment of temozolomide. Let's look at this a little bit more closely. Goodness. They also looked at high-grade tumors versus low-grade tumors. So hypermutation was found to be in a higher percentage of patients with high-grade tumors compared to low-grade tumors. It wasn't as common. And again, very much more common in recurrent tumors than in tumors that were primary. And the primary tumors that have hypermutation are typically patients who have genetic disorders who have that mismatch repair at the beginning, which is not related to temozolomide, and we're not focusing on that in this talk, but it is also a mechanism for developing of hypermutation. All right, let's look specifically at low-grade tumors. So as most of you know, low-grade tumors, when they grow back, can either grow back at the same grade, grade 2, or they can change and become higher grade. We call that transformation. Oligodendrogliomas can transform into grade 3 tumors. Astrocytomas can transform into grade 3 or grade 4 tumors. So when you look specifically at patients who started with low-grade tumors, and then they grew back at a higher grade after treatment with temozolomide, how often did hypermutation happen? And it turns out about 50% of the time, all comers, 57% of patients had evidence of hypermutation. In the oligodendrogliomas, 61%. In the IDH mutant astrocytomas, 53%. So this is a really common event that we do see in our patients when they transform to higher grade. Now, is it associated with higher grade? Well, let's look at this a little bit more closely. So for the oligodendrogliomas, when tumors grow back, like we talked about, they can either be grade 2s or grade 3s. And what we found is that patients with hypermutation were almost always grade 3. In fact, there was only one patient in our group that grew back at a grade 2 that was hypermutated. And that patient actually had very aggressive clinical course, and within just a few months developed recurrence again with enhancing disease. We saw something very similar in the astrocytoma patients. Again, most patients who had hypermutation had grade 3 or grade 4 disease. And there was only one patient that grew back as a grade 2 that had hypermutation. And that patient as well had a very aggressive clinical course and wound up having a surgery again in 9 months. And at that time, it was confirmed that the patient had transformed to a higher grade disease. So overall, hypermutation is associated with a higher grade at recurrence or when the tumor grows back. All right, well, what does it mean? Does it impact the disease course? So these curves are something that oncologists and people in our group really look at very closely and look at all the time. When you start out, 100% of patients are here, and as the lines drop over time, the prognosis is worse, is basically, we look at these for overall survival. I don't really want you to pay too much attention to the numbers, but I want you to pay attention to the difference between the solid lines and the dotted lines. So the top two solid lines are oligodendroglioma patients. And patients without hypermutation are solid, and the patients with the dotted lines have hypermutation. And so patients without hypermutation have a better prognosis than patients with hypermutation for the oligodendroglioma population. Now let's look at the blue lines. Again, solid, no hypermutation, dotted is hypermutation in the astrocytoma patients. Again, patients without hypermutation, the solid lines, did better than patients with the dotted lines. So those are patients with hypermutation. Now, when you look at the bottom, the orange, this is glioblastoma. And these two curves are pretty similar, the dotted and the solid. So this is telling us that when you have a glioblastoma, hypermutation does not impact your survival as much as it does for the other kinds of tumors, the lower grades. Let's look specifically at the low-grade tumors. If you have a low-grade tumor that transforms to a high grade, if you are hypermutated, the blue line, you have a worse overall prognosis than if your tumor doesn't develop hypermutation at the same grade. So patients with hypermutation have a worse prognosis. This was actually the case specifically for patients who transformed to grade 3. So the oligos and the astros, when you transform to grade 3 and had hypermutation, you guys, they had a worse prognosis than patients who did not. However, like I showed you before, if the astrocytoma patients transformed to grade 4, it didn't really matter if they had hypermutation or not, the prognosis was the same. These two curves overlap. So it's really specific for those patients that transform to grade 3. Okay, so I told you that this is associated with grade, and then if you do have hypermutation, you have a worse prognosis. Something else that we interested is that these tumors were acting very differently. And so a lot of times when low-grade tumors grow back, they grow back in the same spot, either contiguous with the surgical resection cavity or just expansion of residual tumor. But what we started to notice is that patients that had hypermutation were developing tumors in completely different parts of the brain. We were calling this discontiguous disease, new spots that were different from those that right where you did the surgery. We found that this was far more likely to happen in patients with hypermutation. It happened over 40% of the time. And in the non-hypermutated patients, it was only happening very rarely, about 12% of the time. So we took a little bit of a closer look at that as well. And what we noticed that patients with hypermutation had very distinct patterns of tumor growth. So not only was it discontiguous, but they had very high levels of things called ependymal dissemination or leptomeningeal dissemination, some of which we just heard about on your lunch break, where it's going to the linings of the brain. And then the parenchymal discontiguous disease, we saw that too, but for the non-hypermutated patients, that was the only form of discontiguous disease, parenchymal. They never went to the linings, the ependyma of the leptomeninges. And in fact, something else really interesting we found, 4 patients with hypermutation even had spinal dissemination. So the tumors went down into their spinal cords, which is very rare. But every time that happened, those patients had hypermutation. Okay, well, what are the risk factors? What makes me more likely to develop hypermutation? So the first question we asked is there a risk if you get more Temodar? Is getting more cycles worse? And for our patient populations, the low-grade tumors, it didn't seem that that was actually the case. There was really no increased risk of developing hypermutation the more temozolomide cycles that you got. However, it may be for all tumor types that more temozolomide may cause a higher risk of development of hypermutation. So when you look at kind of including glioblastoma and all of the tumors together, then more cycles did seem to mean more risk of hypermutation. How about big tumors? Are big tumors more likely to develop hypermutation? Turns out not really. So there was no increased risk for a bigger residual tumor after surgery for developing hypermutation than a small tumor or a gross total resection. The other thing I wanted to note, there's no gender difference, no ethnicity differences, no racial differences for the development of hypermutation. Okay, something that we heard a little bit about before is actually MGMT methylation is quite important, and higher levels of MGMT methylation at diagnosis, although it means your tumor responds better to temozolomide, it also means that you have a higher risk for hypermutation down the road. So patients who had high levels of methylation were much more likely to develop hypermutation than if you started out with low levels of MGMT methylation on your initial tumor. And one of the studies that we did at UCSF actually looked at 17 different methylation sites at the initial tumor diagnosis. And patients who were to go on to become hypermutated had higher levels of MGMT methylation at every single one of those 17 methylation sites compared to the patients who went on to not be hypermutated. They had lower levels of MGMT methylation at initial diagnosis at all those different sites. And so in our group, we actually came up with a scale. If you were less than 42.5% MGMT methylated for our internal way that we do things, then you were very unlikely to become hypermutated. But if you were higher than that, you had a very good chance of becoming hypermutated in the future. All right, so a piece of good news. Is there anything that's protective for the development of hypermutation? Turns out possibly. When I first showed you the graph, I showed you that oligos and astros were pretty much the same for the development of hypermutation. But something that we noticed when we compared our data to the Boston group is that actually radiation treatment seemed to be protective for the development of hypermutation, specifically in patients who had astrocytomas. So patients who had astrocytomas who got radiation and temozolomide together were less likely to develop hypermutation in the future than patients who got temozolomide by themselves. This didn't quite pan out for the oligodendroglioma patients, but for the astrocytomas, radiation does seem to be protective. All right, how do I know if I have hypermutation? Hypermutation is tested by looking at something called tumor mutational burden, or TMB, usually on next generation sequencing of your brain tumor tissue. So as of now, you have to have a surgical resection or biopsy and test the tumor to know if it's hypermutated. And we do this, Dr. Bindra had pointed out, you see hundreds and hundreds and hundreds of mutations, and has a very specific signature called signature 11 that knows that this is specifically temozolomide-induced hypermutation. So this can be done through multiple companies. This is just a few: Foundation One, Caris, Natura, Precision Oncology, all can run these panels where they do next generation sequencing on a tiny piece of your tumor, and it would tell you if you have high tumor mutational burden or hypermutation. Additionally, there are internal panels that many academic institutions use. At UCSF, we use something called the UCSF 500 cancer panel, where it tests 500 of the most commonly mutated genes, but it also tests tumor mutational burden, so you can see if someone is hypermutated. And if I can get there, this would be an example of one of the reports that would come at UCSF, where you would see at the top line, high somatic burden hypermutation predicted from tumor-only sequencing with this predominance of C to T transitions, which is that signature 11. So this, which occurs after temozolomide. So this is what we call hypermutation. So it is my sincere hope, and something that I'm actively working on, is that we would be able to test for this without having to go through surgery and get another biopsy, through liquid biopsies, either the cerebral spinal fluid or the blood. And so that's an active area of research. All right, so treatments. Just a few words on this because we already touched on it, but immunotherapy for primary brain tumors has not been the slam dunk that maybe we had wanted a few years ago. And part of that is because the primary brain tumors look a lot like the normal brain, and so it's almost like the immune system can't find them. But for hypermutated tumors, all of a sudden these have hundreds and hundreds of mutations, and they start to look quite different. And so potentially immunotherapy with blockage of the PD-1, PD-L1, which takes the brakes off your own immune system to find tumors, will work specifically for this patient population. There's active clinical trials, some of which are done through Alliance, that we're looking at whether hypermutated tumors are more likely to respond to immunotherapy with and without radiation. And the other one to mention that Dr. Bindra said is another very common chemotherapy called lomustine, seems to still work for patients with temozolomide-induced resistance, although we're still actively figuring out in our patients, and in cell culture, the cells that are hypermutated, if you treat them with CCNU, they die, so they're still responsive. So another very good treatment, and like Dr. Bindra also mentioned, potentially PARP inhibitors plus temozolomide is another avenue that we're looking into to see if that actually would be effective against patients who have hypermutation. Okay, so just for a few minutes on conclusion, temozolomide-induced hypermutation is actually really common. About 50% of patients it happens in, especially the low grades, 20% in glioblastoma. And for low-grade tumors, it is associated with transformation to higher grade disease. It is associated with a worse prognosis, specifically for patients who transform to grade 3 disease. We see it associated with distant tumor spread. Maybe it's associated with greater temozolomide exposure, but maybe not, still hard to know. Definitely seems like it's associated with higher levels of MGMT methylation, and radiation actually may be protective, especially in our astrocytoma patients. And it can be treated with other kinds of chemotherapy, immunotherapy, and there's so many active clinical trials looking into this. So I just wanted to end is, what can you do as a patient about this? And so even though chemotherapy can cause hypermutation, it still works to improve overall survival. I do not want you to leave this talk thinking that you shouldn't have done chemotherapy, because it does work, it helps. It's just something that hypermutation we have to pay attention to, because we maybe will treat it differently or do different kinds of scans, those kinds of things. The other thing to know, hypermutation can actually be caused by other chemos. Hypermutation is also caused by CCNU. So it's not that temozolomide is necessarily a bad drug. We don't know the rates yet for patients with CCNU. We're actively studying it, but it can be caused. Talk to your provider about your risk of hypermutation and what it means. Discuss with your provider the benefits for treating for hypermutation. And just remember, new treatments are on the horizon. There have been so many people that I've talked to over the past 2 days that have really dedicated their lives to improving treatments for brain tumors, and we couldn't do this job if we didn't believe that there were better treatments coming. And with that, thank you.
Thank you both so much for a wonderful presentation. We have time for some questions. Just as a reminder, if you do have questions that you'd like to ask, please type and submit it using the Q&A button on the bottom of your control panel, and we'll answer questions as time allows. So one of the first questions that we have here is asking, what are some of the other risk factors for hypermutation? We talked about how long the patient might have been on TMZ. Are there environmental factors? Does age play a role in someone's risk for developing hypermutation?
We didn't find that at age or gender or race or ethnicity really made a difference in the development of hypermutation. So I think the major ones are whether or not you have MGMT methylation. That's a big one. So patients who have MGMT methylation are more likely to develop hypermutation. Possibly the number of temozolomide cycles. Timing, I didn't present that data, but it's all over the map. Sometimes people develop hypermutation really soon after their exposure. Sometimes it's years and years and years and years and years later they develop hypermutation. So we didn't really see a timing difference. It was kind of everywhere. And again, tumor volume also didn't seem to make a big difference for the development of hypermutation.
Thank you so much for sharing that. Another question, Dr. Oberheim-Busch, this one is for you. You had mentioned during your part of the talk about hypermutation in patients with genetic disorders. Can you clarify what type of genetic disorders you were referring to?
So patients who have underlying mutations in MMR, like Dr. Bindra had mentioned, a very common one would be Lee-Fraumeni syndrome. Sometimes we can see that. It's pretty darn rare, but we can see genetic disorders where patients have hypermutation at the get-go.
Thank you so much. Another question we have is asking about levels of MGMT methylation. You had shared the importance of the levels of that type of methylation. Can you talk a little bit about how a patient can understand whether they have high levels of methylation? How do they find that in their pathology report?
That is really difficult because it turns out that people test MGMT methylation differently in different locations. Our particular institution uses 17 different methylation sites and they get an index. Quite frankly, it's a random number, and probably Dr. Bindra's group uses something different to test methylation. And a lot of times you actually just get a positive or a negative without an index. So I think it is, so unfortunately, what I presented is not necessarily clinically applicable for everyone, but I think as we learn more and as more labs are starting to do kind of indexes instead of just a positive and negative, we may know more. I don't know, Dr. Bindra, this is your field. Yeah. I don't know if you want to comment on that.
No, thanks, Dr. Oberheim-Busch. It shows you how much we still don't know. Our laboratory has been studying MGMT for about a decade now, and we often have patients that come with frustration where they get a local report that says it's silenced, and then it gets to central review in a clinical trial, and they say the opposite. And it's simply because the laboratory tests that they're using, there's debate on which promoter islands to look for methylation. Should we look at whole exome or whole methylome sequencing? And quite frankly, we still don't understand how MGMT expression is truly regulated. So I think it's still a work in progress, and often, having the pathology reviewed at a major center will provide some level of comfort and validation, but definitely a wonderful question.
Thank you both for sharing your insight on that. Another question we have here is there anything that patients can do proactively to help reduce the chances of getting hypermutation? Is that possible?
I think not necessarily. I think for patients who are newly diagnosed astrocytomas, it would definitely make sense to discuss whether or not doing radiation with temozolomide makes sense versus doing sole chemotherapy only, which is not done that often, but can sometimes be done. But I think there's not much to do to kind of prevent it that we know of.
Thank you. Another question we have here is about the TMB testing or analysis that you had talked about. Is that something that is always done when a reoccurrence happens? Is that something a patient has to request?
Again, that will depend on your institution. So particularly at UCSF, we do next generation sequencing on all of our tumors. It's just part of our standard of care, but most places will not do that. So it is something that you'd have to request to your physician to send off one of these next generation sequencing panels. They're commercially available. So you just take a little piece of tumor and send it off, and then they'll send you back the report with all your different types of mutations and whether or not you have high tumor mutational burden.
Thank you so much. And then with that, along the same lines of that question, is that type of sequencing something that's covered by insurance, or is that an out-of-pocket cost for the patient?
That is a tough question. Most times it's covered by insurance, but not always for sure. Sometimes it can be really difficult. If your physician says it's because of treatment resistance or looking for possible treatment options, many times it can get covered by insurance. And then the cost, if people are curious, can range anywhere from $500 to $5,000, depending on the panel that you would choose.
And I'll add, this is really a moment to mention patient empowerment. And these are your samples. These are specimens that came from you, and getting a second opinion potentially at another place that may be able to do that. For example, at Yale and many other institutions, we do our own in-house whole exome sequencing, and then we do that free of charge, and there's multiple institutions that do that. And so certainly if you encounter a problem with that, consider that second opinion and see if you can get another institution to look at those slides.
Thank you. And Dr. Binder, a follow-up question on that. How can a patient find an institution that does that type of sequencing? Is that something that they can find on their website, or where would they find that information?
Yeah, so I'll start, and Dr. Oberheim-Busch also likely will comment. I think certainly asking your primary doctor first to say, are there other places that we can get a second opinion? Places like Memorial Sloan Kettering, our institution, Dr. Oberheim-Busch's institution, they will either be able to provide that information, or you can directly request, a consultation, and in that initial interaction, you can ask them, would this be possible?
Yeah, I would completely agree. A lot of times when we do second opinions, even if they're remote and from people across the country, we'd say, we'd really like to take a look at your pathology and do sequencing. Would that be okay? And so certainly big academic centers can help with that. It's also usually listed on websites and things, but starting with your primary oncologist. And just like Dr. Binder said, your tumor is precious. It really is. And so just making sure that you're being really thoughtful about what you want to use it for. And I would say that this would be a good use of your tumor, because it may be really helpful.
And exactly. And I'll just add, it's slightly off topic, but often I have patients that get nervous about saying, well, we'd like a second opinion, but it's not that we don't trust you or this and that. And I think it's important to realize that really everyone wants just to help you. And really very few people would be offended by a second set of eyes, because I've always in the last 10 years as an attending seen some surprising differences in that second opinion that are quite important for the outcome. So don't be shy is what I would say.
Thank you so much for that advice. Another question we have here, and Dr. Oberheim-Busch, I believe that you covered this a little bit. Are there other types of treatments, other chemotherapy medications or therapies that can cause, that can have resistance or that can cause hypermutation?
So it turns out yes, and we're still learning about this, but there is data that CCNU can also cause hypermutation. We don't truly understand the rates like we're now understanding for temozolomide, but it can also cause this phenotype. And yes, many treatments can have the development of resistance. It's an active area of research.
Thank you so much. Let's see if we have any other questions coming through. Okay, another question we have here is asking, I think Dr. Oberheim-Busch, I think again, this is something that you might have covered. Does the length of time that you've been on a specific chemotherapy medication increase your likelihood of developing resistance to that treatment or developing hypermutation later?
It probably can, depending on the tumor type. When we looked at kind of all of the tumors, it did seem the more chemotherapy that you got, the higher likelihood that you would develop hypermutation. Specifically in the low-grade tumors, it was not as clear, but I think as we study more and more patients, probably it is the case that the more you get, the likelier you are to develop it.
All right, I think we'll take one more question. This question is asking if a patient has developed hypermutation, does that put them at higher risk of developing other types of tumors in the future? So let's say maybe they had an oligodendroglioma originally and they were in no evidence of disease and another tumor occurred, like a glioblastoma later. Is that possible? Does that put them at higher risk, that hypermutation?
So usually what happens is that one of the cells in your tumor develops this hypermutation and then it decides to grow out of control. And so maybe another tumor pops up, a different part of your brain, but it's still coming from your original tumor. So it still have that original phenotype of the 1p19q co-deletion, and then it became more aggressive. And then so we would say it was a grade 3 oligo because they never become glioblastoma. So usually it's from the original tumor. The hypermutation that we're talking about happens in the brain tumors themselves. So it's not happening in your genome, in your blood, and other parts of your body. So you don't have to worry about that causing the development of colon cancer or breast cancer or lung cancer. And usually the brain tumors that would grow back would be from the original tumor, just developed into something slightly different, but with the same initial clone. Dr. Binder, would you agree with that statement?
Yeah, 100%. I think that's the key. And unless you exactly have a hereditary situation where you actually have a mismatch or mutation, now that's different because all your normal cells have it. But other than that, it's exactly what you said, Dr. Oberheim-Busch.
Thank you. Another question we have is for other cancer types. For example, metastatic brain tumors. How does hypermutation impact these patients? Does it work the same way?
That's a great question. I don't think so. If the metastatic disease was treated with temozolomide, it could potentially happen in the same way. Temozolomide isn't necessarily used as high levels in metastatic patients. Other kinds of chemotherapies are used to treat those. But if temozolomide was used to treat it, then it could potentially impact it the same way.
And it kind of shows you how much we have to learn about all of these cancers. And thankfully, we're doing research, and folks like ABTA are supporting that research efforts, because that is an open question, and eventually we might have some answers there too. Yeah.
Thank you so much. We'll take just one last question, and this question is asking, can radiation cause the development of hypermutation?
So certainly an active sort of controversial area. I'm always biased as a radiation oncologist to say it does not, but in truth, it's really not clearly well established. There probably is a component. There's chromotrypsis, big word, but saying to some genetic instability in the DNA that has been radiated, but true hypermutation arising from radiation, we have not yet seen convincing data, but again, shows you we need to do more research in this area.
Thank you. Dr. Oberheim-Busch, did you want to add anything else before we wrap up?
I'm going to leave it to the radiation oncologist, but I believe in radiation therapy, so you should get it.
Thank you for saying that.
All right. Well, that is all the time that we have for questions for this session. Thank you both so much for your wonderful answers, and thank you all to our attendees for those great questions. I'm going to go ahead and turn it back to Emily.
Take care. Thank you.
Thank you so much, Dr. Bindra and Dr. Oberham-Busch. That was such an engaging and interactive session. We really appreciate the synergy between the two of you. So thank you both so much. For those of you who need to take a quick break, please take this opportunity to do so. We invite the rest of you to stay on to hear a research update. We will return back in just a few moments for our session on immunotherapy. Thank you so much. See you soon.
First, I would like to thank the organizers for inviting me here to present our lab's work, sponsored or supported by the 2019 ABTA Discovery Grant through the Anonymous Family Foundation. My name is Wen Jiang. I'm an assistant professor of radiation oncology at MD Anderson Cancer Center. The topic of my presentation today is bridging innate and adaptive GBM immunity via phagocytosis. Here is my team. We're from MD Anderson Cancer Center located in Houston, Texas. The reason we want to study immunity in the context of GBM is that cancer immunotherapy has really generated significant clinical benefit in the last decade, resulted in the 2018 Nobel Prize in Physiology and Medicine awarded to Dr. James Allison, who is from MD Anderson, and Dr. Han Zhou. Their work has really been focused on targeting T cells, which is a component of the adaptive immune system, and identify new therapies that can block the inhibitory signals expressed by cancer cells that suppress T cell function. Our body's immune system comes into, however, two branches: the adaptive, which targeted include the T cells, and the innate immune response. My work has been mostly focusing on studying the innate side of the story, where we focus on identifying molecules such as CD47 and beta-2 microglobulin. These are molecules expressed by cancer cells that suppress innate immune function. Just as other cancers in the body, such as breast and colorectal cancer, GBM cells also rely on these two molecules to evade the detection of body's innate immune system. And what we have found is that GBM cells overexpress both of these molecules, and their expression is associated with worse patient outcomes. So therefore, what we hypothesize is that if we can simultaneously block these two molecules used by GBM cells as an invisibility cloak against immune detection, we might be able to restore the power of the immune system to eliminate these tumors. And to do so, we generate a bispecific antibody that target these both molecules. When we treated mouse harboring GBM tumors using two different mouse models, we found the bispecific antibody significantly inhibit the GBM growth and almost more than double the overall survival of these tumor-bearing mice compared to the current standard of systemic therapy, which is temozolomide. When we took out the tumor tissue of these treated mice, we see significant infiltration of immune cells as well as activation. These results suggest that the bispecific antibody really creating an immune stimulatory environment allow the body's immune system to come clear and eradicate the tumor. So that summarizes my presentation. I would like to thank the ABTA Discover Grant for being so crucial in laying the foundation of current work. In fact, our subsequent studies to study the bispecific molecule in more clinically relevant model system is now being funded by the NIH. Our goal is really to translate the bispecific antibody into clinical trial for GBM patient in the next 3 to 5 years. And with that, I would like to thank you for your attention.
Welcome back. In this next session, you will hear about innovative immuno-oncology approaches that can increase brain tumor responsiveness to immunotherapy strategies. Please welcome our co-chair, Dr. Eva Galanis, who will be presenting on this session along with her dear friend, who she will take the opportunity to introduce.
Good afternoon, and thank you again for joining us. It is truly my pleasure to present alongside my friend and colleague, Dr. Nino Chiocca, who is a professor of neurosurgery at Harvard and the neurosurgery chair at Brigham and Women's. Dr. Kyoka is also a pioneer in use of genes and viruses to treat brain tumors with wonderful innovative work, and we will hear more about that during this presentation. So I will start first, and then Dr. Kyoka will present additional data on genes, on use of genes and viruses as part of our immuno-oncology armamentarium against brain tumors. And here are my disclosures. First of all, what is immunotherapy? A type of cancer treatment that uses the immune system in order to fight cancer. The immune system is made up of white blood cells with different names. You're going to hear some of these names during our presentations today. For example, T cells, they are critical in the fight against tumor, macrophages, B cells that produce antibodies, and so on and so forth. Also, it consists of the organs and tissues of the lymphatic system. 21st century has been named as the era of immuno-oncology, with multiple immunotherapies approved for different tumor types. Unfortunately, brain tumors have not been benefited yet by immuno-oncology to the extent that other tumor types have. Examples of immunotherapy approaches: immune checkpoint inhibitors. So immune checkpoints are signaling molecules that they are found predominantly in immune cells. And what they do is they rein the immune system. Inhibitors of these signaling molecules can, of course, reactivate an immune system response, including the tumor. CAR T cells are engineered T cells, and Dr. Kyoka will discuss more about that. Monoclonal antibodies and also vaccines. Indeed, immune system in the brain can follow different principles for the immune system elsewhere in the body. And there are a number of reasons for that. One of the reasons is this blood-brain barrier, as the word says, the barrier between the blood and the brain cells, that essentially blocks the free traveling of different substances in the blood, including immune cells or antibodies, from freely entering and reaching out to brain cells and tumor cells. Also, despite the fact that there are some functional lymphatic vessels in the central nervous system, we do not have a classic lymphatic system in the brain. And if we add to that primary brain tumors, a primary brain tumor, a glioma, the things become even more challenging. Gliomas, and especially glioblastoma, are immunologically cold tumors. And this is because of characteristics of the tumor and because of the treatments that we're giving our patients. So both tumor cells, glioma cells, as well as the stroma, the interstitial tissue that surrounds the tumors, have immunosuppressive properties. They secrete different substances, signals, cytokines, they're called cytokines, that they can block inflammation, which again, inflammation is a signal for the immune system to be activated. They also change the type of cells that they can infiltrate, type of immune cells that infiltrate the brain tumors. In general, in brain tumors, we see a lower number of immune cells or immune infiltration as compared to other tumors. And in addition, these cells are not necessarily the right type. A lot of the cells that infiltrate brain tumors have immunosuppressive properties, including the immunosuppressive Treg cells or immunosuppressive macrophages. Furthermore, with some of this activity, there is sequestration of the good, of the fighter T cells in the bone marrow, and they're blocked from traveling into the brain. And we have an increased expression of immune checkpoints that we discussed. They rein the immune system and they blocked it from being activated. So with that in mind, what are some of the steps in order to develop an optimal anti-tumor immune response targeted against brain tumors? First of all, we need an immunological target or targets. And as you realize, the brain tumors are very smart in creating mechanisms of escape, of resistance against immune therapy. For example, a very common mechanism, if we target any single antigen, any single target in a brain tumor, is that the levels of expression of the specific target may decrease. And that allows the cell to then escape the immune therapy we're trying to develop. And that's a prime example. This is exactly what happened with vaccines targeting the mutant EGFR, EGFRB3. So we need to have an immunological target or targets that the immune system can recognize. We need to have activated T cells. We need to encourage T cells and other immune cells to target to the tumor and infiltrate it. And also when they get there, we need to keep them engaged and active. A phenomenon that we frequently observe in a brain tumor microenvironment is what is called an exhaustion. And as the word says it, the T cells are there, but they are inactive because of the immune suppressive environment. And this is something we need to prevent and reverse. With all these challenges, it's not surprising that very large trials, large immunotherapy trials for glioblastoma have been negative. In addition to the vaccine, the EGFRB3 vaccine trial I mentioned, that includes 3 large studies using an immune checkpoint inhibitor, nivolumab, both in the recurrent disease setting, where nivolumab was not better than bevacizumab, and for newly diagnosed patients with glioblastoma, both MGMT methylated and MGMT unmethylated. So when I see patients in the clinic and they tell me, I would like to find a way to receive immunotherapy outside the clinical trial, I share this data and highlight why I don't think that this is a good idea, because the data so far point very strongly towards immunotherapy for unselected patients with glioblastoma using the immune checkpoint inhibitors we have commercially available will not work. So truly, the best approach is to consider participating in immunotherapy clinical trial with some of the novel and promising agents and combination, and some of them we'll be discussing today. So in order to overcome this resistance in glioblastoma, and primarily the resistance in glioblastoma is what we call the primary resistance. In other words, the tumor will never respond. There is also some what we call the secondary resistance. In addition, in other words, the tumor initially responds and then stops responding. But in order to see that, we need to have this primary response first. And unfortunately, we very rarely have seen that in glioblastoma. And how do we do that? By increasing the immunologic targets that the immune system can see. And what are the approaches to that? One is to really select the right patients for immunotherapy. Patients who have a very high mutation load to start with, for example, maybe good candidates. But then the second approach is to really treat the tumor cells with agents, viruses, and Dr. Koka is going to talk about that as a prime example, that can increase the number of immunologic targets. Or follow an approach, for example, a dendritic cell vaccine approach, DCVax being one of the examples, where from the get-go there are multiple targets. Again, none of these approaches have yet panned out to the point of being acceptable as the standard of care, but this is additional background on the rationale as to why a multi-targeted approach might have a higher likelihood of success as opposed to an approach targeted at a single immunologic target in glioblastoma. Second is to modify the microenvironment to convert immunologically cold tumors to hot. And I would say, despite the fact that primary brain tumors and glioblastoma are particularly hard to treat, some of the lessons we are learning in this effort can benefit other tumors, can also benefit patients with metastatic disease. We talked about the 21st century being the immuno-oncology era. Nevertheless, across the border, across all tumor types, only 20 to 30% of the patients can benefit of immunotherapy approaches because of primary or secondary resistance. So lessons learned in the toughest of all tumors, GBM, can also be applicable and helpful for other tumor types and metastatic disease to the brain. So going back to the first goal, increasing immunologic targets. Perhaps a low-hanging fruit is patient selection based on tumor mutation burden. So how do mutations impact the likelihood of response to immunotherapy? Mutation, as a lot of you know, a mutation is a change in the structure of the DNA. And that leads to frequently to an altered protein. And this protein, in the case of a mutation in a tumor cell, could be a completely new protein that the immune system would recognize as new. And this can be presented to the immune system as tumor-specific new antigens, neoantigens, as we call them. So how can this high tumor mutation burden be caused? One is it's present in the tumor from the get-go. This is, for example, in some situations, some patients who do have hereditary diseases that lead to high tumor mutation burden, Lynch syndrome being one of the example. Or high mutation burden can be developed as a result of glioma therapy. For the ones of you who attended the previous section, you saw how temozolomide can lead to increased tumor mutation burden. Indeed, for glioblastoma, less than 5% of the patients have a high tumor mutation burden at diagnosis in de novo glioblastoma. But then at recurrence, 15 to 20% of the patients have a high tumor mutation burden. And I will show to you how we plan to capitalize on that as part of clinical trials. And this is true, not just about primary brain tumors, but also across all tumor types. And indeed, in June 2020, FDA provided accelerated approval of pembrolizumab for adult and pediatric patients with refractory solid tumors and high mutation burden. How do they define the high mutation burden in that approval? More than 10 mutations in megabase. And this is applicable also for brain tumor patients. So that could be a path in the one situation where standard of care treatment with an immune checkpoint inhibitor, pembrolizumab in this case, is A, appropriate, B, FDA approved, and C, as a result, it should be reimbursable by insurance companies. Now, talking about immune checkpoints, the signaling molecules that block activation of the immune system, we also know from other tumor types, for example, melanoma, that if we block multiple immune checkpoints, we can have higher efficacy. And this is exactly what we are trying to capitalize on a trial, clinical trial. We activated in Alliance. Gavin Dunn is the principal investigator in this trial. And this is for patients with recurrent glioblastoma with high mutation burden. And there we give our patients the opportunity to receive a combination of 2 immune checkpoint inhibitors in a context where we have the right multiple target antigenic environment in the tumor to lead to a higher likelihood of response. So selecting the right patient would be applicable in some glioblastoma patients and in some primary brain tumor patients, where I think the higher impact can come from is modification of the tumor microenvironment. And there are different approaches that can allow us to accomplish that. For example, activating T-cell signal and immune cell trafficking. Reversing resistance to immune checkpoint inhibitors. How can we do that? There are different approaches. For example, there is increased knowledge that there are other checkpoints in immune cells. For example, LAG3, TIM3, that can mediate resistance. Thankfully, now we have antibodies against these additional checkpoints. So we can think, and we are thinking and developing combinatorial strategies. The other thing that happens in the brain tumor microenvironment is upregulation of an enzyme called IDO that indeed can cause immunosuppression, actually in part by depleting the nutrients that the immune cells, T cells, use. So there are commercially available inhibitors that can block this enzyme. And again, strategies incorporating inhibition of this enzyme are currently in clinical testing. Last and not least, an area of great interest and passion for me as well, use of viruses and genes in order to create a strong immunologic signal from the tumor, but also create a pro-inflammatory environment that will increase the likelihood of response. And this is a segue to the presentation of Dr. Kyoka. Thank you very much for your attention. And Nino, we are looking forward to your talk. Thank you.
Thank you, Eva. That was a great talk, and it's really a privilege to be here with you and with all the people on the panel and on this webinar. So I'm going to talk about looking to immunotherapy to move forward from resistance. So these are my disclosures, and let's go to the next slide. So GBM become resistant to current therapies. So surgery can remove the bulk of the tumor, GBM, but there are single GBM cells left behind that have infiltrated normal brain, which cannot be removed with surgery. Radiation and chemotherapy with temozolomide can destroy some of these single tumor cells left behind, but these GBM cells can evolve to become resistant. And there are several mechanisms that involve repair of the damaged DNA caused by radiation and temozolomide. These GBM cells that are left behind are also very different from each other in terms of what makes them malignant. And that is why a lot of the targeted therapies, targeted drugs against one particular cancer mechanism have failed. Next, number 4. Immunotherapy has the potential to answer this problem, since it educates you, educates your own, and it's a mistypo, your own immune cells to attack the tumor, regardless of what mechanism the tumor employs to grow and establish itself. And immunotherapy has been successful for several cancers, melanoma, lung, renal. However, as Dr. Galanis just discussed, in spite of the promise of immunotherapy, the initial clinical trials of this therapy in GBM have not been successful. Next slide, please. So barriers to successful immunotherapy in GBM, and why, and I think Dr. Galanis discussed it, but why are GBM not been treated with immunotherapy, is that first of all, GBM patients are fairly immunosuppressed. Number 2, GBM can actually hide from the tumor-killing immune cells called T cells by decreasing some of the surface molecules that are usually recognized by T cells to levels that are unrecognizable. Number 3, GBM have few T cells inside them. Number 4, GBM have lots of tumor-promoting immune cells called M2 myeloid cells that are enablers of tumor growth, persistence, and resistance to treatment. Number 5, and so the end result of all this is, next, tumor immunoresistance more than tumor immunoactivation. So in this balance, the immunoresistance wins. Next slide. So let's go through each one of these. Immunosuppression from steroids. Dexamethasone, which is a drug that a lot of GBM patients are on, is a powerful immunosuppressant. It kills off these tumor-killing T cells, but also stimulates tumor-promoting myeloid cells. Number 2, it is a great feel-good drug, and we use it because it reduces swelling from the surgery, radiation, or swelling from the tumor itself. It's really unclear if we have any other substitutes. If patients need dexamethasone, it needs to be given. So I'm not trying to say we should not be giving dexamethasone. We need to give it. However, your provider will try to taper the dose more quickly, or will try to prescribe in lower doses due to the side effects of long-term use. Number 4, sometimes we can use things like low-dose Avastin as a substitute because it's not immunosuppressive, but it also has its own disadvantages, such as infusion, risk of bleeding, and risk of wound dehiscence. Next. So let's go to the second part. GBM tumors hide from these tumor-killing immune cells called T cells by decreasing the surface molecules that are recognized by T cells. And basically what I'm showing here is this cancer cell that has this molecule at the surface called an MHC molecule. In humans, it's called HLA. And basically, this is the molecule that presents the antigen, the tumor antigen. And this is actually recognized by the T cell through this T cell receptor, allowing this immune cell, this T cell, to basically kill off that cancer cell. Next, press again. So this docking mechanism is similar to the space shuttle. You need a space shuttle docking to the International Space Station for recognition to happen, for astronauts to go back and forth. So similarly, you need this to happen. But unfortunately, tumor cells like GBM cells downregulate, do not have enough of these class 1 molecules on their surface. Next slide. So the second point is that the third point is that GBM tumors have very few tumor killing immune cells inside them. And we think of GBM not as an immuno-inflamed tumor. For example, melanoma is thought to be very immuno-inflamed, and that's why a lot of the immunotherapies work. GBM is more the one on the right, the bar on the right, which is an immunodeserted tumor, a tumor that basically does not allow a lot of T cells in it. And can you click one more time? So when you look and think of GBM, it's like a desert. There's not a lot of T cells in there. In fact, if GBM has a lot of immune cells, they're actually the wrong kind of immune cells. They're called the M2 myeloid cells. These are actually enablers of tumor growth. They enable the tumor to grow, to persist, and to resist to therapy. To making an analogy, whenever you have all dictators are bad, but when you have dictatorships like the one, if you click, Hitler had, Adolf Hitler by himself could not be a dictator. He needed a number of enablers, as shown here, to allow him to rule Nazi Germany for 12 years and basically start World War II. Next slide. So we are trying to use biology to overcome immunoresistance pathways. We're trying to find ways to make this glioblastoma, this cold immune desert, make it warm and infiltrated with tumor-killing T cells called CD4 plus and CD8 plus. If you can click again, please. If you can click, yeah. And one way to do this is to inject directly into the tumor a powerful immunostimulant. And this is where what Eva was talking about, gene therapy or viral therapy using basically tumor-killing viruses come into play. Next slide, please. So with gene therapy, what we're trying to do is to use some type of vector to deliver a powerful immunostimulant into the GBM cell. And by doing this, you get profound immunostimulation. In fact, the coronavirus vaccine depends on this. the vaccines that people are getting with coronavirus, like the Johnson & Johnson vaccine, is the same principle. It's using an adenoviral vector to deliver the immunostimulant. In this case is the particular protein from a gene from the coronavirus to make your own immune body fight off the coronavirus. Next slide, please. So there are varied clinical trials of gene therapy. Here are some of them: combining gene transfer with a thymidine kinase superantigen and valacyclovir with standard of care chemoradiation in newly diagnosed GBM, or using gene therapy to deliver a powerful immunostimulant like interleukin-12 with an immune checkpoint inhibitor. And in fact, CAR T cells are basically T cells that have been modified via gene therapy to target different molecules like EGFRB3, IL-13RA, or CMV antigen that can be presented or that are present inside the GBM. Next slide, please. So tumor-killing viruses have been engineered to basically infect a tumor and not infect normal brain. And in this process of infecting the tumor, you basically get inflammation and stimulation of both cells in your immune system, such as macrophages and myeloid cells, as well as the T cells that we were discussing, to come in and basically destroy the tumor. Next slide, please. So there are several clinical trials of oncolytic viruses. There's trials using oncolytic HSV1, like CAN3110. There's trials of poliovirus plus an immune checkpoint inhibitor. There's trials of an oncolytic adenovirus plus an immune checkpoint inhibitors. There's a trial of measles virus, as well as a trial of an oncolytic herpes virus expressing interleukin-12. Next slide, please. All these trials, you have to understand, though, are in early phase clinical trials. And so these therapies are still unproven. They can cause inflammation and pseudoprogression, and if steroids are used to manage this, uncertainty related to how it will counteract the desired immune response. There have been phase 3 trials in the past that were not successful, such as the Tokagen trial or the Aspect trial. But these newer products have been designed to circumvent some of these past failures. When post-treatment tissue is available from trials, biologically, there's been evidence of increased T cells and increased inflammatory tumor-fighting myeloid cells, as well as upregulation of human euleukocyte antigen. And these are things we want to see. These tell us that these trials are doing the immunological things that we want to see in the tissue that's been injected. Next slide, please. So in conclusion, there is biologic data that these biologic agents can stimulate immunity in tumor and can change this balance between local tumor immunosuppression and tumor immunoresistance and make these tumors more immunoactivated. And therefore, you're overcoming the resistance to treatment. And therefore, by using an oncolytic virus, a CAR T cell, gene therapy, or other local applications, we can activate these tumors so that basically they fight off, they're getting destroyed. Next slide. So question to ask as a patient when talking about immunotherapy and biologic agents is the trial for newly diagnosed or recurrent GBM? What phase trial is it? Is it an early or late trial? If this trial is for recurrence, how many previous therapies are allowed? If this trial is for recurrence, do other biologic therapies exclude you? Does the trial involve surgery? Are steroids allowed? How often are the follow-up and blood work times required? You also have to understand that trying to find out how other patients on trial are doing is not easy because most trials don't have a lot of follow-up and every patient is very different. It is also important that as providers, we continue outreach and assistance program to address issues related to disparities of access to clinical trials and clinical care. Next slide, please. So these are the disclaimers. And finally, next slide. I really want to thank the ABTA. The ABTA has been very crucial in supporting my research, our research, via several awards, beginning an award when I first started doing research in 1992, and then finding several awards to my postdocs as well as medical students. Thank you for your attention.
Thank you both so much for that wonderful presentation. We will now take questions. As a reminder, if you have a question that you'd like to ask, please type and submit it using the Q&A button in the control panel on the bottom of your screen, and we'll answer questions as time allows. So one of the first questions we have here is regarding these trials. Are these trials currently only being done on glioblastoma? Are there any trials for immunotherapy or these oncolytic viruses for other tumor types as well?
I can answer that. So most of the trials I showed you have been for high-grade glioma. Some trials want you to actually be a glioblastoma. For most of the times are for high-grade gliomas that have failed standard treatment. There have been some trials for pediatric gliomas, not as many. So, for example, there's been a trial of an oncolytic herpes virus for pediatric gliomas that was recently published in New England Journal of Medicine, and I think that trial is still ongoing. Eva?
Yes, thank you. And I agree with Nino, and there is a reason for that. If we think about viruses, especially viruses that replicate, as a lot of you know, viruses, they don't have their own replicating machinery. They rely on the substrate of the actual tumor cells in order to replicate, and that makes them also specific. So a high-grade tumor will replicate faster, and usually that's a much better substrate. There is also another reason as to why we are focusing on higher grade tumors, and that has to do with the animal models we have. As a lot of you know, animal models from lower grade tumors or IDH mutant tumors can be quite difficult to establish. So when you translate a new treatment, you try to have your patients recapitulate the characteristics of the tumor model where that was effective. So a lot of the virotherapy work as a result of it is performed, as Nino said, in high-grade tumors. In terms of vaccine approaches, especially IDH vaccines, some of them are targeted lower grade tumors. For example, one of the ongoing trial with an IDH1 vaccine for recurrent low-grade gliomas, and there is the slower growth pattern of these tumors also may provide a nice environment for the immunotherapy approach to build, because it may take some time for the immune response to happen. While on the other hand, high-grade tumors, you want to have also tumor cell kill and then give the time to the body to build an immune response.
Thank you so much for those answers. Another question we have is asking, are the barriers that you had discussed, the barriers to success for immunotherapy, are those barriers, when you talked about them specifically for glioblastoma, but are those barriers similar for other high-grade gliomas or other brain tumor types as well?
I can start, and then maybe Nino can chime in. Perhaps in glioblastoma, among all gliomas, glioblastomas are the better studied. Having said that, a lot of similar challenges apply to other gliomas. And we just talked about, for example, vaccines targeting IDH. Sometimes molecular characteristics of the tumor, mutations such as IDH, technically can also create an additional immunosuppressive environment. For example, IDH mutation has been shown to block chemotaxis. Chemotaxis is a Greek word, of course, and means blocking the ability of the T cells to infiltrate the tumor, to travel to the tumor. And that creates also some additional opportunities there, because if you block the metabolic function using an IDH inhibitor and combine with vaccine, for example, that could be an opportunity. Now, another very important question related to that pertains to the metastasis, the brain metastasis, where some of the challenges we discussed regarding the distinct characteristics of the brain tumor microenvironment from an immune suppression standpoint, from an access standpoint, are applicable there as well. However, we think to a lesser extent. For example, we had very nice responses of melanoma metastasis to immunotherapy, including immune checkpoint inhibitors. The blood-brain barrier is more distorted and uniformly distorted in brain metastasis. The tissue, the brain tissue around the metastasis, we see less of the infiltration that we normally see in gliomas. So although there are some common challenges, we think that it may be easier to attack metastatic disease to the brain, as some of the recent successes have shown. But having said that, if we're successful in conquering GBM, we can make great strides for many other things, because we would have been able to overcome one of the worst barriers in immunotherapy.
Thank you so much.
Yeah, not much to add to that. I mean, I think you've said it all.
All right. Another question we have is asking, how do stem cells play a role in immunotherapy? Do they impact these studies at all?
You know, that's a very good question about the fact that you know, a lot of times GBMs are thought to have, or all cancer are thought to have, some cancer stem-like property. Ultimately, with GBMs, I think a lot of the GBMs have a lot of GBM stem-like cells. How they affect immunotherapy, I think, is not really well known, although I suspect that they probably contribute greatly to the evasion from immunotherapy. And in fact, I suspect that they're the ones that are responsible for what we see as immunoevasion through those mechanisms that both Eva and I discussed.
Yeah, I completely agree. Both evasion and immunosuppression. I completely agree.
Thank you so much for sharing that. Now, I believe in your talk, you touched a little bit about the COVID vaccine. Can either of you share any insight on how the COVID virus or the vaccine may impact patients or impact these trials at all?
I can be happy to take it. So we don't know. We don't know if we don't think the vaccine impacts therapy or impacts the tumor. I don't think we've seen any. And again, the vaccines have only been around for 6 or 7 months, and so it's very hard to know exactly if they would impact it. But I don't think they do personally. I think that there's probably very little impact. Definitely, there's no impact on the therapy or on your tumor itself. But I don't know whether the vaccine, by stimulating immunity, may make your tumor also more responsive to your immune cells, but that is totally unknown.
So I would approach this question, I agree with Nino, I would approach this question 2 ways. One is, first of all, the issue of the COVID, the disease in cancer patients. And we know cancer patients have a higher likelihood of dying from COVID. So for our attendees, if you have not vaccinated, please, you have not been vaccinated, please do so. The second part is the vaccine, how the antibody response against the virus can impact the effectiveness of virotherapy or immunotherapy in the brain. In one of my favorite viruses is measles virus. Measles virus is an RNA virus like coronavirus. We have strong immune response against the measles virus. Actually, 90% of the patients in the US have an immune response because they either got the disease when they were children or they are vaccinated. So we have done experiments where we tested that and the efficacy in the context of vaccinated animals. And what we found is that actually the presence of a systemic immune response is not going to impact the activity when you administer these agents in the tumor environment. If anything, as Nino said, can increase your likelihood for response. So I have absolutely no concern about being vaccinated as that being as a negative factor for the effectiveness of virotherapy or immunotherapy. The last thing I want to say, some of the best things for humanity have come out of the worst enemies. So coronavirus is an RNA virus, and every time that Dr. Koka and I see a virus, we see an opportunity. So it might be that some of the things related to this virus and the genome down the road, where we're over the pandemic, we may be able to actually use it to devise a new and better treatment for tumors, including brain tumors.
Thank you both so much, Dr. Galanis and Dr. Kioka. For those of you who need to take a quick break, please take this opportunity to do so. We invite the rest of you to stay on to hear a research update, and we will return back in just a few minutes for our next session on a very important topic titled Managing Mental Health After a Tumor Diagnosis. Thank you so much and see you shortly.
Hi, my name is Gary Cohenbush, and I'm currently an assistant professor at the University of Pittsburgh. The title of my talk today is Theranostic Antibody for Improving Glioma Immunotherapy and Immune Monitoring for Glioma. The study was made possible by a 2020 ABTA Discovery Grant supported by the Southeastern Brain Tumor Foundation. Today I will talk to you about theranostics. Theranostics are single agents or drugs that can be used both for therapy and diagnostic imaging. When a theranostic is used for therapy, it will be labeled with a specific radioisotope that can kill target cells. And for diagnosis, the theranostic is labeled with a radioisotope that can be detected by a PET scanner or other imaging. My lab focuses on brain tumor immunity, and it is well known that immune cells can cross the blood-brain barrier, find and kill tumor cells. However, cancers, including brain tumors, are infiltrated by multiple other cell types that promote tumor proliferation and immune escape. One of these cell types are called TAMs or TAMCs, and these cells are important in brain tumors as they can account for up to 30% of the tumor. They are not tumor cells, but they promote tumor growth, therapy resistance, and importantly, reduce the effectiveness of immunotherapy. There are multiple trials targeting TAMs in glioma and other brain tumors. So our idea was to develop a theranostic targeting TAMs to measure TAMs in patients by PET imaging and to kill the TAMs to allow immunotherapies to work better. So we chemically modified an antibody that can bind to TAMs so that we could label it with radioisotopes for either imaging of TAMs or therapy to kill and deplete TAMs. We first tested our theranostic for diagnostic imaging. We injected it into mice with brain tumors or mice without brain tumors. Here you can see the yellow dot, which is a PET scan image of our theranostic successfully binding to TAMs, indicating that our theranostic can detect TAMs within a tumor successfully. We next use our theranostic as a therapy by labeling it with lutetium-177. Once again, we administered the theranostic into mice. We then removed the tumors from these mice and assessed in the lab if our therapy was successful. If you look at the graphs, which show two types of TAMs, you can see that in the tumor, with two different doses of our therapy, that we were able to successfully reduce TAMs within the tumor. Since we were successful at reducing TAMs, we next tested if we could use our theranostic to reduce TAMs to make immunotherapy more effective. So for this study, mice received 2 doses of theranostic in combination with an immunotherapy called checkpoint immunotherapy. Here you can see the blue line that mice treated with combination immunotherapy and theranostic survived significantly longer than either therapy alone. We also performed MRI on these mice and found that the mice treated with the combination had significantly smaller tumors than untreated mice. Finally, a key part of this ABTA-funded project was to test multiple amounts of antibody and radioactivity for safety. At high doses with single injection, mice became sick and experienced significant loss of total cells in the blood. But at doses from the last slide that prolonged survival, mice still maintained safe number of immune cells in blood. So in summary, our newly developed theranostic may be a tool to monitor efficacy of TAMC-targeted therapies in brain tumor patients and to reduce TAMs to slow tumor progression and improve immunotherapy for brain tumor patients. I want to acknowledge the others who have contributed to this project and once again thank the ABTA and the Southeastern Brain Tumor Foundation for making this work possible.
Welcome back. Our co-chair, Dr. Sean Hervey-Jumper, will introduce our next speaker.
All right, folks, we're getting close. We have a couple of really important topics to cover, and I'm thrilled to introduce our next speaker. So we understand that a brain tumor diagnosis is a life-changing event that not only affects someone physically, but also emotionally, even influencing our personal and professional relationships. And these topics often go unaddressed, but not today. So this is why we have our next topic titled Managing Mental Health After a Brain Tumor, After a Tumor Diagnosis. And our speaker, Ashley Logan, is a clinical neuropsychologist at Virginia Commonwealth University, Massey Cancer Center. And not only is she just a phenomenal person, but she's really one of the field's foremost experts in mental health for patients with brain tumors. So please welcome Dr. Ashley Logan, and we hand our controls over to her.
Thank you so much, Sean. And thank you to the ABTA for inviting me. I'm excited about this presentation and to get into some great discussion about mental health after a tumor diagnosis. Here are my disclosures and support. Also an added disclosure, any real life photos that I used in this presentation, we did receive permission from. So my hope during this talk is to go over, like Sean said, mental health. I want to talk about what do we know, how can we manage it, and where do we go from here? So I will start off with what do we know? We know that we have moved beyond just treating the tumor. We now look at the whole cancer survivor and treat the entire person. So this not only includes the biological aspects, the tumor, treatment, side effects, but it also takes into consideration the psychological aspects or the mental well-being and mental health of our patients, and also the social aspects, so socioeconomic status. How much support does our patient have? Do they have access to our healthcare and our services? We really look at the person as a whole in this biopsychosocial model. We know that distress is exorbitantly high in patients of all different types of tumors. But we also know that our patients with brain tumors are at higher risk. So why? There is a high certainty of tumor progression. Despite science's best efforts to date, we do not have curative treatments. And because of the placement of the tumor in the brain, the treatments affecting the brain, this disease impacts a person's functioning and overall quality of life. And unfortunately, to date, there is no standard of care for supporting mental health in neuro-oncology. So next, I want to talk a little bit about the types of distress that we see in our clinic and with our patients. And the first one is depression. And most people have heard of depression. It's this overarching sadness, loss of interest, a feeling of limited motivation or worthlessness. Nearly all brain tumor patients report symptoms of depression. In fact, up to 95% report that they have experienced it during their disease trajectory. And 30% of those go on at some point to receive a clinical diagnosis of depression. Now, this is much higher than other cancer populations. Other cancer populations, the rate of a diagnosis of depression is only 13%, and that's compared to 7% in the general population. Now, depression can present as a whole host of different symptoms. It could be psychological, that is the traditional sadness, loss of joy, loss of pleasure. It can also be behavioral, where a person is extremely fatigued. They spend the day in bed. They aren't hungry anymore. And it can also be cognitive, where they have a reduced sense of self-worth and self-esteem. Now, what is interesting here is some of the areas that I just talked about can also be a result of brain tumor treatment. So we have to be really careful at how we diagnose depression, to make sure that we are actually looking at the mental health or distress of depression and not just the effects of treatment. So depression is associated with functional day-to-day impairment. It can produce cognitive dysfunction, including reduced speed of processing, distractibility, poor memory, and it is actually the main predictor of reduced quality of life in our patients over and above the tumor surgery and the adjuvant treatments. It has also been shown to reduce survival. Those who have been followed who were meeting criteria for depression versus those not depressed, they had a lower survival rate. Now, it is across grades that we see this depression. There's some research out there that says that tumors in the left hemisphere might be more common to have depression. However, the literature is still mixed, and I'm not yet willing to put my my finger on that one. We are still investigating. So the next area of distress I want to talk about is anxiety. So this is a general anxiety. This is that sense of worry, sense of gloom and doom, almost like a panic that we walk around our day feeling. About 17 to 31% of our patients report moderate to severe levels of general anxiety. There are some documented risk factors for anxiety. Low-grade tumors tend to report higher levels of generalized anxiety, and tumors on the right side of our brain. This parallels what we find in other brain injury literature. So traumatic brain injury, stroke, white matter disease on the right side also tend to have increased rates of anxiety. Females tend to report higher levels of anxiety, and those of younger age. Now, what is interesting about anxiety is symptoms tend to be transient, so they wax and wane, meaning there's times of heightened and times of lowered, and those heightened associated times seem to be around the MRI, which most of the patients here that are listening or the caregivers will know this term very well. If it comes up, scanxiety. I'm not sure I've met a patient that hasn't talked to me about their fear the week before the MRI and their scanxiety. So what is underlying this fear? It is the fear of the tumor coming back. Now, what's interesting in brain tumor patients is that this is not an irrational fear. One, this is how they found out, right? They've had the experience of diagnosis, going into an MRI machine and being told that devastating news afterwards of you have a brain tumor. So they've lived through this before. And they know most patients are going to experience a recurrence at some point. So they know that it's coming, they just don't know when. About 50% of cancer patients describe this fear of cancer recurrence. And it is actually documented as one of the greatest unmet needs across oncology populations. Nearly all brain tumor patients report symptoms. Here's what's also interesting though. Treatment should be dependent on the severity. So mild fear of cancer recurrence is actually very common. Like I said, almost everyone reports it, everyone experiences it. But if it's at a low, mild level, oftentimes through repeated experience and exposure of going through those MRIs and hearing stable results, this lessens through time. But if it is up at that moderate to severe level, it can cause some pretty devastating adverse effects. It can cause avoidance patterns where patients don't come to their MRIs. They're scared to know what the results are. Or on the flip side, it can cause this hypervigilance, whereas somebody thinks every single thing that they feel in their body or their brain means the tumor is back, and they're asking for scan after scan after scan. This actually hasn't been studied in brain tumor patients as far as the hypervigilance, but it has been extensively studied in breast cancer and melanoma. If you think of a patient who does self-checking of their breasts 100 times a day, or looking at their skin over and over again to make sure there's no additional spots. In brain tumors, we suspect it is more likely to be when they have word finding. They can't come up with the word. All of a sudden they start in their mind a spiral of, oh no, does that mean my tumor is back? Or they trip and fall coming in from the car, and all of a sudden they're like, oh no, I had a fall. Does that mean my tumor is back? Moderate to severe fear of cancer recurrence can produce an inability of living meaningfully and planning for the future. Another distress construct is this fear of the future. I have my patients ask me all the time, what does the future hold for me? What does death look like? How is this going to happen? And what is my family going to do? In the literature, in the research world, we call this construct death anxiety. This is common in advanced cancer patients. About 32% have been found to have moderate severe levels of the fear of mortality. But we in our lab just assessed this in brain tumor patients, and we found 48% of brain tumor patients have death anxiety, to show it's a significant concern. Now, high levels can be associated with decreased quality of life, medical non-adherence, and poor health outcomes. What we have found in our studies is that this happens across grades, this happens across tumor locations, this happens across genders and from young to old. Also, the top-rated death anxiety symptoms appear to be the fear of becoming a burden to others, and also the impact of their death on their loved ones. And lastly, the third that comes into play is this loss of opportunity. So are there going to be milestones or events that I had planned for in the future that I'm not going to be able to obtain or enjoy experience? There's this idea of a dynamic existential trajectory, which really means that it is through the course of a disease that it might change. This hasn't been studied quantitatively, so with actual data numbers, but the patient's words through focus groups and interviews have told us that after diagnosis, it's skyrocketing, and then it kind of has its ups and downs through treatment. And as the patient gets closer to the end of treatment and to the end of their disease trajectory, they come to find more acceptance and are able to reflect back on life and find more meaning and purpose in what they were able to experience here. And I would be remiss if I didn't also talk about the caregiver mental health, because we know that having a brain tumor is not just an individual diagnosis. We know that it significantly affects the caregiver, the whole family, and friends as well. So a caregiver immediately takes on additional responsibilities. They begin to, from the day of diagnosis, monitor their loved one's illness. They are communicating with doctors at a level that they probably didn't expect and a language that they don't understand. They're arranging medical appointments, and at the beginning of care through radiation can be significant. They are going into the hospital every day, they're getting labs, they're checking in with their physicians. They are providing physical, emotional, and social support to the patient. But interestingly, they're also providing that to everybody else as well, because they're the gatekeeper between those who love the patient and the patient. So they're constantly jumping back and forth, trying to manage everyone's emotions and distress level. And then lastly is this decision making. They all of a sudden are thrown into the driver's seat of their loved one's life, having to make some very serious and heavy decisions. And unfortunately, there's no formal training for this. It's not like we have this year to get ready to become a caregiver. Okay, you have a year until your loved one's going to be diagnosed. It's time to start planning. Here's a course. We need to prep for this. It is, they go to bed one night, they wake up the next morning, and their role has changed. So we know, again, the literature has showed us that caregivers experience reduced quality of life. But what is interesting is that the caregivers actually experience higher distress levels than the patients. Through all of the research I just told you about, depression, generalized anxiety, fear of the tumor coming back, and a fear of the death and dying, our caregivers are rating higher levels of distress than the patients themselves. So what does that tell us? We need to be treating the caregivers also. Okay, let's take a shift here and talk about how can we manage all of this distress that our patients and loved ones are experiencing. So I'm going to talk about medicine first. And the reason I'm going to talk about medicine is because it continues to be a physician's first line of treatment for mental health. Yet, there are absolutely no high quality studies that have shown that it's useful in brain tumor patients. And trust me, I have looked. About 25%, so a quarter of patients with low grade brain tumors will be put on depressants, at some point in their disease trajectory. And nearly half of malignant brain tumor patients will be put on antidepressant medicine. Unfortunately, there's a lot of contraindications though. We have to watch out because it lowers the seizure threshold, it increases patients' memory impairment, and it increases their fatigue. These are three of the top concerns that our patients report to us going through the disease trajectory. So what else can we do, right? Let's take another approach besides adding on another pill to our patient's load. What we do in our clinic is start out with basic mental health strategies. How do we teach a person how to live well, brain tumor or not, to be honest with you? So the first one is exercise regularly. We tell patients, move your body. I know you're tired and you don't want to believe me, but it actually combats the fatigue if we move our body. And I'm not talking going out and running a marathon tomorrow. Research has shown that just 15 minutes a day of a vigorous, and this isn't, running, this is just walking outside, actually helps with fatigue, it helps our concentration, and it helps our mood. We tell our patients to maintain a healthy diet. Think of your brain as, we need to fuel our brain. We need to fuel our body. So we need to be feeding it good, healthy choices. This next one, get sufficient sleep. I cannot overemphasize this. The analogy that I use, a metaphor that I use with my patients is to think of a phone charger, right? You use your phone all day long. And at the end of the night, before you go to bed, what does everyone do? We plug our phones in, we give it through the night to recharge so that when we wake up, our phone is fresh and it can carry us through the day in all of our communication. Think of your brain and sleep the same exact way. When we go to sleep at night and sleep well through the night, we are recharging our brain so that we can wake up fresh and ready to take on whatever that day holds. And it's even more important for brain tumor patients that might have some damage in their brain. So they need an extra boost anyways. They need that energy to get through the day. We've actually shown that 62% of our patients have sleep disturbance and another 22% meet criteria for insomnia. But unfortunately, about 60% report that they don't feel it's being well managed by their medical team. So this is an area that we need to be studying. We tell our patients to get up, move, like I said before, go outside, off the couch, off the bed. Even if we have mobility issues, we can go. I have one patient who every day goes up and down their driveway 4 times. It is a goal that they set for themselves and they are getting up off the couch and moving, getting that fresh air and that sunshine. We want you to surround yourself with positive social support, engage in pleasurable activities. Don't give up your hobbies. This is what brings you joy. We might need to get creative on how we manage those hobbies or enjoy them, but you can and you will and you should. Also experience new things. This is really important for the brain. So I also tell patients, think of your brain as any other muscle in your body. The more we use it and work it, the stronger it's going to get. Our brain is the exact same way. So I want my patients out there learning new things. I've had patients learn new languages. I've had patients read books. I've had patients go out and take up a whole nother hobby that they've never even explored before. This is what I want them doing because I want them making new connections in the brain. It's possible that through surgery or radiation, we have damaged the signals in the brain or the connections. But there are some signals and connections that are still working. So I want to strengthen those. And I want my patients to be an active participant in that. So again, these are basic mental health strategies that every one of us could benefit from. We should all be doing. What if somebody is doing all of this and they're still telling me, I am so sad. I am fearful of the future. I can't move forward from this diagnosis and live meaningfully. That is when I would recommend to them that it's time to take the next step. And what that looks like, the number one thing is to go into your provider and ask for a referral for a mental health practitioner. Now, as some of the speakers were talking about yesterday, there are some of us that are at large academic institutions that have a whole host of services, but there are a lot of patients that are listening to this call that might be at community centers that don't have that. So there's kind of a chain here. You ask for a neuropsychologist, you ask for a clinical psychologist, somebody who is specialized to provide this care. But if you don't have those at your facility, you can ask for a counselor. Social workers are amazing. They have access to all opportunities in the community and can connect you to all of those services. Honestly, your nurse is probably become a pretty significant person in your life through a brain tumor diagnosis. They have the ability to talk with you. They understand what you're going through. And also reach out to your local pastor or clergy member if you belong to a church. So once you have connected with somebody, it's really important to determine what your symptoms are and how severe they are, because that is going to guide our evidence-based treatment. So here are the evidence-based treatment options that have been studied and shown to be successful in brain tumor patients. So we have our relaxation skills, our deep breathing, our progressive muscle relaxation. This is where we get in a state of calm and we learn how to combat those distressed thoughts and feelings and calm our body, which then calms our mind. Courtney was amazing yesterday when she talked about her practice of mindfulness and meditation, being present, living today, not worrying too far ahead in the future. These last three are a little bit more higher level. You might need somebody who has been trained in them. Directed attention training actually works for that fear of the cancer recurrence. So it's when those thoughts or fears enter your mind, being able to redirect your attention to something that brings you joy. So for example, if I'm worried about my scan that's coming up tomorrow, and I'm noticing that my mind is starting to spiral, I have practiced redirecting my attention towards my dog and taking him out, and I know exactly what I need to do to pull my mind away. So it is directing your attention to something else. Goal management training is more to do with the cognitive impairments that we experience that leads to increased frustration and distress in our patients. So a prime example for this is my patients tell me all the time, I go to the grocery store and I can't remember what I was supposed to get. Goal management training would help a person write down the steps of what they need to do when they decide to go to the grocery store. They write a list. They plan for exactly the route that they're going to go through the grocery store so that they don't forget anything. So it's basically planning through those cognitive challenges. And then finally, the gold star of general distress treatments is cognitive behavioral therapy, which most clinical psychologists have been trained and counselors have been trained to provide this type of therapy. And the underlying basis of this basically is that our thoughts and our behaviors and our emotions are all connected. And so we need to get out of the loop of negative thoughts, which produce negative behaviors, which make us feel bad, to positive thoughts, purposeful behaviors, and obviously positive emotions. So what I wanted to do now is I wanted to jump to a quick case presentation. I just wanted to tell you an experience we had with one of our patients and how we helped her with her mental health. So our patient here that I'm going to talk about is JC. JC was experiencing exhaustion. She was experiencing numbness in her fingers and difficulty swallowing for a couple weeks. So of course she went and talked to her medical provider, who suggested an MRI. What they saw in the MRI was inflammation or expansion of the brainstem. And I should have put a picture of this on the screen. I apologize, but if you can see me, it's basically the part of your brain that connects the brain to the spinal cord. And so their differentials were, could this be multiple sclerosis or could this be a brainstem glioma? So they threw a whole bunch of steroids at her, didn't get better. So they suggested, or they thought it was the glioma. Now, what you need to know about a brainstem tumor is often they're inoperable. And some physicians won't even, or surgeons won't even do a biopsy on them. She was lucky enough to have it in a place they felt they could safely do a biopsy. So the results came back as an astrocytoma grade 3. So she underwent the standard of care radiation and chemotherapy. Now, I had the pleasure of meeting JC early in her treatment, and I did a full neuropsychological evaluation on her. Now, JC was in her 50s. She was an art major through college and continued to do that as a hobby, but she actually helped her husband in their private business. She ran all the financials and the administrative duties of the family business. So when I met her, we determined she had extremely high intelligence. She was high average to superior across the board for her cognitive functioning. But she was noticing this physical decline. She was having difficulty walking. She was having difficulty swallowing, which made eating hard, and she was starting to gain weight. At this point, she did not have emotional distress, but she told us about a history of depression that she was concerned would reoccur now that this had happened in her life. So initially we set her up with, we helped her get disability benefits. She pulled out of the family business. She just wasn't able to keep up with it physically. We got in-home PT. We made sure that her home was safe for her to move around with. She was using a walker a lot of the times at this point. And we suggested some local therapy providers. She lived about an hour to an hour and a half away from us. So we told her, here are some resources, keep them in your back pocket if you feel this depression starts to creep in. So fast forward about 4 months later, and she shows up in our clinic again. This time she's in a wheelchair, and she's telling me that she's using a walker at home, but she's pretty much not able to do anything around the house anymore. She is able to maintain self-care, meaning she can shower. It takes a long time. She can put on her top. She needs help with her bottoms. And she can keep up with her medicine, although her husband was checking behind her. But she said that that depression had creeped in, that she was experiencing some significant fears and sadness. And so what we did, she had reached out to those people we had connected her to, and unfortunately they had 6 to 8 month waiting lists. And that wasn't an option for her given her diagnosis and what the prognosis was. So we set up care for her at our institution. She drove an hour, she didn't, her husband drove her an hour and a half every other week to see one of my amazing trainees. Now, here's the support we provided. My trainee worked with this patient for about 4 months. They worked on a mindfulness and creating a meditation tradition practice every day. She focused on being non-judgmental of her experiences, savoring those short bouts of functioning. So when she was able to walk, to enjoy it, because they were things that she missed, just those simple pleasures that we take for granted. We helped her reduce catastrophic interpretations of her body sensations, which what that means is every time something else would decline, she felt like, okay, this is the end. I'm not going to make it to tomorrow. So we helped her realize that that wasn't necessarily the case, that this was a trajectory and a disease decline, but this wasn't going to jump to tomorrow. So not to catastrophize it. And we really contextualized those negative thoughts. We helped her with value exploration, finding ways to achieve meaningful goals and focus on accomplishments and strengths. Now, if you remember, I told you this patient was an art major and did it as a hobby. So my trainee tapped into that. She encouraged her to continue producing the art that she was able to, which was large knit hooking. And she did it for relaxation, she did it for productivity, and she also did it for emotional expression. I'm not sure you can see on there, but she put her mantras on this artwork. Still and quiet, peaceful and calm, health and strong. So I had the pleasure of seeing this patient one last time in the hospital before she was sent home for hospice care. And though she could not speak well at the time, she was able to thank us for what we had helped her through. And I'll never forget when she told my trainee that she had been a ray of light during this horrific disease. The one thing this patient said she wanted to experience, that one milestone before she passed, was to have a mother-son dance at her son's wedding. And she gave us permission to share this picture. This is her a few months before she passed, having that wonderful mother-son dance at his wedding. Okay, so quickly, I know I'm running out of time here. Where do we go from here? Because we are nowhere close to being able to treat all of our patients' mental health and aren't really to do that. So what I wanted to let everybody know is that we are currently investigating some interventions that have been shown successful in advanced cancer patients, but have never been tried or adapted for brain tumor patients. So we're trying to do that. If they're shown to be successful, we hope to roll them out to the field and to providers all over. The first one is called Managing Cancer and Living Meaningfully. This is a psychotherapy. It's a brief psychotherapy, about 6 sessions, where patients have the opportunity to discuss their symptoms, discuss their relationship with themselves and how that has changed, and their relationship with others. It has a really heavy focus on finding meaning and purpose in life through the dying experience. And how is a patient able to hold both, which is something called double awareness. Knowing that I have an incurable disease, but being able to live every day with meaning, purpose. This one is currently under investigation. We have it open at our site at VCU, and I know NIH also has it open at their site. The next one I want to talk about is cognitive behavioral therapy for insomnia. If you remember, I talked about how important sleep is. And actually medicine, even though it's the first thing done when a patient says, I have sleeping problems or insomnia, it's the first thing prescribed, it's actually not the best evidence base. Cognitive behavioral therapy for insomnia is the first line treatment for insomnia. So one of my amazing trainees and graduate students is studying this. She is providing cognitive behavioral therapy for insomnia to our brain tumor patients in hopes that we can have another option for our patients besides just giving them more medicine. And last but not least, we have yet to start studying this, but this is an intervention called Conquer Fear. It was created out of Australia, and it's actually for that fear of cancer recurrence. So that's anxiety. It's specifically preventative and skills-based. So we're teaching patients what to do when they have these thoughts and fears before their MRIs happen. There are some adaptations that need to be made, which we are hoping to get funded and be looking at it over the next year. It was created or at least investigated for breast cancer and skin cancer, and I believe prostate as well. And the brain cancer is just a different trajectory with some different fears that we talked about before. But this is another one to keep your eye out for in the future. So in sum, I know I'm out of time. I want you guys to leave with this thought. Mental health is health. And now as a field, we appreciate that. But mental health is a significant concern for our brain tumor patients, and we still have a ways to go to help treat. Because while quantity matters, the scientists need to continue to try to find a cure for this devastating disease. But in the meantime, we need to make sure that the quality of life of our patients is as high as it can be. And one challenge we have with that is ensuring that the resources are accessible to all brain tumor patients. One positive with COVID is that it has allowed us to expand a lot virtually, like this. Some patients that are listening to this call would not be able to necessarily attend the meetings of the past, but they're able to hear this wonderful information. The same thing is happening in our clinic. We are converting our interventions, converting our testing to virtual formats so that people out in the community that don't have access to the good resources at my institution or others that you've heard from today can still have access to our care. And then I need to thank my lab because their efforts do not go unnoticed. All the work that I've talked to you guys today have been a product of my team and how hard that they work for our patients. Our lab is called Live Now Lab. Feel free to reach out to us anytime. And of course, I have to thank our patients, our caregivers, and the funding resources that we have. And I'll hand it over to questions now.
Thank you so much for that wonderful presentation. We do have time for questions. As a reminder, if you have a question that you would like to ask, please type and submit it using the Q&A box button on the bottom of your control panel, and we'll answer questions as time allows. So one of the first questions that we have here is asking, can either the brain tumor location or the treatments that a patient has undergone, can that impact the patient's ability to manage emotions?
Yeah, that's a great question. So I think it depends on what kind of distress we're talking about. Again, like I said, the fear of the cancer recurrence and the death anxiety appears to be across locations, across grades, and across treatments. The treatments don't seem to impact the severity of that fear of the future. Depression and anxiety, I think it can. I think it has a little bit more of an impact on. There are locations in the brain like the frontal lobe that we can't regulate emotions as well, but that's why that's that mental health provider referral that I was talking about. So if somebody is having a hard time managing those emotions, and especially if they think it's because of the brain tumor or the surgery or the radiation that they've undergone, ask for somebody that is knowledgeable about the brain that can help you, because a neuropsychologist is going to understand brain function and not only help you work through it, but help your family and your loved ones understand why your behavior patterns are the way that they are and help you work through that as a team.
Thank you so much. And just a follow-up question on that, do you have any advice on how patients can find neuropsychologists? Are they readily available at all treatment centers, or how can they?
I wish they were. I wish I had better news. Unfortunately, they're not. There's probably 10 to 15 of us in the country that specialize in brain tumors, and you're going to find them more often at the large medical centers, the academic medical centers. But again, like I said, there are neuropsychologists are all over the place. There are ones that are private. There are ones that are at community hospitals. They might not be specialized in brain tumor, but they are going to understand the brain, and they can connect and consult with somebody like myself or others out there who do understand brain tumors and treatments more. Honestly, the best way to do it is probably to look on the internet. Because, and Google neuropsychologists in your area and see what pops up, and then just ask them, call them, ask them, see if they can send you to somebody that they know that specializes in brain tumors. There was another part of that question. Oh, the other part is, despite there not being many of us, a significant amount of us have transitioned our neuropsych testing to the virtual format. And we were forced to do that, obviously, because of COVID, but a lot of us have kept a blended model. I offer my patients either or right now. You can either choose to do it virtually if that's easier for you because you live 2 hours away and you can't drive anymore because of seizures, or if you're able to come in and get a more comprehensive eval, let's go ahead and do that. But we're still providing care to a wide range of patients that weren't able to have that care before.
Thank you so much for sharing that great insight. Another question we have here is asking, are you aware of any evidence-based practices or studies that are being done to help support children who are coping with a brain tumor?
Oh, that is such a great question. I'm not, only because I'm in the adult world. However, I do know that there's an amazing group at St. Jude's that studies interventions and treatments for children with brain tumors, and also up at Children's National Cancer Center also has a very heavy and large oncology focus group. So those are two hospitals that I would reach out to get connected with.
Thank you so much. Now, another question we have here is, you talked about some of the basic skills that patients and caregivers as well can do to help cope with some of the mental health issues, like going outside, getting active, engaging in hobbies. But sometimes it can be hard to start that. Do you have any advice on how to get over that initial hump and to just get started?
Yes. Pick one thing, one little thing that you didn't do yesterday. It could be to go get the mail today because your spouse has always, or your child has always gotten the mail for you. Pick one small attainable goal that you can check off that you accomplished. And then the next day, pick one more, or do the same one for a couple days and then pick more. But I tell patients, don't look at this whole presentation and decide tomorrow you're going to completely change your life. You're going to set yourself up for failure. Pick one attainable thing and work on that. And then when you've accomplished that, pick one more attainable thing.
Are you aware of where patients and caregivers can go to find maybe some guided meditations or some videos that they can follow to do that at home?
Yes, there are some wonderful online resources. There's actually a lot also on your phone. Nowadays, you don't even have to have a computer. You can open up your phone and go to the apps, and there are a lot of free apps that you can learn guided meditation, you can learn mindfulness and practice it on these apps. Like there's an app called Calm. So there's many of those that actually are evidence-based now on touch of our finger. We have all the access now. And then obviously, if they wanted something more community-based, they could look at their local YMCA has things. They can look at their Brain Injury Association close by, or I'm sure ABTA has great resources on their website.
Thank you so much for sharing that. Another question we have here is focused on the investigational interventions that you had shared toward the end of your presentation. Can you share where attendees might be able to find more information about those?
They can go, if I don't know if I can go back, they can go to our lab website, and that it explains a lot of them there. Unfortunately, right now they're still in the investigational process, so they're not open to everyone. So like I said, Calm is just at our institution at NIH, but it was developed out of Princess Margaret Cancer Center up in Toronto. So if a patient can go onto their website, they can find all the information about it. The cognitive behavioral therapy, that one is open to everybody. So if somebody is interested and they're experiencing insomnia, let us know and we will see if you are eligible to participate in the trial. And then the other one, the Conquer Fear, we do not have open yet because we do feel it needs to be adapted to brain tumor patients, and that's our next step.
Thank you so much. Now, another question we have here, sometimes, when a patient is newly diagnosed and they're actively undergoing treatment, they're in that fight mode where they're not really thinking about their mental health and they're just doing what they need to do. And it's not until after treatment has ended that things slow down and it starts to hit them. What advice can you provide for patients who are in that phase of their brain tumor experience?
That are in the after treatment?
After treatment, yeah. Now they're survivors and trying to cope all of that mental health stuff is hitting them now.
Yes. So it's good to put this stuff into practice before you actually need it. That's my first line of advice, is to not wait till you need it. Establish these practices so that they help protect you when you need it. The second thing is that same number one that I put, contact a mental health provider. They can help you at that time. But we actually just learned, we had a focus group of about 15 brain tumor patients. We were looking at kind of a roadmap or a navigation for mental health care in neuro-oncology. And they actually told us that it needs to be us that continues to reach out to them, because they are not always comfortable or believing they need it or feel they need it. But they said, if they were basically like, try again, right? Ask at initial diagnosis, ask after radiation, ask every time you come in. Do you want to talk to somebody? Is there anything you need? And the physicians need to be asking patients that. Every time they see them, they need to say, how is your mental health? Are you concerned? Do you want to talk with somebody? So that we can make these connections to the providers that are specialized with the patient when they need it.
Along those same lines, something that's being talked about a lot now is survivorship care plans. Is mental health support something that is being actively built into these care plans?
They should be. That's kind of a catch-22. So yes, they are, because like I said before, we have finally moved away, thankfully, from just treating the tumor. Right? So we are now treating the whole person. And we realize that that is not just about targeted treatment to the brain, right? We need to be treating a patient's overall well-being, their physical effects, their mental effects, their emotional effects, and also their community resources. And so, yes, these are being integrated into survivorship plans and should be, in my opinion, right after treat the tumor, provide emotional support.
Thank you so much. Another question is focused on caregivers. We understand that mental health is so important for the caregivers as well, but sometimes it can be hard as caregivers to focus on ourselves. What advice can you share for caregivers to kind of take that time for that self-care too?
Yeah. Those basic mental health strategies need to be implemented into your life as well, the caregivers, but also know that you're not alone. Reach out to other caregivers, talk to people that are experiencing what you're experiencing or who have walked this journey ahead of you. There is so much wisdom out there from others who have walked this path. Get involved in a support group. Also take the time for yourself. I know that caregivers often feel like they must 24/7 need to be with their loved one, but if you don't provide your own self-care and have a strong foundation, you can't be your all for the patient and for your loved one. And so building that in, making sure one day a week you go out with your girlfriends or your guy friends, have a guy's night out, you go get your nails done, whatever, and allow yourself, if it's planned, tell yourself, I am not going to feel guilty about this. I am making sure I am strong. So when I return back to my loved one, I can be strong.
Thank you so much for that wonderful and important advice. Unfortunately, that is all the time that we have for questions for this session. Thank you again for your wonderful answers, and I'm going to turn it back to Emily for the rest of the program.
Thank you.
Thank you so much, Dr. Logan, for sharing strategies with us to manage distress during a brain tumor diagnosis. I know that our attendees definitely benefited from this session, and it is such an important topic to address mental health mental health. And we are so glad that more awareness is being brought to it, especially for our community. So thank you. For those of you who need to take a quick break, please take this opportunity to do so. We invite the rest of you to stay on to hear a research update. We will return with our final session, our patient and caregiver panel that you don't want to miss, that will focus on symptom management. We'll see you back in just a few moments. Thank you.
Good afternoon. I'm Justin Lathia, a professor at the Lerner Research Institute, which is part of the Cleveland Clinic, and in collaboration with my colleague, Dr. Josh Rubin, who's a professor at Washington University School of Medicine in St. Louis. We were awarded a 2019 American Brain Tumor Association Research Collaborative Grant in memory of Victor Perez Maldonado. And the focus of our grant was trying to understand sex differences in glioblastoma. So if you take a deeper dive into the epidemiology, one of the first things that becomes apparent is there's actually a sex difference in incidence in brain tumors, as well as a variety of cancers. So what you can see on the left is differences in incidence in overall cancer between males and females, as well as differences in cancer or glioblastoma incidence in males and females. Now, if you take all of this information together and you look epidemiologically and you adjust for all clinically relevant variables, it actually turns out that males have a poorer prognosis of glioblastoma than females. And you can see that here on the survival curve, where males are in blue and females are in red. So you now have a situation where males get tumors or glioblastoma more frequently than females, and they have a poorer prognosis. And this was really the basis for our project and the things that we've been thinking about in our laboratories. So really the big question is, can we understand how these sex differences emerge? So as we think about the idea of precision medicine and treating every patient precisely, one of the first things that comes up is biological sex. So it's very clear a one-size-fits-all approach may not work because there seems to be sex differences in the epidemiology, the genetics, and the immune response. So we feel like once we understand the foundational differences between males and females, we can actually identify new therapeutic targets and in the end develop sex-specific approaches that'll help all patients. To really get at this, what we've done is we've utilized a 4-core genotype model to assess the differences between sex chromosomes and gonadal sex hormones, both in the molecular genetics as well as the tumor microenvironment interactions. And this model is very unique and allows us to pull these two aspects apart. So in general, with 2 X chromosomes, you end up becoming a female, and there's a specific set of sex hormones that are associated with being a female or that are elevated, and those are ones like estrogen and progesterone. However, in males, you actually have an XY sex chromosome complement, and there you have sex hormones like testosterone that drive things. So this model is very unique because you can actually generate scenarios where you have, for example, an XX sex chromosome complement actually growing in an organism that has testes. So allowing us to pull apart the differences between the two. And you can see that here on the right, where we have a pretty good idea of sex-specific interactions. But as you can see, what's blurred below is what's really driving that. And that's really what we're hoping to discover in this project. So we used a series of mouse models to address this. So we first looked at growth and stem cell frequency as a driver of tumor malignancy. And for example, in blue, that's XY plus. So that's sex chromosomes XY in a hormone testosterone situation, so in a male. And then the reverse would be XY negative. So that's again XY sex chromosomes, but in a female. So you can see there's different growth dynamics in this situation. So if you look closely at the chromosomal effects, which I'm showing you in the middle, you really don't see a difference between an XX and an XY. But what's interesting is you actually see that you see more stem cells in male tumor cells. Now, if you actually use this model and you ask the question about hormonal effects, you see something interesting. You see no difference in what's happening in terms of the hormones in the stem cell frequency, but you actually see a difference in growth. So this is really providing a first glimpse at the difference between sex chromosomes and hormones and how they may be altering these key aspects of tumor behavior. So we think using this model, we're really just starting to scratch the surface of what's going on. And I think at this point, we are now really well positioned to try to ask what genes are involved in these chromosomes and how do hormones actually alter the dynamics of tumor growth. And importantly, these studies were actually the foundation of a much larger collaborative grant, which we've since successfully gone on to receive, where we've expanded the scope of this to look at sex differences in the genetic and epigenetic makeup, as well as things like iron metabolism and immune response. So again, this 4-core model was really important for those studies. So we want to thank the American Brain Tumor Association again for their support.
Welcome back. The American Brain Tumor Association understands it could be difficult for family and friends to understand what you are going through. By hearing from other patients and their caregivers who were also on this journey, you can find the encouragement and advice you need from someone who has walked in your shoes. That is why our next panel session is titled Living with a Brain Tumor Patient and Caregiver Panel, Addressing Symptom Management. Our speaker, Dr. Heather Leeper, who is an assistant research physician at the Center for Cancer Research, National Cancer Institute, National Institutes of Health, will first share key strategies and approaches to symptom management. She will then introduce our patients and caregivers serving as panelists and ask for their personal insight on how they have managed their symptoms. Please welcome Dr. Heather Leeper.
Thank you for the introduction. It is my pleasure to speak about symptoms and to facilitate the patient caregiver panel focused on symptoms. We are honored to have two patient caregiver teams on the panel, and we are so grateful for their willingness to share their experiences and insights. So I have no disclosures. Next slide, please. I work at the National Institutes of Health, and I am a federal employee. Fun fact, the National Institute of Health is the largest biomedical research agency in the world. It's headquartered in Bethesda, Maryland, which is just outside Washington, D.C. Its director is Dr. Francis Collins. Maybe you recognize him from TV. He's been on quite a bit lately. Next slide, please. What is person-centered care? So let's start by first taking a couple minutes to answer this question. Next slide. Many of the presentations today and yesterday were about tumors, how to diagnose them, what's driving their biology, ways to treat them. This system of thinking about the tumor or the disease as the focus of medical care is referred to as the biomedical model. It's depicted here on the left. The overall US healthcare system, like in many countries, is based on this biomedical model, and it is what drives healthcare decision-making. There is another model of healthcare called the biopsychosocial model. It's depicted here on the right. It has a person experiencing symptoms of illness at its center, of where biologic, sociologic, and psychologic factors intersect, also referred to as patient-centered care. Some key biologic factors are one's age, sex, genetics, body physiology, health status. Some key sociologic factors are gender expression, one's relationships and roles with others, what kind of social supports, and things of this nature that exist at home and at work, one's social networks, one's relationship with one's faith community, and in a larger sense, one's social standing within society. Last but not least, some very important psychologic factors include who we think we are, the story that we have about ourselves, your mental and emotional well-being, and how you cope with stress and adversity, good news and bad news, as well as your beliefs and expectations, among other things. Next slide, please. Now that we know a little bit more about the biopsychosocial model, let's talk about examples of care which you might have already received that are based on this. The most prominent example is nursing, which is widely delivered throughout the US healthcare system. For those of you who have participated in rehab, the specialties that work in the rehab field, such as physical medicine and rehabilitation, physical, occupational, and speech therapy, all use a patient-centered approach to guide their interventions and decisions about how to help you improve your function and your abilities and to keep you safe. Next slide, please. These also provide patient-centered care, but you may be less familiar with them. So let's go over them. Survivorship care is not a specialty, but rather a means of providing patient-centered care focused on those who are living with and through cancer. It aims to address symptoms and concerns of people living with cancers, including brain tumors, due to the effects of the cancer and its treatment. There is no standard way that survivorship care is being provided, and unfortunately, it is not yet widely provided across the United States. It is provided by oncology and primary care practitioners, in survivorship clinics and programs, in academic and community healthcare centers. It's a big topic of discussion and research within the oncology field and has been for many years. It's actually something I'm very supportive of, and I'm interested in furthering for neuro-oncology patients and their care partners. We'll come back to this in a few slides. Palliative or supportive care is person-centered care for those living with any type of serious illness. It focuses on relieving symptoms and the stress of illness. It also aims to facilitate person-centered communication about treatment decisions and care options so that people can make decisions consistent with their goals, priorities, and values. Palliative care's ultimate goal is to improve the quality of life and to reduce the suffering of the person living with the illness and their caregivers. It is available anytime, but most commonly, people start seeing palliative care providers during or after disease-focused treatment. And hospice care provides comprehensive symptom management and quality of life focused care for the person and whoever that person considers family. This care is available when physicians believe the person has 6 months or less to live if their disease were to continue on its natural course. In summary, there is always care available for the person through palliative and hospice care, independent of tumor-directed medical care. Next slide, please. So let's circle back to talking about survivorship. The official definition of a cancer survivor is an individual is considered a survivor from the time of diagnosis to the balance of their life. Family members, friends, and caregivers are also impacted by the survivorship experience and are therefore included in this definition. This definition comes from the patient advocacy organization, the National Coalition for Cancer Survivorship, and has been endorsed by the National Cancer Institute, the NCI. It was actually written by a physician who was diagnosed with and treated for esophageal cancer several decades ago. Even though healthcare providers may refer to survivorship care and use the term survivor, we acknowledge that many people do not identify with this term or don't feel that it resonates with them, and we respect that. Next slide, please. Even if not everyone feels at home with the terminology, survivorship care aims to be inclusive of everyone by starting the care at time of diagnosis to encompass all experiences. It includes those receiving continuous tumor-directed treatment to lower their risk of recurrence or progression. It includes people diagnosed with tumors which are not considered curable, and includes people regardless of race, ethnicity, gender, sexual orientation, religion, or socioeconomic status across the lifespan. Survivorship care, thank you. Next slide, please. Thank you. Survivorship care recognizes that people living with and through cancer have concerns across many areas. Therefore, the goal is to address the physical effects, the emotional effects, the cognitive effects, the social effects, as well as financial effects. These can be from the cancer itself and/or cancer-directed treatments across time. By listing these domains, the aim is to identify the symptoms, needs, issues, and concerns so they can be addressed. So on that note, in the next slide, let's start talking about symptoms and how to manage them. Next, thank you. Research focused on people living with cancer has demonstrated that many people don't have just one symptom, but will have several symptoms at one time. As depicted here in this illustration from the National Cancer Institute Patient Education website, symptoms that are experienced together are called symptom clusters. The two clusters depicted here are the most commonly reported ones. Dr. Logan talked about in her presentation anxiety and depression. Well, it turns out mood symptoms and mental health issues such as depression and anxiety are not only common, but they are often experienced along with fatigue, pain, sleep, and cognitive issues. It is very important for providers and people living with brain tumors and their caregivers alike to be aware of this, that the person may be well experiencing multiple symptoms and therefore in need of more than one symptom to be managed at a time, and the need to have their whole person treated, because this is more likely to provide relief from the symptoms, the stress, and to reduce suffering than if you focus on just one thing. Next slide. So let's talk about what you can do to manage that symptom cluster of fatigue, depression, pain, sleep, and cognitive issues. And yes, it turns out that what Dr. Logan just presented about applies to this symptom cluster as well. It's really important that you exercise regularly, maintain a healthy diet, get sufficient sleep, spend less time being sedentary, get outside, interact with your social network and have positive social interactions, do things you enjoy, be open to new things, new experiences, and learning. Next slide. To take care of yourself and your spirit, to make a plan that balances rest and activity throughout your day. Try doing the things that are most important early so that if your energy runs out as the day goes on, you will have gotten those top 2 or 3 things that were really important to accomplish done. If you need rest, plan your rest time to be no more than 10 to 60 minutes and try doing that resting by early afternoon so that when it's your bedtime that you're sleepy enough to fall asleep. People who snore or gasp for air when they sleep or lie back are at risk for inefficient sleep. That means that their brain is not getting enough actual sleep, even though it looks like they might be sleeping. If you think these concerns apply to you, please talk to your provider about your sleep. Practicing good sleep hygiene is also really important. It's most important to stop using screens 30 to 60 minutes before bed, have the room where you sleep be cool and dark, and to get up and go to bed at the same time every day. This helps entrain your circadian rhythm as best you can. These are the same things that we can do to manage our everyday stress, our everyday fatigue. And this is true whether you are living with cancer, getting through the pandemic, any other major life events or stressors, whatever it may be. Fatigue is the most common symptom reported by people living with brain tumors. Things that you can do to manage your fatigue is to be well hydrated by drinking plenty of fluids like water and avoiding high-calorie sugary drinks, limiting caffeine and avoiding alcohol, eating small meals throughout the day. Uncontrolled symptoms, whether physical or emotional, can worsen or even cause fatigue in and of itself. So it's important that you be aware of how you are feeling and seek help, just as Dr. Logan was so eloquently pointing out in her presentation. Next slide, please. For those of you who have neurologic issues such as weakness, muscle tightness, and/or incoordination, there are several management options. Participating in physical therapy, occupational and speech therapy as appropriate can maximize your functioning and help you maintain that functioning. They can give you exercises to keep you strong, strategies to help you accomplish tasks and keep you organized and safe. You may benefit from having an assistive device like a brace, a glove, a sock, or using a cane or a walker. These therapies are usually available at most communities across the United States at hospitals, clinics, and outpatient therapy centers. Regarding the muscle tightness, there are medications that can be taken by mouth or Botox injections for those who need it. It is important to know that neurologic deficits of all kinds will worsen when you tire, and sometimes you just need to rest. Next slide, please. For those of you who have neurologic issues, such as difficulties with spoken and/or written language, reading, writing, typing, vision, memory, or behavior, there are also management options. Working with speech and occupational therapy can be extremely helpful. Neuropsych providers are also extremely helpful, as Dr. Logan was saying. However, they are a very precious, limited resource, even amongst academic centers. Some key self-management strategies you can use are to make lists, use schedules or planners to keep you organized, set timers and reminders for things you tend to forget, including things like when it's time to drink water, take your medications, remember it's time to go to the bathroom, and then to keep important items like eyeglasses, keys, wallets, phones in the same place so that you can find them the next time that you need them. Again, neurologic symptoms worsen as you tire out, so being well rested to perform at your best is important. Next slide, please. If you would like to learn more about ways to manage your symptoms or to see more information similar to what I've been providing, there are resources available. There is a brand new mobile app specifically designed for brain tumor patients and their caregivers to learn about symptoms and how to manage them. This app is freely available to everyone with an iPhone. I'm sorry, but the Android version is still in the works. We hope to get that done as soon as we can. The development of this app was led by Dr. Terry Armstrong, who is co-lead of the NCI Connect Rare CNS Tumor Program and leads the patient outcomes team at the Neuro-Oncology branch at the Center for Cancer Research at the NCI, where I also work. Next slide, thank you. The app includes a symptom log that allows users to rate their symptoms and functions, a self-care education section that guides users through learning how to recognize, manage, and report their symptoms and functioning, a care log that allows users to track their self-care activities, a calendar where users can add and review treatments, appointments, when symptoms happen, and what the user did to care for that symptom. And through the Connect functionality of the app, users can share their symptoms, functioning, treatments, and self-care activities with others through creating a report and sharing it. Next slide, please. All of the symptom management content on the app and the app download are freely available on the NCI Connect website, shown here in the slide. If you Google NCI Connect in all caps, like you see it here with the dash between the NCI and the Connect, the website should result in the search. The information, along with other freely available online resources about the topics I've covered in this presentation, will be available on the ABTA website, along with all the other information from this year's national conference. Next slide, please. The ABTA also has a wealth of important resources about symptoms, treatment, and many other crucial topics available on its website, shown here. If you go to abta.org and you look at the top menu bar and you cue yourself in to seeing the American Brain Tumor Association logo and you look to the right, you'll see the words about brain tumors. Once you put your mouse over that, you'll see this little drop-down arrow show up. And if you click on the arrow, this list that you see here will appear. Thank you so much for your attention, and I hope this presentation was helpful. And I think now we'll be able to transition to our panel. Serving on our panel is Rick and Debbie Fazo. Rick is a multiple brain tumor survivor diagnosed with 2 meningiomas and 1 acoustic neuroma. Presenting with Rick is his wife, Debbie. Our other panelists are Natalie and Brandon Burr. Natalie is an oligodendroglioma grade 2 brain tumor survivor. Presenting with Natalie is her husband, Brandon. Rick and Natalie both serve as ABTA peer mentors. Let's welcome them as they share their brain tumor experiences. Rick, I understand that at the time of your initial diagnosis in 2009, you were playing horseshoes at a barbecue. Can you describe the symptoms you were experiencing that indicated something was wrong?
Hi, good afternoon, Dr. Leeper. Good afternoon, everybody. Yeah, I was playing horseshoes at a barbecue when I lost all strength and coordination in the right side of my body out of nowhere. I could only reach halfway to the pin. When I tried to throw straight, I would throw sideways. And it was really concerning for me, and so caused me to go to my doctor, who sent me to a neurosurgeon, did some physical tests and said, yeah, you've got some weakness on your right side. We're going to do an MRI. So they did the MRI, and lo and behold, it showed that I had an enormous non-malignant brain tumor.
Wow. Rick, what was your reaction when you heard this diagnosis?
This was in 2009, and so I knew zero about brain tumors. I thought maybe all brain tumors are cancer. So when I got the call, I just kind of dropped the phone and put my head in my hands, and I said, I'm dead. And, left work because that's where they called me the day after, and went home and, tried to make it home, kind of in a daze. Again, I didn't realize that there were so many different types of brain tumors. I think there's 120 or more different types of brain tumors. So making any kind of diagnosis and treatment is very difficult. So my knowledge of brain tumors was pretty much nil. And so I thought, it was really a death sentence, and we know that that's not true.
Well, that sounds like that was a really traumatic experience. Debbie, Debbie,
yeah, for sure.
Yeah, Debbie, how did you respond to hearing this news when your husband came home?
I was in total shock. I'd never known anybody or heard of anybody ever having a brain tumor, so I didn't know what to expect. I was just in total shock.
Wow, that sounds like it was a really intense experience, life experience for both of you. Definitely. Thank you for sharing. Natalie, you also experienced some new symptoms, and that was in 2012. Can you share what your diagnosis experience was like?
Yeah, thank you for having us today. ABTA has been so helpful for me, so I'm honored to be here today. In 2012.
Feel free, Dr. Leeper, to just skip ahead to Rick.
Okay, I was hoping she might unfreeze. All right. So Rick, let's ask you some more questions. I was wondering if by the time your symptoms presented, it sounds like maybe your doctor thought your tumor had been growing for quite some time, like 10 to 15 years.
Yeah.
When you look back, is there any indication that maybe something was wrong?
That's a great question. So as we all know, hindsight is 2020. And so I did have a lump on my head. And so I did go to a doctor and, said, I got this lump on my head. I don't know what this is about. And I was very asymptomatic. I didn't have problems with headaches or nausea or sleeplessness or vision problems. So they said that it was probably just a calcium deposit. And, if anything presents itself to, let them know. And really, the symptoms that I had really mimicked things that could have been easily explained away. So, I was having this tumor grow in me, and I didn't even realize this beast was in my head, which is just crazy.
Yeah, that sounds really crazy. What advice would you share with others when they suspect something is wrong like you did? Now that you know what you know, what would you advise?
I would absolutely, let people know. The lesson that I learned was if you think that something's wrong, get it checked out. Again, MRIs were commonplace, but, you really had to have something wrong with you to get an MRI or a CAT scan. And so, when somebody in the medical profession tells you that you're going to live, you tend to believe them, right? But really, you're your own biggest advocate for your care. And so, do the research, go and get another opinion. Second opinions are always great strategy, and get it taken care of, get it looked at, and have some other people take a look at what may or may not be happening with you, right?
That is really, really good advice. Thank you for sharing that. Natalie, let's come back to you. I'm so sorry
about
for
that. I don't know what happened.
The blessings of the internet. You never know when you're going to show up, right?
I guess I can quickly just say I was at work. My right arm went numb, and I just had this feeling of just very foggy, didn't quite know where I was at for a moment. And my coworkers immediately came to me, or I went to them, and I couldn't remember where my husband worked to call him, because obviously I wasn't able to leave by myself. And so they were able to they knew where he worked, so they were able to look up the company that he worked for, and they gave him a call. And so he came and picked me up, and then the next day I immediately went and saw my primary care physician, and she was like, well, you know, let's get an MRI. You're young. This doesn't quite sound right. And so I went and got an MRI, and they called me like immediately and basically said that there was a lesion, but they weren't quite sure what it was. And so they set us up with a neurosurgeon, like, I think it was like maybe that week or the week after. And the neurosurgeon was like, well, it's in your motor cortex, so I can't do surgery. And so we just decided that that's kind of like where it kind of stopped there. And then they weren't sure exactly what it was at that time. So we went through about 6 months of trying to figure that all out. And then 6 months later, we ended up seeing a neuro-oncologist.
Wow, that sounds like a huge odyssey to go through, starting with a very frightening experience.
Yes.
Yeah, wow. Brandon, what was it like for you as Natalie's partner?
I was scared, for sure. Like the call that we got from the radiologist, like after the MRI came through, we were in the car together driving to my parents' home in Indiana. And so I got to listen in on the phone call. And that kind of led to like a weekend of just going down a rabbit hole and thinking the worst of the worst. And I think that's where, like, it's human nature to go to that place. And I think through research and thoughtfulness and reflection, we were able to kind of get those feelings under control and start, I guess, staying a little bit more positive and see what we can do.
Wow, well, thank you for sharing what that was like. It sounds, I can't imagine. That must have just been, like Rick's experience, also just really gut-wrenching. Maybe we could go back to Rick, and Rick, could you tell us a little bit about, since your initial diagnosis, it turns out you've had some other diagnoses come up, a meningioma and another one, and an acoustic neuroma. How did you come to find these two additional tumors?
So I was on a schedule of MRIs after my surgery. So, you know, kind of going back a little bit, my tumor was not cancer, but still it was, the doctor told me that I was within 2 weeks of dying, even though it was quote unquote benign brain tumor, because it hit critical mass at the barbecue, which meant that it crushed my brain down as far as it could go. And it actually pushed my skull up, which was the lump on there, about 4.5 centimeters. So it had nowhere else to go. So he said, if I wasn't playing horseshoes, I would probably be dead. I would either had a grand mal seizure, or I would have just slipped into a coma that I never would have came out of, and I would have just expired. I would have perished, and I wouldn't even have known what the heck was going on. And so 10.5 hours of surgery, spoiler alert, I lived, but they couldn't save my skull. My skull was compromised because my tumor was so huge. So I have titanium all the way around here. So it's a titanium plate that's in my head, and some of the collateral damage from my non-cancerous, my quote unquote benign brain tumor, was that I was paralyzed from the waist down. And so, you know, going back to the occupational, the physical therapy, the stress, getting caught in the tall grass, you know, or going down the rabbit hole, as Brandon was saying, all of those things happen, right? So, you know, you go through the 5 stages of grief, things like that. And it took me months to learn how to walk again, and thankfully things hooked up. So I do walk again, but I was getting annual MRIs. 2 years later, it showed that I had a small meningioma right here, which is still there. So that's residual. And in 2016, I found that out of nowhere, just a snap of a finger, I went deaf in my right ear, and I was having problems with balance and falling and walking. And they diagnosed me with an acoustic neuroma wrapped around the 8th cranial nerve. So I had radiation to stop the growth. So it did stop the growth of it. So I still live with 2 brain tumors in my head, but I'm clear so far as of my last MRI 7 months ago.
Wow, well, I'm glad to hear that things have stabilized, and thank you for sharing what it was like going through all of the post-surgical recovery. Do you have any symptoms that you still need to manage on a day-to-day basis?
I do. I have balance issues every day, so I have to be careful when I'm walking. In the wintertime, I'm very cognizant of what the weather is, and so ice is not a friend of mine. So I do use a cane in the wintertime, but you know, I still have some paralysis in my ankles and in my feet and my toes. It's manageable. I don't even think about it. And I have pressure in my head because of the plate. So when the barometric pressure is, you know, goes really low, we just had a couple of hurricanes come through here in Pennsylvania. I felt it completely. So that's where some of the pain comes in. So my pain usually is at a level of, it's probably a 3 or 4 every day. But honestly, unless it really ramps up, when the pressure goes down, I don't even really notice it. It's just kind of part of who I am now.
Okay, so it doesn't sound like you need to manage it on an ongoing basis. It's kind of as needed.
It is as needed. So, you know, I do have to be careful when I'm walking and things like that, but nothing that isn't manageable, right? The one thing that I do have to manage is something that Dr. Laughlin was talking about previously, was the fatigue. You know, it's a different type of fatigue, and I don't know if Natalie feels it, but man, oh man, it's just like it's crushing fatigue. It's not like you're tired. It's just all encompassing, and that's really the biggest thing that I have to manage is the fatigue.
I see. I was just going to ask Natalie, can you maybe share with us what things are like for you now, and if you've gone through any treatment that you have symptoms from?
Yeah, so I went through treatment in 2015. I did 10 months of Temodar, and during that I had extreme fatigue, some constipation, just I think mostly from the nausea medication, but it was definitely a symptom. And yeah, I would say that was for that stunt. And then I'm currently going through treatment again. I had about, can you guys hear me?
Yes.
Okay. So I did the Temodar for 10 months, and then we were back on the wait and see. And 6 years later, it started growing again, about 30%. Currently in March, I did radiation, and the symptoms from that were actually, I felt pretty good during that. I was pretty tired like in the evenings, but for the most part, I got through the radiation pretty well. I was able to drive myself to work, drive myself to the appointments, and get through that. And then right now I'm going through PCV, but without the vincristine regimen of that. And so far it's been okay. I just started cycle 2 on Tuesday, and mostly with that is also fatigue. It's like this feeling of I don't know, you just have bricks on your shoulders. I don't know how to describe it. It's just you just have this weight, and sometimes you just don't feel like moving. But yeah, so far with that, I've experienced the fatigue, and then a little bit of nausea this time around, but the medication has helped manage the nausea. And thankfully, from the tumor itself, I am pretty asymptomatic, meaning I don't have any symptoms. Never had a seizure or anything like that. So I'm pretty grateful for that.
I gotta say, I agree with how you described the bricks. That fatigue is just the word to describe it. I was hard pressed to do that. It just feels heavy, man. It's just so heavy, and you can't get out from under it. So yeah, the bricks is a really good analogy.
Yeah. And I also say, like, if anyone who has like been pregnant before, the fatigue that you get from a pregnancy, I feel like is like kind of comparable to the fatigue that I feel sometimes.
I don't have a point of reference. I can't help you there, but I just got to take your word for it. Debbie, what do you say? Yeah, Brandon, I know that you're probably kind of, I don't know.
So maybe, Rick, you could share with us what you do to manage your fatigue.
So I was doing a lot of things, like I would drink a lot of coffee, and I went on a medication that was, for truck drivers to keep them awake and everything, but they just were kind of quick fixes. So I make sure that I get at least 8 hours of sleep. I go to bed at the same time every evening. I get up at the same time in the morning. As Debbie said, I take naps. I'm not ashamed of that. I will, take a nap for 15 minutes, a half an hour during the day. And the most important thing besides all that is I dropped a lot of weight, and I still have about 30 pounds to go. And I keep myself hydrated. I feel that is so important. Your body is made up of so much water. If I don't drink enough water during the day, that's a problem. And so coffee can tend to dehydrate you. But I make sure that I'm drinking water everywhere I go. There's water, and I keep, the house cool, much to Debbie's dismay. But, as a business coach, I go into some of my clients' offices, and they get it. They know, they immediately, whether they have the air conditioner on or not, they put the air conditioner on to make me comfortable. And I appreciate that, and I respect that. So those are the things that I do to kind of manage that. Yeah, for sure.
Okay. Thank you so much, Rick. Natalie, what do you do to manage your fatigue?
Yeah, I think water, fluids is definitely a big one. When I was going through radiation, my radiation oncologist actually suggested drinking like more electrolytes. So I have been using like the Mio, like electrolytes, and like squirting that in my water, instead of just drinking just water, which I think has helped. I don't know. And we have a 3-year-old, so like chasing after him, I think like exerting some energy, even when I don't really want to get up, like that has actually helped, because it like forces me to like get up and move around. And then more recently, I just got like a bike seat for my son on the bike, so now I can like actually go for a bike ride and like take my son with me. Instead of like, going, because sometimes it's like kind of hard to like go for a really long walk, because I don't know, sometimes I just kind of get exhausted. But like a bike ride has seemed to like at least like help me exert some energy.
Yeah, and you could probably go further with the same amount of energy than if you were walking.
Yeah. And then, and sometimes if you don't feel like pedaling, you can kind of just like coast a little bit. So we actually got it like 2 days ago, but so far I love it.
Yeah, you can go into an easier gear too, so it's not so, the pedal is less strenuous. Yeah, great. Well, that's great to hear. Debbie, could you tell us a little bit about what it's like living with Rick in terms of supporting him with his needing to manage his own symptoms?
Yeah, I mean, it's different. I mean, everything kind of changed after that. It was very stressful. It's a lot of just trying to help him do what he needs to do to cope. It's not always easy. It was hard to get used to him being different than what he was prior to the brain tumor, the walking issues and stuff like that. So that was difficult. I mean, I support him in everything that he does, and he has done so much. And it was hard, now I'm kind of used to everything, and it's a lot easier, but it was a challenge to get used to all those different things that he could not do, but he's made up for that and all the things that he can do.
I mean, the caregivers are the real MVPs. I mean, let's face it. I mean, I can't speak for all the patients, but my goodness, I mean, I couldn't do anything without her. I mean, she had to do things for me that I never even imagined, and neither did she. And there's just,
well, you take on roles that, you know, things that he was doing, I was doing them plus what I was doing before. So it, you know, it's difficult, but then we worked through that, and
Great.
he's where he is today.
Yeah, but I mean, that's really what it is. The caregivers really are the ones that do the heavy lifting when it comes down to it.
We would not be where we are without them, that's for
Amen.
sure.
For sure.
So Natalie and Brandon, we understand that you did embryo preservation as part of your family planning.
Yeah.
Maybe you might have some advice to share about what that experience was like. And
sure. Yeah, I did it right before I did the Temodar treatment. And I will say we had to actually advocate for ourselves to do it. Our oncologist didn't even mention it, but I knew that maybe one day we wanted to have a family, and I wasn't gonna, you know, I obviously didn't think that I was dying. So I was like, if we, you know, if there's like any small chance that we can do this, like I would really love to take this opportunity. And thankfully, at that time, the tumor, you know, wasn't aggressive. So I did have time to do the embryo preservation right before starting treatment. And there are grants out there to help with some of the costs. So I was able to get, because if anybody has ever gone through IVF, it is so expensive. And our insurance like didn't really cover much of anything. But there are grants out there to help support like cancer patients. And so they actually helped pay for like all of the medication, which was like probably over $5,000. And yeah, so that was, did you have anything to say about that?
No, I mean, it was good to hedge. I think that better safe than sorry. And unfortunately, after chemo, like she couldn't get pregnant naturally. So we're really happy that we did preserve the embryos, and now we have Atticus.
Yeah.
So,
and there's not any, I don't think there's any actual like studies to say that the Temodar would cause infertility. I haven't read anything to say that, but you know, we did it as a precaution, and you know, maybe I didn't get pregnant naturally because, you know, for whatever other reason. But I was really thankful that we did have the embryos. I kind of do wish though that we had just gone straight to using the embryos right after finishing treatment. I think after we finished treatment, we waited at least 6 months. I think they wanted us to wait at least 6 months for the chemo to kind of get out of my system before trying to get pregnant. But we tried on our own for a whole year. Kind of wish we didn't do that, because in hindsight, I kind of feel like we like wasted it a year, but you know, you just never know. But so I guess my advice would be like, if you have the embryos, just use them. In my opinion, it's like the time is now, and like we're here, and like you know, I don't know like what tomorrow is going to be, and but you know, in the end, like we're so blessed, and he just turned 3 in May. So
congratulations. I'm so glad to hear that it all worked out, and that you have Atticus, and that you can take him on bike rides. That's fantastic.
Yes.
That's wonderful. Well, I think we're at the end of our time for the panel, so that we can maybe see what kind of questions are out there for us. There's Ambreen.
Hi, thank you so much, Dr. Leeper. So we will open up for questions from the audience. As a reminder, if you have any questions that you'd like to ask, please type and submit it using the Q&A button on the bottom of your screen, and we'll answer questions as time allows. First, I just want to start by thanking all 4 of you for sharing your insight and stories. It has just been wonderful to listen and learn from your experiences. So one of the first questions that we have, you know, in these last 2 sessions, Dr. Leeper and Dr. Logan both talked about the importance of mental health. And I'd love to hear, what are some coping mechanisms? What are some things and strategies that you all implemented to try to cope with the mental health aspect of the diagnosis? Maybe let's start with Natalie and Brandon, and then we can move on to Rick and Debbie after.
Sure. during the first, when I was going through treatment the first time, I actually picked up yoga. And that was like, that truly like just saved my life. And I got real heavy into yoga. And then I got pregnant and yoga kind of fell off the radar. And then now as I'm going through treatment again, or during the second time of the recurrence, there were like moments in January where I would just come home and I would be like reading a story with my son. And I just felt so like, I just wasn't there. Like I just felt like I really wasn't there. And I went and talked to my oncologist, and he got me in touch with a neuro psychiatrist at Ohio State University. And we had talked, and I got on some anxiety medication, and it has like completely changed the way that I feel. And I just feel like it's really helped me cope this time around.
I personally take time for myself and I work out, and I think that's super important. No matter what's going on, I always try to like give myself a little bit of time each day I make it a priority, and it just puts me in a better spot. And I mean, you still have anxiety and there's moments of depression, but it's cool when like you have a rock. So like when I'm down, she picks me up. When she's down, I pick her up.
Yeah,
it works out.
You're a team. That's great
Yeah.
to see. All right, Rick and Debbie, do you want to share some of your own tips that you've done to help cope with your mental health?
Like Natalie, I did go to see a neuropsychiatrist. I was having cognitive issues after my surgery. I mean, you know, I use the hashtag benign is not fine, because it doesn't have to be cancer to be, you know, one of the worst things to ever happen to you. But it really helped me to cope. I was having panic attacks, and the doctor that I went to see gave me such great strategy to do it. Music has always been super important for me, and so I listened to a lot of music. I did like to write, but I wasn't a writer. I'm not a Dear Diary kind of a guy, but I did keep a journal when I was in the hospital and I was in rehab learning how to walk again, and I turned that into a book. And I feel that you know, I wrote the book under the premise that I was writing it for other people, but really it came down to I wrote it to heal myself first, and that was really important. And I found that was super important for me to do, was to write the book and get it out there, and you know, kind of let it all hang out of what it was like for me, and the support, which, you know, the ABTA is just so invested in supporting people that have brain tumors and brain cancers and people in that community. And so I had created a group on Facebook called Brain Tumor Talk, and it's got 14,000 people from like 50 different countries. It's the largest general brain tumor support group on the planet. But really that just means to me that people have a voice, they have a platform to be heard, and they're not alone. And this is just so scary. I always thought if it could drop me like a sack of dirt, it could do it to anybody. And so, you know, I just wanted to be there for other people, and that helped me to heal as well. Deb, what do you think?
Well, I think the same, you know, as Brandon had said, you need to take time for yourself. I do yoga and I do Reiki, and I have to take that time too, so that I can be there for him, and him, you know, for me also, he needs to take that time. But yeah, it's very important to take time for yourself and kind of reflect, and then you just go on.
I couldn't agree more. Thank you so much for sharing that. Rick, I love your hashtag, benign is not fine. Very true.
Use it as much as you want. I don't know, so it's all yours.
So Rick, you mentioned the importance of sharing your story and connecting with others, supporting others as you're going through this as well. And I believe both of you, Natalie and Rick, serve as mentors for the ABTA. Can you share your experience as a mentor? What has that been like? What impact has that had on you in your brain tumor experience? Rick, let's start with you, and then we can go to Natalie.
It's really, I love being a mentor with the ABTA. The training program was really, really good when I did that. I started, I don't know, 4 or 5 years ago, maybe. And, Vince at the ABTA, Vince Rock is a rock because he really connects people with somebody that is just, on a similar journey. Nobody's journey is the same. So the people that I've mentored over the years have been on a similar journey. So, similar experiences, kind of same circus, different tent. But it's really good to connect with somebody that has kind of been there and done that a little bit. And so the person that I'm mentoring now is, I've been mentoring him for over a year. It's just been wonderful. And, it's good for the both of us. I mean, he's a great guy. So yeah, for sure.
Great. I think Natalie had to just pause for a moment. So we'll move on to the next question. Let's see. So Rick, can you tell me a little bit about what your experience has been like with work? Are you working at the moment? Have you had to stop? What has that looked like as you've been going through your treatments and coping with some of the side effects that you've experienced?
Yeah, so I actually, my job was there for me when I came back. I missed 5 months of work and came back, and they had accommodations that were there for me. So that was really good. I had a good run where I was, but I wanted to do something for myself. So I turned my experience with brain tumors and mentoring other people, and I turned it into a business coaching business that I own. So I own my own business, and I coach people from around the country and, a lot of people locally. And it's been a wonderful opportunity. I'm so grateful that I'm able to do what I do. And so I wouldn't be a success at what I do had I not gone to that place and had the brain tumor journey that I have, because it really taught me something that was super important, which I don't feel that I had before, which was empathy. And, if you're not empathetic, I don't care what you do, you're not going to be successful. So it really showed me the importance of being a servant leader. And that's how I see myself. So I am very grateful and blessed that I'm able to do what I do. Yeah, good question. Thank you.
Thank you for sharing that. I think we have time for one last question. Natalie, this one is directed towards you. If you don't mind, would you share how you're doing now? Are you in active treatment? Has there been any changes in your diagnosis or your prognosis?
No, I'm doing great. I am in active treatment. I'm currently in cycle 2 of PCV, which is a regimen that's used for, I guess, a lot of different types of patients, but I'm doing PCV without the V, which stands for vincristine. And the reason for that is because some studies have shown that vincristine might not cross the blood-brain barrier as efficiently. And so our team, the medical team, decided that we just will not do that part of the regimen. So I'm in cycle 2. One cycle is about 56 days, unless your blood work does not like to cooperate. So my first cycle was 70 days because my neutrophils were like not going up as they were not reaching the point where they needed to be before I could start cycle 2. So yeah, so far, I mean, I feel good. I'm still working. Thankfully I work at a children's hospital, and the team there has been phenomenal. They're allowing me to work from home, like when my counts are low, just so that way I'm not around a lot of people, even though everybody is wearing PPE. But I feel totally safe, like when I go there. So I am very thankful for that. So like the last 3 weeks, I was actually working from home because like my counts got pretty low, but yeah, so far I feel okay. Yeah, no complaints.
I'm happy to hear that. And
Yeah.
I do want to share in the Q&A, it looks like one of our attendees, Natalie, is your mentee, and she is giving you a shout out for being a solid rock in her life.
Oh.
All right, well, I am so sorry, but that is all the time that we have for questions for this session. Thank you all so much for your time, for sharing your insight and support for all of those who are tuning in today. I'm going to turn it back to Emily.
Thank you, guys.
Thank you so much, Dr. Leeper, and to our wonderful panelists for this really inspiring session. I commend each of you on your bravery and your willingness to share some of the challenges that you've had to experience during your brain tumor journey. And also thank you for championing our audience and offering an advice and encouragement. What a way to close out our day. I really, really appreciate each of you. If you'd like to connect with us to help others in a way that these panelists are by sharing their stories, we would love for you to connect with the ABTA. Thank you all so much. All right, so before we end today, we invite each of you to share your feedback with us. Each of you should have received an email that just went out just a minute ago to take a brief survey to evaluate this year's national conference. We ask you to please take a few minutes to share your feedback, which is important as we plan for future programs. For everyone who completes the survey and provides their email address, you'll be entered into a raffle for a chance to win a $100 Amazon gift card. The winner will be emailed the gift card post-event. I would now like to welcome Ralph, ABTA President and CEO, to say a few closing remarks. Thank you all so much.
Thank you, Emily. What an amazing 2 days. I just really appreciate the phenomenal leadership of our conference planning co-chairs. You've heard a lot from Dr. Sean Hervey-Jumper and Dr. Eva Galanis. They did a great job assembling the expert panels. There they are on the screen. Thank you both, Sean and Eva. I really appreciate the time, the energy, the commitment you've made. You're busy, brilliant professionals, but you made time to help put on this conference. To our speakers who dedicated their time throughout the 2 days, you heard from researchers. And when you get information from us, please look through that. You see on the screen the sponsors who help fund the work that we do, including this very special 2-day conference. As you've heard before, it's unique in the brain tumor community for the way we assemble the expertise and really put first and foremost the needs and the concerns of patients and caregivers who are in the brain tumor community. Our titanium sponsor, Northwest Biotherapeutics, you see on the screen, SDP Oncology, and of course, Novacure, which is just a phenomenal supporter of ours. We thank those three and the others that you'll see flash up here on the screen. So on behalf of the ABTA board, on behalf of the ABTA staff, I want to thank everyone for joining us today. There are a lot of people who made this 2-day conference truly special. I talked about Sean and Eva, all the brilliant people lending their expertise. But there were 5 ABTA staff that I just want to say special thanks to: Emily and Breen and Nicole. And then our Marcom dynamic duo of Leah and Colleen. They did a great job promoting this, as did many of you using your social media channels. So to the patients, families, caregivers, friends, relatives, you've been touched by this disease. We hope that these 2 days have been meaningful to you. And if you've been, like most people, you probably have joined in for certain segments. You've not been able to join for both days. So as you've heard throughout, you'll be getting a resource kit that will be emailed to you. As always, please, we're here for you. Sign up for our free e-newsletter, Mind Matters. There it is on the screen. And please, abta.org. We are here to support you wherever you are on your journey. And if we can't provide the direct service, we've got phenomenal relationships with organizations like the Brain Tumor Network and many other organizations all over the country that want to be there for you where you are on your journey. So thank you. We wish you good health, and we appreciate you tuning in for these 2 days. Yeah, let me, in closing, I almost forgot to mention, you'll be getting a save the date, but if you are, if you have pen and paper, we are planning to have this conference in person next year in Chicago, September 9 and 10. And again, pending the pandemic, but we are planning to have it in person. It will be offered to you virtually, as many of you may not be able to travel into Chicago. So save the date. Thanks again. Have a good afternoon.